management we can take. Is that okay? Around fifth or sixth talk?
No, you are not taking question answer in between.
In between only we will do.
No. What I'm saying is question answers you are taking at the end.
I think we can do along with the talks only. We have enough time.
Then it will be delayed because we have 8 minutes talk, and then it will be.
Okay.
Try to fit me a bit early.
Okay, sir. Then what we will do is after visual fields, we will take your talk.
Okay. Thank you.
Yeah, that will be fourth.
Okay.
And if it is getting late by question answers, we will shift it even up. Is that okay?
Yeah, please. That will be very good.
Okay, sir. We will miss you. Then you are the co-chair of the session also.
No, madam, you are boss of the session.
Nothing like that, sir.
No, I didn't know actually I had to do live surgery. This was only decided 1 day back, 2 days back. So at that time I had no idea.
Okay.
Now I'm at home and then I'll go and do the OT. So
okay.
That's
at RP Center, sir?
Yes.
Okay.
So please, thank you for this adjustment.
You're welcome, sir.
Good morning, Dr. Tanuj.
Hanji, good morning.
How are you?
Very nice.
Good morning, sir.
Good morning, Dr. Shwan. How are you?
I'm good, sir. Thank you.
Thank you very much. Dr. Tanuj, after some time, how is going on?
It's with everything very fine with God's grace.
Yeah, of course. The situation of pandemic is everywhere. So
yeah, that is totally. We were thinking it is all over. Now it is starting fresh.
Yeah.
I don't know how to hold meeting and all, and this is totally unpredictable. But Sushma, you are going to Guwahati?
Yeah.
Are you going to Guwahati GSI?
No.
Sushma, what about you?
No, sir. I'm at home only.
Very good.
Yeah.
We had the same Bangladesh Glaucoma conference, the same date, like GSI, 17, 18, 19, like that.
Okay.
So we could not go to any place, and they also could not come to our conference.
Okay.
Good morning, everybody. I'm Professor
Imtiaz and
Pakistan.
Hello. Good morning, Ji. Good morning.
Good morning.
Sushma, I'm just trying to share my screen and just check. Okay.
Yeah, please do, sir.
So it is visible?
Yeah, it's visible, sir.
Okay,
nice and clear.
Shall we load the presentation now or when the time comes?
No, actually, when your name is spoken, then
okay.
Screen sharing at that time.
Okay, thank you very much.
So it looks like these 3 days are very auspicious days for conferences. So everywhere,
yeah.
GSI, SAC, Bangladesh, then Bihar Ophthalmic Society meeting, all are on these 3 days.
I think my screen is also visible.
Yes,
sir. Yes, visible.
Okay. Thank you. I think it's okay. Fine. Thank you very much.
Shall I try mine?
Yes, please do.
Okay.
We shall wait for another 5 minutes and then we'll begin with our session.
Okay, fine.
Okay, you let us know when we go live.
Yes, definitely.
I think
Sushma, you will have to prompt us on the timing because we are all very bad in keeping.
Sure, I'll tell Sabrina to put timer so that we are all aware.
What happens sometimes when you play this screen, the timer is not visible to the speaker. That becomes a problem then sometimes.
I'll prompt you, sir.
Yes, thank you. You are the boss. Hi, Venkatesh.
Good morning, Dr. Venkatesh. Yeah, sure, but you can stop sharing.
Yes, ma'am. I just wanted to check if it's working.
Yeah. We have 2-3 more minutes, Dr. Venkatesh. Would you want to check your share screen? You're okay.
Okay.
Yeah. All good.
Good morning. Good morning, Tanuj.
Good morning.
Good
Dr. Venkatesh, good morning.
And other professors. Pleasure meeting you all in this platform. Sushma, to answer your question, it's better we stick on to this, than keep traveling again. We have learned a lot of lessons.
Yes.
But all the lessons are only, like how we talk to our patients. Very short time we have memories of that, and then we are back to, see, at the end of the day, we are only spending somebody else's money in all these conferences.
Yes, very good. I also totally agree with you, Venkatesh.
Indirectly, that goes to our patients. Whatever we do, we don't think it's indirectly it's going to the patient through prescription.
Yes.
True. And also, it's so convenient to not travel and be able to do so. Saves a lot of time.
Definitely. Once in a while, we should travel. I mean, it should be like this All India State Conference should be there for the mutual interactions. But all these subspecialty symposiums, all that we should try to see whether we can explore this in the future also.
True. So COVID is teaching us a lot of things.
Sure.
Yes, the whole lifestyle has changed, Everything has changed in the life.
Sure.
Anuj,
You have to press the share screen and then
Just create. You first open your PowerPoint and let it be on your desktop, and then you press share screen.
Okay.
And then you will see that presentation. You double click on that.
okay, just.
Venkatesh, you were asking something.
No, Dhanuj, I was listening to Mr. Paul yesterday that we may touch 13-14 lakh cases a day.
Yeah, I know. Yeah.
What is the discussion in Delhi? I mean, are they really worried about that? Or
Now they are worried because the way it is behaving in other countries, the only thing with God's grace, if it is mild, then we'll be spared. Otherwise, volume-wise, health system is going to be overwhelmed. If it is mild, then only it will go through. Otherwise, it is going to hit definitely what they're saying, because all other places it is spreading. In India also, every day the numbers are increasing. Matter of time. They are saying February we'll get the peak.
The 13-14 lakhs seems to be, kind
Too
of
much, yeah.
bothering.
Yeah.
A minute to go.
We have 1 minute left. Then.
Yeah, Sabrina, let us know.
Yes, ma'am.
So, Dr. Sushma, you can start at exact time.
Yes, sir.
I'll just give the introduction and then, ma'am, you can take over.
Sure.
We are going to introduce all the speakers.
No.
Okay, very good.
Good morning.
Good morning,
morning.
Good morning, Ji.
Morning.
Can you see my presentation?
Yes, very nicely. Gonioscopy.
Okay. Good.
Good morning, Dr. Madhu. You're on mute, ma'am.
I said, good morning, Sushma. Good morning, Tanuj.
Good morning, madam. Good morning, Ji.
It's such a chilly morning, yaar.
Anji. I have just taken off my cap for the presentation. You please stop shares now the screen, Doctor. Whose screen is this, Dr. Imtiaz Ali? Your screen is this?
Yeah.
Is that gonioscopy?
You please stop
share.
Stop share.
Is that okay now?
Yes, fine. Thank you.
Good morning to one and all.
Good
I
morning.
welcome you all to South Asian Academy of Ophthalmology Conference. To begin with our session, I would like the chairpersons Dr. Madhu Badaria, Dr. Nadeem Bhatt, and Dr. Nazrul Islam, co-chairperson Dr. Tanuj Datta, moderators Dr. Sushma Tejwani and Dr. Shorba Dinakaran, to please switch on the camera. Over to you, Doctor. Doctor, you can take over.
Well, thanks, Sabrina. A very warm welcome to all of you. And I'm really grateful to all of you for accepting the invitation and agreeing to share your knowledge with us. Well, I'm going to hand over the stage to Dr. Shorba. Shorba is a colleague and friend. Shorba, you can share screen, please. And she's been working at Narayan Netralaya as a consultant. She's done her graduation, post-graduation at Mangalore and has been with us for a long time now. So Dr. Shorba, over to you to start the session, please. Shorba, unmute.
Ma'am, please unmute yourself.
Thank you, ma'am. Good morning to everyone, and a warm welcome to the South Asian Academy of Ophthalmology Conference 2021. Let me begin by extending a warm welcome to our esteemed chairpersons, Dr. Madhu Bhadoria, Dr. Nadeem Bhatt, and Dr. Nazrul Islam, and our co-chair, Dr. Tanuj Dada, and a very warm welcome to all our speakers and our audience. Thank you for being with us today, and we look forward to an interesting session. It is an honor for me to introduce Dr. Madhu Bhadoria. I just share the screen. Is it visible?
No, currently it's not
Shorba.
visible.
Okay. Is it visible now?
Ma'am, please click on share screen
Yes,
button. Ma'am.
Yeah.
Yeah, now it's there.
Slideshow mode.
Yes. So Dr. Madhu Bhadoria is the Chief Medical Officer of the Sitapur Group of Hospitals and Director of the Regional Institute of Ophthalmology, Eye Hospital, Sitapur, UP. She is a graduate and postgraduate of KGMC, Lucknow, and she has worked in the armed forces for 25 years in capacity of a clinician and researcher. She has presented research papers, videos, and posters at AO, Asia Arbo, and AIOS, and she has conducted several instruction courses at annual conferences at AIOS and SAC Ophthalmology Society conferences. She has been actively involved in community service and was awarded the Dr. Sushila Memorial Award in 2010, and she has received the All India Achievers Foundation Award for Excellence in Healthcare, and Vision 2020 has awarded her for equitable eye care, especially for women and children. A very warm welcome to you, ma'am. So let us begin with.
I just said thank you, Vithi.
Yes, sir. Very warm welcome to you. And let us begin with the talks, and we will continue with the introductions as the session progresses. Our first speaker for today is Dr. Venkatesh, and he will be speaking on strengthening opportunistic screening for glaucoma. Dr. R. Venkatesh is the Chief Medical Officer at Arvind Eye Hospital, Pondicherry. He completed his ophthalmic residency in Arvind Eye Hospital, Madurai. He is actively involved in clinical activities, research work, and teaching, and plays an active role in consultancy and capacity building of eye hospitals in the developing world through the consulting division of Arvind Eye Care System. He has many peer-reviewed publications in cataract and glaucoma and has won several awards in national and international forums, including the ASCRS Film Festival Award, the AO Best Show Award, and the IIRSI Gold Medal. He has also been invited to speak about the Arvind model in many international meetings, including the African Glaucoma Summit, the Pacific Health Summit, Moorfields International Glaucoma Symposium, and the Wilmer Eye Institute Grand Rounds. His areas of clinical interest include cataract microsurgery and glaucoma. Welcome, sir.
Thank you.
You can stop share, Shorba.
Okay. Thank you, Sushma. Thank you, Madam Madhu, Madam, and all the senior colleagues here who have joined for this excellent session. So I'll be briefing quickly about how we do opportunistic screening. So this problem we all know, and there is going to be a staggering number by 2040. Nearly 120 million may have glaucoma. Kind of the burden is multifold because it's asymptomatic, poor awareness. And if you see in countries like India, Bangladesh, Pakistan, 90% of glaucoma remains undiagnosed. So early detection is key. People again challenge, why do you want to detect early in developing world if you cannot manage? But the story is different. If you diagnose early and intervene, it reduces the risk of glaucoma blindness. You improve the quality of life. You create awareness, and maybe medications would work in some of the early glaucomas, or even lasers to treat them. And this will reduce the need for surgical intervention for some years. So some of the risk factors we understand from a lot of these prevalent studies which we have done in South India is older age, lower education, lower economic status, lack of awareness, residing in a rural area, and also difficult to access a healthcare facility. So when you talk about screening for glaucoma, would you do a mass screening or a high risk or opportunistic? I think mass screening is difficult, but high risk screening and opportunistic screening is the way to go. Why mass screening may not be very effective? Because of the low prevalence. Screening needs to be a continuous process. And again, further evaluation and infrastructure you need for some of the suspects which you diagnose. And no single test is diagnostic, and it is also not cost effective. So I'm going to focus today only on the opportunistic screening, but not about the other areas which we normally do. So opportunistic screening is basically doing a comprehensive eye examination for all. You target the high-risk population, like in glaucoma, a family screening. And you piggyback glaucoma screening with any other programs you have. It may be a diabetic retinopathy screening program. Whatever you do, can you piggyback a glaucoma program? So this is something which you all do. In any of your base hospitals, you try to do a comprehensive evaluation. Whoever has been referred from your general clinics or in your triaging centers to the glaucoma facility, I'm sure a comprehensive examination is very important, including a good tonometry, a gonioscopy, and in patients, wherever you suspect optic nerve changes, visual fields, OCT, and all that is very important. So in base hospital, wherever we have clinics in the form of primary, secondary, or tertiary care centers, we need to do a comprehensive evaluation. I'll just focus on this high risk, which we really do a lot of work on family screening, because we have found significant angle closures happening among siblings in a study which we have done some time back. So family screening has become a mandatory now. So every proband who is diagnosed to have a primary open angle or an angle closure glaucoma, the counselors sit with them, and then they enter most of the information. They enter into, they give them kind of a sibling screening card. So this card, the proband carries and gives it to his siblings so that they bring it for an examination. And now we have changed this, after we have the electronic medical record, into something which sends an automatic SMS to their sibling or children if they are above a certain age. And every information is entered. And at the end of the month, we analyze how many siblings or family cards we have issued, how many of them have come back for screening. And we critically review by sending them reminders. Now we send them videos on WhatsApp just to create awareness about glaucoma and why family screening is important. The other area which I really focus on is the vision centers. We have 94 vision centers across Aravind Eye Care system. Pondi has got 14 vision centers. And in all our vision centers, we make sure a very comprehensive examination is happening, like the video which you are seeing here. So there are two staff. One is a technician, another is an optometrist. The technician registers and does certain tests like blood pressure, blood sugar, and then the optometrist does detailed evaluation. They do an applanation, they do refraction, they dilate, and at the same time, they do a 90-day evaluation normally. And wherever they suspect a disc suspect or a diabetic retinopathy or some other, they put the findings into the EMR. But now we have introduced this fundus on phone, and we have given this to all the centers so that they image the fundus and they upload this into the electronic medical record. What you see is a slightly older video done a couple of years back, but now we can seamlessly transfer the image through a Wi-Fi network so that it even doesn't take the time of putting a cable inside. And then every patient gets a teleconsult. The doctor sees the image, and if there is any suspect of glaucoma or any other posterior segment diseases, they are referred to the base hospital. The rest are treated there. This is a study we did just before pandemic. We studied whether doing a routine fundus photograph in vision center would help. So we found that by doing routine fundus photograph than believing just how they see fundus, there's a significant increase in diagnosis of posterior segment diseases, and more so for non-urgent referrals, like it picks up early glaucomas, early diabetic retinopathies. There's a significant increase when you do a routine fundus photography. The other thing which I want to highlight is this work has just got accepted in WHO bulletin, where it beautifully shows how vision centers immediately after the unlock happened, the volume increased to 80% to 120% after the post-unlock. Whereas the secondary or even the tertiary care centers took a significant time. Only when the unlock happened, the volume increased. So this shows that access is very, very important. And these vision centers are doing a good job whenever there is a catastrophe like this, like a pandemic or even cyclones and floods. And this is one thing which we tried. I'm sure there will be an audio with this. So what you just saw is we do shared medical appointments in the base hospital. We did a big trial comparing shared on one-on-one. And this is basically shared medical appointments in vision centers. In the pandemic, we were able to get some of these patients back to the vision centers and consult with them after an intraocular pressure and everything is checked. And finally, I would like to touch upon, there's a minute video on how we do community outreach now. We have come a long way in iCamps. Now we have excellent technology. So we are doing electronic medical record-based iCamps now. So you see the vision check is done with a nice LED chart, not the old charts now. So you can see a preliminary examination again with torchlight. They also have a handheld slit lamp. Wherever they need, they may use it. And then the optometrists do refraction. Every information is entered into the electronic medical record. And after this, you have an eye care tonometry, and you know how reliable it is to measure the intraocular pressure. And we have trained technicians to take fundus images. So you can see this is a Bosch camera, which is by the Optomed. And then this Bosch camera images again YY transferred into EMR. So the doctor has got a final look. So it's very difficult to do sometimes a direct ophthalmoscopy or things like that in an iCam. So this, using all these low-cost technology, has significantly improved the way we screen. And this is again a work which we just did before pandemic. It was published last year in ophthalmology, where we found again between the historical way and the new cams, the novel way of doing, we compared significant greater PSD detection in the novel cams. So by doing something novel like this, by doing something using low-cost technology, we can definitely improve even our opportunistic screening in iCams, which we do for cataracts. With this, I would complete my talk on how we do opportunistic screening at Aravind. Thank you.
Absolutely wonderful, Dr. Venkatesh. Hats off to the great work that you're doing, and using the technology to bring the eye care to the common man is a tremendous job. I would request Dr. Madhu if she would like to comment.
We are actually partners in this whole thing. South Korean camera company also, that not the Lab SD. With them, we are doing this project, a similar kind for vision centers as well as for the outreach now, starting for outreach. And I think this is the best way, because we can't possibly go for mass screening.
Yeah.
And I totally endorse what Venkatesh is saying, because unless and until we diagnose early, there isn't a way that we would ever be able to reach forget the bottom of the iceberg, even under the water layer of the iceberg.
True that.
I would also like to comment on this. It's an excellent presentation, and they have shown the screening method to be wonderful for the developing countries like India, Pakistan, Bangladesh, and Sri Lanka. And the technology being used at the level of iCamps is very impressive. Most of the iCamps, they just screen out cataracts and then do the surgery for them, whether they do phaco or some other procedures. But screening for glaucoma at the level of iCamps with the help of equipment is really commendable. Wonderful talk and wonderful work being done at the level of community. Thank you.
Thank you,
Can
sir.
I?
Yeah, yes, sir.
Dr. Venkatesh, a wonderful presentation and eye-opener for me at least. I was always a proponent of that screening for glaucoma is not possible, but I think I'm going to change my mind today.
You made my day, sir, because even within the system, it was so difficult for me to make them believe. But after doing this couple of work on routine fundus photography in Vision Center and doing this novel outreach, I even changed some of the minds within even the system. Now we are practicing glaucoma for several years. And now they have started doing eye care tonometry and of course fundus photography. We know that we are missing significant glaucoma who are 6'6" coming into the camps and going with the presbyopic glasses. And it was touching many of us and we were not doing anything. So now at least we know that we are detecting some of the early or even moderate glaucomas.
Thank you.
Thank you, sir. I think
I also agree with all the speakers that Dr. Venkatesh is really a dynamic person. I know him many years and he's doing very good works. And for the screening, he has different techniques. And also for the awareness, I have seen one video for the awareness since a special day we're working. So it's really encouraging for all of us. I want to mention one thing, that awareness is very important for all of us. I think that if we can increase the awareness and screening, the glaucoma we can actually make the good treatment and diagnosis. Thank you for the good presentation.
Thank you, sir. I think, Dr. Shorba, we can go to the next in interest of time.
Yes, ma'am. So moving on to our second speaker for today, Dr. Syed Imtiaz Ali. Dr. Ali is a professor of ophthalmology from a reputed teaching hospital in Pakistan. He's primarily a glaucoma specialist and an anterior segment surgeon. He's the founder president of the Pakistan Glaucoma Association and regional secretary of Pakistan for APAO. He delivered the prestigious Sushruta lecture in Bali in 2009. He's the ex-member of the editorial board for the Asian Journal of Ophthalmology and the ex-chief editor for the Journal of Rawalpindi Medical College. He's the president for the Pakistan Glaucoma Association, the ex-general secretary of OSP Federal Branch Islamabad, and member of the advisory committee of the Pakistan Journal of Ophthalmology. A warm welcome to you, sir.
Thank you very much. I'm just going to share the screen. Can you see my screen?
Yes, sir.
Yes, sir.
Is that clear now?
It's visible, sir.
Yes, you can start.
It is visible. Can you see this screen?
Yes, it is visible. You
can screen, please start.
Thank you.
Okay. I always say that the gonioscopy is a forgotten art, and I'm going to revisit it. And what are the fundamentals of gonioscopy? We often forget to do a gonioscopy. In this presentation, I will describe the purpose of gonioscopy, the principles of gonioscopy, methods, the angle structures and grading, and some key points at the end of that. One should ask himself or herself, why should we do a gonioscopy? We tend to forget it. It needs to be done because it's a fundamental part of any comprehensive examination or glaucoma examination. It's the most important factor in correct diagnosis, and the omission will lead to misdiagnosis. It should be done initially for all glaucoma patients and all suspects, and it is repeated periodically in primary angle closure glaucoma. It's not enough that you do a gonioscopy once in a year or once in 2 years and forget it, and particularly in secondary glaucomas as they occur. The purpose again is the clinical uses of gonioscopy to differentiate between a primary open angle glaucoma and primary angle closure glaucoma, which we tend to miss, and to diagnose congenital glaucomas, Secondary glaucomas, particularly angle recession glaucomas, uveitic glaucomas, neovascularization, which is subtle sometimes that you don't see on the iris, but you will see in the angle, and iridocorneal syndrome or iridocorneal endothelial syndromes. You can see subtle tumors of the anterior segment. You can see a cyclodialysis. You can see a ciliary body cyst, intraocular foreign bodies, which are hidden, which are not seen otherwise. And you can see a KF ring if you cannot see clinically on a slit lamp examination. And some unusual mysteries of glaucomas you can solve with gonioscopy. And it can be used to perform an argon laser trabeculoplasty, a laser iridoplasty, laser cyclophotocoagulation, peripheral iridectomy and its follow-up, iridoplasty, trabeculectomy, and indentation gonioscopy can be used to break some soft synechia in attack of acute angle closure glaucoma. How it is done? People are scared of doing gonioscopy. I was before I learned it properly. There are two methods: direct gonioscopy, indirect gonioscopy. Indirect can be without indentation and with indentation. In this picture, you can see without indentation and with indentation, the angle opens up. You can use any lens that you are familiar with. You can use a simple 3-mirror lens, which is available in any clinic. You can use a rich trabeculoplasty lens, or you can use all other lenses that are available. MagnaView lens is very handy. There are two types of gonioscopy: direct gonioscopy that we do on the slit lamp, and indirect gonioscopy that we do in the operation theater for doing a goniotomy. Advantages of direct are straight on view, angle of visualization is variable, more panoramic, angle recession comparison can be seen. Disadvantages: it is very inconvenient. The patient has to be put in an awkward position, special equipment and special lenses are used. Indirect gonioscopy you can do with a Goldman 3-mirror lens, which is already available in any eye clinic. You align the outer canthus with the mark on the slit lamp, black mark on the slit lamp, and you apply a coupling fluid in a Goldman mirror, and in a Vogue 4 mirror, you don't need to apply a coupling fluid. This is the mirror that I use. It's a 4-sided mirror, and it will give you a panoramic view. It doesn't need a coupling fluid. It rests on the cornea, not on the sclera, and you can do indentation. You have a decent magnification on the slit lamp, usually 10 or maybe 16, and then you can apply it. You pull the lower lid down, and you can apply it just under local anesthetic and get a good view of the angle of the eye. General guideline: first do the external examination. Tonometry must be done before gonio, otherwise you will get a wrong reading. Use local anesthetic, pay attention to patient's comfort, and magnification of 10 is usually sufficient. And use 2/3 beam and a semi-dark room. This is the most commonly used 3-mirror Goldman lens, which is available in any clinic. Put a coupling fluid there, and then you can apply it. Pull the lower lid down, and you can apply it there. And this is the thing that you start to see when you rotate the mirror in different directions. You can see you can keep rotating the lens, and when you want to remove the lens, just give counter pressure on the eye. This video is not moving properly, so you can just remove the lens. The advantages of indirect gonioscopy: preferred by most, quick, convenient, no special equipment needed, only slit lamp, can create corneal wedge, allows differentiation of apposition and angle closure. Disadvantage: mirror image can be confusing, inadvertent pressure on the cornea exaggerate the degree of angle narrowing in Goldman lens and opens the angle in 4 mirror lenses. Now, recognizing the angle structures: when the iris covers the trabecular meshwork, it is very easy to mistake it for non-pigmented trabecular meshwork. For the scleral spur, a pigmented Chauvet's line for the trabecular meshwork. Indentation gonioscopy is practically useful in these cases to see the synecdoche. This is a illustration of, you can see, look at the arrow in the diagram and look at the arrow. This is the ciliary body phase. This is the scleral spur. And then this is the pigmented trabecular mesh spur, which is the first landmark that you look for. And this is the non-pigmented. And then the Chauvet's line. Or you can start from the Chauvet's line and come down. This is your own choice. And then the cornea. These are you have to do many gonio, and that's the corneal wedge. You have to do many gonioscopies before you become proficient in the use of gonioscopy. This is the normal angle that you see in a mirror. You can see the landmark, the non-pigmented trabecular meshwork. Then on top of that, you can see the Chauvet's line, that whitish band there. So once you've seen many angles, then you will get a hang of it. Now you can see there's a lot of pigmentation in this angle. This is normally due to age, but the pigmentation due to age, these are the different landmarks that I've shown. Ciliary body phase, scleral spur, trabecular meshwork, pigmented. This is the Sempolici line that you see in some glaucoma, and this is the cornea, and you can see and normal, if you see hyperpigmentation in normal individual at 6 o'clock, that is because of age or in certain conditions, but mostly it is due to age. You can keep rotating the lens and keep looking at the angle, and you'll get a hang of it one day. This is a magnified picture of the angle. You can see the pigmented meshwork and the non-pigmented, and these are the grades of the gonioscopic that we do: grade 4, grade 3, grade 1, and there are different classifications that you can use. You can use any one that you like, but the most common use is the Schaeffer classification, or you can use the Spaeth classification. These are the different angles that you can see. This is an open angle. This is an open angle. You can see all the landmark. There's no pigmentation, no Chauvet's line that you see here. And these are the peripheral anterior synechiae that you have to differentiate from the iris processes. These are the new vessels that you see in the angle. There's a foreign body stuck here, and you can see microhyphema in the trauma angle after trauma, and you can see a big uveal iris melanoma there. And this is a very interesting picture. Nowadays, we don't have to touch the cornea. This is a dynamic, this is a non-touch gonioscopy technique by Nidek. This is just like an autoref. This is Professor Nadeem Hafiz's, but in a conference we did it, and that was his eye. And you can see the whole eye moving there. Look at this. This is, you don't have to touch the patient, and this is the most advanced gonioscopy, but it has got its own limitations. And this is my own eye. You can see the angle very clearly, and the machine is rotating the eye very well. So, key points: fundamental part of any examination, confirmation of normal angle structure, determination of narrowness of closure of AC angle, grading of the angle can be done, pathological findings and need to be performed. And the conclusion is the study, one study highlighted the ophthalmology trainees' dissatisfaction in the current gonioscopy training curriculum and a lack of confidence in performing the procedure. Appropriate modifications to the ophthalmology specialty training programs could enhance trainees and gonioscopy learning experience. Thank you very much.
Thank you, sir. In the interest of time, is it okay if we move on to the next talk by Dr. Tanuj Dada, since sir has to leave for a live surgery?
So can you stop share, Dr. Imtiaz?
Okay, that's it, done.
Thank you, sir, for the wonderful talk. In interest of time, we will move ahead.
So thank you, Dr. Sushma, for organizing this, and I apologize for this intrusion and changing the timing. And I'll be just briefly covering a few oops in glaucoma surgery. I have no financial disclosures. So one of the most important problems we faced after trabeculectomy is post-operative hypotony. And you have a situation where patient has a hypotony maculopathy post-surgery. However, this is an early post-operative period. There is no sedal test. There is no leakage from the conjunctiva. So it is just a over-filtration from under the scleral flap. And you can see the pressure is 3 and the visual acuity is 6/60. There is no leakage. But here you can see there is excess aqueous drainage occurring under the scleral flap. So I'm showing this technique of transconjunctival suturing. This is for post-operative hypotony in the early post-operative period where you don't have a wound leak. So you just use 10O monofilament nylon sutures. You go from the conjunctiva to the scleral bed and close the ostium. And you can see multiple sutures have been put. And over time, they get embedded under the epithelium. And you can see now the bleb is still raised, but that excess filtration cleft has been closed and the hypotony has recovered and the patient regained a good visual acuity. Now this is a second situation. Here the patient has come to us very delayed after 2 months, and 3 times the patient has had anterior chamber reformation, but still there is a hypotony. There is no leak, very healthy conjunctiva. And you can see on the UBM, there is a large aqueous cavity here under the bleb. So it shows that there is a hyperfiltration occurring with a shallow anterior chamber. So in these cases, we have to do a surgical exploration because there is no obvious leakage. So we try to open up the conjunctiva. And now you can see after putting trypan blue, there is no area of leakage found. So we dissect the episcleral tissue and then redo the test with the trypan blue. And now you can see there is excess drainage of trypan blue here. Now this is very important. You can see there is an inadequate closure because excess cautery has been done, and because of that the scleral flap has shrinked and this large defect is here. This was under the episcleral tissue and this was causing the hypotony in the 2 months after surgery. So now we have to close this cleft. So especially in the COVID era, you don't have so easily the eye bank sera available. So I'm showing a transverse repair. So you raise a transverse lamellar scleral flap and then you just roll it over and close the area of the large defect. So this is what is a sort of a modified Momney's repair. So this is a lateral transverse rotation of the scleral flap. And with that, you can close the area. And important thing is you shouldn't suture the posterior part because you can still have some aqueous drainage. So you have some area which drains aqueous and the post-operative pressure does not rise very high, which is a problem in some of these surgeries. So this is how the scleral defect was closed. And you can see in the post-operative period, now the patient has recovered and there is no excessive leakage. Now this was a patient recently referred to me. So patient has had a phaco trap and then has had a shallow AC and multiple suturing of the conjunctiva has been done. So he has presented now with a shallow AC and a very high intraocular pressure. So patient has gone into malignant glaucoma. This is a pseudophakic patient. So I'm just showing a simple, you can see multiple suturings have been done. So you can see there is a complete obliteration of the periphery of the anterior chamber angle with 360-degree apposition. Just slight amount of central anterior chamber is left. So in this patient, we plan to do what is known as a limited anterior vitrectomy. So we will go through the cornea, through the peripheral iridectomy, through the zonules into the vitreous. So it is like a iridocorneal zonule hyalidotomy. So now you can see this MVR knife is going through the cornea, through the iridectomy, through the zonules and into the vitreous cavity. Now you can see some amount of vitreous coming. Already a side port has been made for the anterior chamber maintenance. And now this anterior vitrectomy is done. So the basic purpose is that you have to make a single communication between the anterior chamber and the posterior chamber so that the eye becomes one cavity. And you can see just when I start the surgery, there is a deepening of the anterior chamber and the pressure goes down and the malignant glaucoma block is resolved. So this is a very simple technique, especially pseudophakic cases. You use a single port and cut through the iris, the zonules, and go to the vitreous cavity. And after that, of course, the viscoelastic is being removed. And now you can see very nicely a very deep chamber, and we are suturing the port. And you can see post-operative ASOCT, the angle has now very nicely opened, and patient had intraocular pressure of 14 millimeters of mercury and regained good visual acuity with this simple technique. You can see post-operative now, very deep chamber, and the malignant glaucoma has resolved. Now, this is another challenging case. So patient has had a PCG surgery and come back because the corneal edema is not resolved. So there was a large deciment detachment. This is an OCT guided surgery. And so the C3F8 has been injected. And gradually you will see that this on the OCT, it is getting opposed to the cornea. So on the table, we could just make a apposition of cornea and we were very happy with this. However, you can see post-op date 2, again, there was a persistent decimal detachment, and this is a problem because these patients are having primary connected glaucoma and there may be abnormality in the decimate membrane pre-existing. So our surgery failed. So now what modification we did was that there is aqueous between the decimate membrane and the cornea. So we are making 4 full thickness entry mid peripheral stab incisions in the cornea so that the aqueous comes out. And after these 4 stab incisions have been made in the mid periphery of the cornea, after that we will inject the C3F8. So what the advantage is that now when we inject under the C3F8 14%, because of these 4 peripheral mid peripheral openings that we have made, the aqueous is able to drain out. And now here you can see on the OCT that the decimate membrane is reattaching. So this is what we learned, because in primary congenital glaucoma, this is not a very easy surgery and the decimate membrane may have a pre-existing abnormality. So mid-peripheral stab incisions with C3F8 and we could achieve a complete readhesion of the decimate membrane and then the corneal edema resolved. So I think I have just managed to finish in time, and thank you very much for your kind attention. And Dr. Sushma, thank you for arranging everything.
Thanks, Dr. Tanuj. It was a treat to see the wonderful videos after Dr. Imtiaz Ali's gonioscopy videos. That was also awesome. And then now we had interesting surgical management videos. I think, Shorba, we missed Dr. Tanuj's introduction. We can just flash the slide once.
Yes, ma'am.
Yeah, Dr.
Is it sharing?
Yeah, it is Dr. Nadeem Butts.
Yes.
You can share Dr. Tanuj's once.
Sorry.
Yeah, the sequence would have changed, no problem. Yes. Although everybody knows him, but we would like to. Yeah, so thanks, Dr. Tanuj, for being there, and
thank you very much.
Try to be there till the time you can be. I'm sure your other audience are waiting there for your live surgeries. And I just wanted to ask a question, if you don't mind.
Yes, sure.
That when you make those full thickness corneal cuts, does that leave scars or astigmatism later on?
No, actually, these are done with a very sharp MVR, and this is a last resort because we had failed to reapposite the decimate membrane. So ideally, in first go you may not do, but because in this case we were going in second time, so just to make sure we made these 4 ports. This is normally a procedure that is done in keratoconus patients when they come with a corneal edema.
Right.
But we didn't have any post-operative scarring or that. patient recovered well.
Right. Thank you, sir. Thanks so much. I think in interest of time, we will move to the next talk. Shorba. We have Dr. Nadeem Bhatt with us, so you can introduce him. Slideshow, please.
So Sushma, just one word, welcome everyone, and it is a pleasure to have Dr. Nadeem Bhatt, who has been the past president of the SARC Academy of Ophthalmology and is the leading light and the torchbearer of SARC Academy of Ophthalmology, which has been going on. Thank you, sir, for being here. Thank you so much for your presence.
Thank you very much, Dr. Namrata, for your very generous compliments and introduction. We are just, all of us are just doing our job and our work so that, you know, we can take the SARC Academy of Ophthalmology to the greater heights. So we are all working together, and I'm very happy to work with all of you. And on behalf of Pakistan, greetings from Pakistan in this morning. And thank you very much for arranging such a wonderful 3 days virtual symposium. And I think it's no less than any supranational, international forum and conference. And we can compare it with the Asia Pacific, with the ICO and with the World Congress. So thank you, Namrata, and all the team, Lalit Verma, Rajvardhan Azad, our friend, and Madam Awa, and all, the big caps from all SARC countries, that they supported this symposium and this virtual Congress. And we are very happy to be with you.
Thank you, sir. Thank you so much.
So we'll go on to the next talk by Dr. Nadeem Bhatt, who's speaking on visual fields in glaucoma, a step-by-step interpretation. Sir is a professor of ophthalmology at the Allama Iqbal Medical College and Jinnah Hospital, Lahore. He's the secretary, Faculty of Ophthalmology at CPSP. He's graduated from King Edward Medical College, Lahore, and he did his fellowship from the Royal College of Physicians and Surgeons of Pakistan, and his FRCS from the Royal College of Surgeons in Edinburgh. He is the chairman of the Standing Committee of Fellowship, APAO, and the Executive Vice President for the Ophthalmological Society of Pakistan. He is the past president of the SARC Academy of Ophthalmology and member of the Pakistan Society for the Prevention of Blindness. Over to you, sir.
Can you all see my screen, please?
Not yet, sir.
Yet.
Can you see it now?
No, sir, we can see you, not your screen.
Not yet.
Yeah.
You have to minimize your screen of Zoom, then open the presentation, then again comes the Zoom.
Once you share screen, the desktop, you will see, and then also you can open whatever way you like.
Is it on now?
Yes, sir.
Yeah.
Yes, sir.
Can make it
That's fine.
slideshow, sir. Yeah. Thank you.
Thank you very much, ladies and gentlemen, for arranging such a wonderful symposium for all of us, for the whole SARC region. And today I'm going to present a few important aspects of visual field evaluation in the glaucoma diagnosis. As you all know that anterior segment examination, posterior segment examination, and then gonioscopic examination, they are all important for diagnosing making the primary diagnosis of glaucoma, and also differentiating it from the primary and the secondary and congenital and adolescent glaucomas. And the visual field examination is currently is always done to find out the stage of the disease. Similarly, we do the OCT to find out the stage and damage of the disease, which has been done so far. So once we have the visual fields and the OCT, we know the status of glaucoma of the patient, and in addition to intraocular pressure. So we just don't rely on intraocular pressure. We also go for the visual fields and the OCT for the extent of damage that has been done. So glaucoma, as you know, is a group of disorders characterized by typical glaucomatous optic neuropathy, clinically manifested by characteristic visual field changes with normal or raised IOP. As you all know that there are very few patients who are very intelligent who can pick up their visual field problem themselves. It's mostly the ophthalmologist and the technologist who diagnoses the damage to the visual field with the help of perimetry or with the help of static threshold perimeters. So some of the patients, they come up with the finding that they were driving and they couldn't see on this side while driving, and somebody, the motorbike or the cycle, came from that side and he couldn't see that and he hit that the other one. So today my focus will be the visual field changes that are characteristic for the glaucoma. We know that psychophysical testing for glaucoma patients is in glaucoma, the perimetry to assess the peripheral vision of an eye and in the peripheral vision, we say that it is the anything beyond the central fixation, which is 5 to 10 degrees. So the perimetry is an attempt to assess the visual threshold at a particular location in the visual field, and the visual threshold is the minimum level of light that can be perceived at a given location in the visual field, which is also called as retinal sensitivity. The visual threshold is highest at the level of fovea, and it's less at superiorly because of the brow. The nasal bridge obstructs it and it makes it 60 degrees. Inferiorly, we have a malar bone that restricts it to 75 degrees, and temporally it is quite wide open and it's 100 degrees, and this is called as hill of vision, which can be seen in this photograph. The maximum is at the fovea, and as we move towards the periphery, it reduces. There are two types of perimetries. We have kinetic manual perimetry and the static perimetry. In the kinetic, a visual stimulus of known size and intensity is brought from the periphery where it is not expected to be perceived, and at some point it will move into an area where it will be perceived, which is called as visual threshold in that area. The static automated threshold perimetry presents visual stimulus in varying sizes and intensities at fixed locations, and higher intensity stimuli are presented, and then gradually the intensity is lowered until the patient can no longer perceive the stimulus, which is the visual threshold in that particular area. This is the difference between the kinetic and the static. In the kinetic, you can only judge the length and breadth of the scotomas, whereas in the static, you can also judge the depth of the scotoma, as shown in the picture. The important thing to remember is that the earliest visual field detectable by achromatic automated static visual field corresponds to approximately 40% of the ganglion cell loss. This is a very big figure, as most of the ground is already lost when we diagnose the patient so late. So as we have seen in the first presentation, that screening of the glaucoma patient is very important, and we have to diagnose it much earlier. That's the reason we have started using the OCT, which diagnoses the structural damage before the functional damage starts showing itself in the form of visual field defects. And you can see that this is the Humphrey Field Analyzer report, and this is the type of report that we usually get, and it has got different sections. The topmost section is the patient's data, and then we have got the reliability indices, then we have numeric scale, then we have a gray scale, and then we have a mean deviation, pattern standard deviation, and then we have global indices, and then we have p-value graphs. And we have to, interpret the report step by step, starting from the top of the report, going to the bottom gradually, and not just jump on seeing the gray scale and saying that this much damage has been done to the patient. Sometimes the findings of the reliability indices are suggestive that the report is not reliable. So you can't rely on that report, and you have to repeat it again. So don't please just jump on the gray scale and get horrified with the blackness of the grayscale and start seeing. The typical patterns show in the glaucoma visual field defects, and this is a nasal step that has been shown, and there is a the connection. The arcuate scotoma is also developing along with the nasal step in the superior region as well as in the inferior region. The visual field defects usually correspond with the anatomical structures of the retinal nerve fiber layer. And the horizontal raphe is a line that intersects the fovea and the optic nerve, and the temporal wedge defect is because of the axons of ganglion cells of nasal retina traveling straight into the optic disc, and the nasal step defects and arcuate scotomas are because of the axons of the ganglion cells located temporally arc into the optic nerve. And this is the list of the visual field defects that we usually see in glaucoma. The presentation can be variable from patient to patient. Some patients show generalized reduction in sensitivity. Others can show temporal wedge, nasal step, paracentral scotoma, arcuate scotoma, double arcuate scotoma, bearing of the blind spot, total loss of field except central 5 to 10 degrees, and total loss of field and vision. And this is a relationship of the lesion and the field effect as shown in the picture. You can see the arcs of the retinal nerve fiber layer traveling above and below the fovea, and whereas the fibers from the nasal side, they just cross straight and enter into the optic nerve head. So the defect shown here on the fibers is reflected in the form of visual field defects in the perimetry. Now I'm going to show you some of the photographs of the defects on the fundus photographs and Heidelberg retinal tomography along with the visual fields. And the important point to remember in this is that you always correlate the clinical findings with the visual field defects and also with the OCT or the Heidelberg retinal tomograms or the the structural analysis. So the clinical findings, the structural analysis, and the visual field analysis, they should go hand in hand so that we know that these defects are not artifacts, they are the real visual field defects that are happening to the patient. So you can see the early superior nasal step defect, the effect on the optic nerve disc, the effect on the retinal optic nerve head tomography, and also the visual fields. And so they all correspond with each other. Therefore, these defects are to be taken notice of and treated accordingly. Similarly, the advanced superior nasal step defect that can be seen in all three areas: the clinical photograph, the fundus, and the tomography and the perimetry. And same here, advanced nasal step defect with the early arcuate and bearing of blind spot. And you can see the optic nerve head defects and the tomography and as well as the visual fields. And the superior and inferior nasal step and superior and inferior arcuate defects can be seen damage to the whole of the optic nerve, the periphery of the optic nerve, and shown in the tomography and also in the visual fields. And then there is an end stage defects, total loss of field of vision with preservation, and you can see the Heidelberg optic nerve tomography and also the Humphrey field analysis. And these pictures correspond with each other, and they are clinically important. So the clinical indications of perimetry are for the purpose of diagnosis when we find a case to have the raised IOP, when there is a suspicious optic disc changes, and also in cases of myopia and family history of glaucoma, we go for the confirmation of diagnosis and we see the visual field and do the visual field analysis. And is also important for the management of glaucoma. As for the monitoring of glaucoma on the long-term basis, we always do the visual field at 6 monthly intervals, sometimes earlier if the disease is progressing at a rapid pace. In conclusion, the diagnosis of glaucoma requires, if not high, at least the optimum index of suspicion, and the patients of almost all levels of visual field defects and visual acuity can undergo visual field testing. And the careful selection of patients for perimetry should be done to reduce the overburdening of the perimetrist. And the monitoring of glaucoma can only be done by repeated optic disc evaluations and regular visual field examinations. I thank you very much for your presence and attention for this presentation.
Thank you, sir, for such an interesting talk. I request for Dr. Madhu Bhadoria, ma'am, if you could give us your comments.
Very nice presentation given by him. I think could have been a little more precise in the sense that 24-2 is more useful now for certain specific reasons. So that, and right now we are using 10-2 a lot more in the early detection of glaucoma. Similarly, 10-2 for follow-up of the advanced glaucomas, which are absolutely zero on OCT and HRT. So these things we could have added, but whatever he's told, wonderful, absolutely perfect.
Thank you, sir, for giving us a very good insight on the wonderful topic. And it's very, very important for any glaucoma person to understand and read those fields and correlate. Thank you so much, sir.
Thank you.
We can move on to the next talk, Shurba. Time. You're on mute. You're on mute, Shurba. Unmute yourself.
Am I audible?
Yes.
Yes, ma'am. And next speaker for today is Professor Afzal Bodla. Sir will be speaking on the role of RNFL thickness and disc perfusion in the diagnosis of pre-perimetric glaucoma. Sir is currently the president of the Pakistan Glaucoma Association, professor of ophthalmology, CMH Institute of Medical Sciences, and consultant eye surgeon at Bodla Eye Care in Multan, Pakistan. He has an active interest in research activities and has several national and international presentations to his credit. He has been an active and regular participant in APAO, SARC, ICO, and the Afro-Asian conferences. Welcome to you, sir.
Thank you very much. I am really thankful to all organizers organizing for the excellent SARC conference. And Dr. Nadeem has an excellent talk on the wheel fields. Wheel fields are very important if you have moderate to advanced type of glaucoma. I am going to highlight on the most difficult topic, that is the diagnosis of the pre-perimetric glaucoma and how to diagnose the pre-perimetric glaucoma. I'm going to share the screen.
Yes, sir, it's visible.
My talk is based on the role of retinal nerve fiber layer thickness and the disc perfusion in the diagnosis of the pre-perimetric glaucoma.
Can you make it full screen, please?
Yeah. Next, please. I have difficulties. Next, please.
Make it full screen.
Slideshow mode, sir.
Slideshow mode.
Having some Is it okay now?
No, it's not in the slideshow mode as yet. सर वो जो बड़ी सी स्क्रीन बनी हुई है ना नीचे उसके ऊपर ले चले जाएं. नीचे होती है, नीचे है वो.
At the bottom, yeah.
Yes, sir. That's
just click on.
That's fine. It's okay now.
I think it is not allowing because he's clicking on that. Yeah. So maybe, I think, sir, we can present like that. It's not allowing because you've clicked, but it is not showing.
All right, go ahead.
Is that okay?
Yes, sir, please go ahead.
Slide line. As we all know, the pre-perimetric glaucoma is defined as the presence of the characteristic glaucomatous changes in the optic disc, and there is neuroretinal rim thinning with the cupping of the disc, and there could be a suspicious inferior or infratemporal retinal nerve fiber layer defect. And this is all without the presence of the visual field defects. As the visual field defects, they only start when the functional changes they have taken place, and when there are structural changes, they don't become prominent. Next slide. As we know that the more than 50% of the total retinal ganglion cell, they synapse the central 5 mm of the macula. The importance of the macula that has become much more, and there is a growing recognition that the measurement of the glaucomatous macula, along with the retinal nerve fiber layer thickness at the optic nerve head, that is as important as the optic nerve head, and we can evaluate the vasculature of the optic nerve head and the macular ganglion cell complex by OCTA. So nowadays, with the help of the OCT and OCTA, we can have a very good diagnosis of the early cases, or those cases which are at the stage of the perimetric glaucoma or glaucoma suspects. Next. Imaging devices like OCT and OCT plays a critical role for assessing the risk of retinal nerve fiber changes, and at the level of the optic nerve head and at the level of the macula. A comparative study has shown that an objective structural assessment of the retinal nerve fiber layer thickness by the imaging devices is more accurate than the clinical evaluation of the disc photographs. Previously, what we used to do was that we used to take the photographs of the optic nerve head, and then we used to correlate it with the visual field changes. But once the visual field changes, they have not taken place, so naturally, we can use the OCT or OCTA for the evaluation in the cases of the glaucoma suspects. Numerous studies have found already that objective quantitative assessment of the retinal nerve fiber layer loss in moderate and advanced glaucoma that can be compared with the visual fields, but not in the cases of the pre-perimetric glaucoma. Objective of my study was to highlight how to diagnose the preperimetric glaucoma, and for the purpose I have used the Fourier domain optical coherence tomography system, which is RTView with the SD, SDOCT and OCTA with a software version of 6.12 and 7. Methods for patient selection was patient with the positive family history of open angle glaucoma with a borderline intraocular pressure of 20 to 23 millimeter of mercury, having a minimum of 2 to 3 readings with the normal CCT. On the clinical evaluation, having CD ratio of more than 0.3 and optic disc color and rim changes, and gonioscopic showing the open angle of grade 3 and grade 4. As we know, the structure changes precede the functional changes. By the time the 20 to 30% of the nerve fiber layer has been damaged, the visual field changes begin, and the time difference between the nerve fiber layer damage and the visual field changes, that is approximately to 3 to 4 years. So basic concept of all this study is that we have a specific selection criteria, and then we are going to use the OCT and OCTA for the evaluation of the retinal nerve fiber layer thickness at the level of the optic nerve head and parallel at the level of the macular ganglion cell complex. And then we are going to have the disc, see the disc perfusion at the level of the optic nerve head and at the level of the macula by the OCTA. Next. Average GC thickness is approximately 95 to 100 microns, and a change of 5 or more micron is considered significant. So the glaucoma structural diagnostic index is required for the accuracy of such cases, diagnosis of such cases. As we all know, the optical coherence tomography angiography is a non-invasive, non-dye-based imaging of the retinal and toroidal circulation, and it detects the blood flow through the motion contrast by the red cells movements. Optic nerve head is supplied by the two arterial system, the central retinal artery in the superficial layers and the posterior ciliary artery in the deeper layers. Next, please. And it is known that the main pathological changes in the glaucoma, they are localized in the deep optic nerve head region, which are supplied by the ciliary arteries. So if you want to evaluation of the vascular density, the evaluation of the vascular density that can be divided into 3 parts: in the periperimetric glaucoma, in the preperimetric glaucoma, and in the normal eyes. There are a lot of studies they have been done, and my pattern of the study that was the same, that how to evaluate in the cases of preperimetric glaucoma. Now these are the different vascular studies, and they indicate at the level of the emetropia, the hypermetropia, and the myopia. The upper one is showing the vascular density at the macula, and the lower one is showing at the density at the level of the optic nerve at the RPC vessels. So the revised diagnostic approach for the preperimetric glaucoma, that is by adopting the available and more accurate diagnostic approach by having the microvascular changes at the optic nerve head and at the macula, objective and quantitative assessment of the optic nerve head and the macular ganglion cell layer thickness with disc and macular vascular evaluation by OCTA, then to have the disc rim changes by OCT and simultaneous retinal nerve fiber loss in a non-diffuse pattern at the 2 opposing locations, which are the most important at the inferior and at the superior. Now here is a case presentation. This patient is on prostaglandin, and I have given all the analysis starting from the optic disc up to the level of the vascular studies. Now this is a fundus photograph of the disc of the right eye having a CD ratio of 0.7. The other eye is having CD ratio of, the right eye is having 0.7, the left eye is 0.4. Now if you see the retinal nerve fiber layer thickness at the level of the optic nerve, there is an inferior defect in the right eye, while the left eye that is having the normal retinal nerve fiber layer thickness in all the 4 quadrants. Now this is the macular ganglion cell study, and there is a change at the level of the inferior macular ganglion cell complex in the right eye again, while the left eye is having the normal macular ganglion cell thickness. Now, when I study the focal loss volume and the global loss volume, the right eye, as there was changes in the macular area, that showed the focal loss volume and the global loss volume in the right eye, while the left eye, that was normal. And on the vascular density study, When I studied the right eye, there was change in the thickness in the inferior quadrant or infratemporal in the retinal nerve fiber layer thickness, and similarly there was a change in the vascular area of the optic nerve in the inferior and infratemporal quadrant of the right eye, while the left eye that remained normal. Now this is the right eye showing the abnormality at the inferior part, infratemporal, and the nerve fiber layer thickness as well as the vascular, while the left eye that is showing the normal pattern. So coming to the conclusion and having the latest diagnostic criteria for the preperimetric glaucoma and glaucoma suspect, I conclude as under, we have to look for the optic nerve head cup to disc ratio and disc rim changes. We have to analyze the retinal nerve fiber layer thickness changes of the optic nerve head at infratemporal and the supratemporal areas. We have to look for the retinal nerve fiber layer changes at the macular ganglion complex and looking for the focal loss volume and the global loss volume. And last of all, the most important, they are the changes in the optic nerve head vascular density and the macular vascular density. Thank you very much.
Thank you, sir. That was a very interesting and educational talk. I request Dr. Nadeem Bhatt to please give us your comments.
Yeah, it was a wonderful talk by Professor Bodla. He has been working on this subject for last many years and has been making presentations nationally and internationally. And he has found out very interesting information from that very early diagnosis can be done with the help of macular cell complex and ganglion cell complex. And with the help of that, you can even diagnose the preperimetric cases of glaucoma, as we all strive to diagnose the glaucoma as early as possible. And therefore, this technique and this methodology is very important for the early diagnosis of glaucoma. Well done, Professor Bodla. The very well made presentation.
Thank you very much. Thanks a lot.
Thank you, sir.
Thank you, Shorba. I have one question for Dr. Bodla. I really admire his work. It's really worth in this time. I just wanted to know that all of the studies say that RNFL changes occur before the macular changes in early glaucoma and the GCC things. So what is he finding? Are they going side by side, or the macular changes are appearing early before RNFL changes?
Well, actually, as I told you that I'm using this RTView, and I've got all the software of the analyzing the macula as well as the optic nerve thickness. The strain thicknesses, I have seen few cases in which the retinal nerve fiber layer thickness at the optic nerve head is normal, but the macula that has started the changes. And the changes which are appearing at the macula that are again at the inferior macula.
Yes, sir.
So in certain cases, you will find first changes in the optic nerve head, and again you find changes at the macula. But I would like to say a few words about the macular area, because there are no vessels at that area, and we have got the maximum concentration of the retinal ganglion cells. But if we see the optic nerve head, that can have a different variations. There could be a myopic eye, peripapillary atrophy, and other abnormalities. So I have started feeling the macula is much important as compared to the optic nerve head. There could be variations, but the macular study can give you a better evaluation of in cases of the glaucoma suspect and preperimetric glaucoma.
Yeah, so the message that is going very clearly that macula is as important as disc and RNFL, which most of the people as on today do not think like that. So I think the message has to go that all three of these parameters are important in all the patients, especially in preperimetric. Right?
Exactly.
Right.
I have one question to Dr. Bodla. As Dr. Madhu rightly said that GC changes, the GC IPL changes or macular ganglion cell changes may come in some patient, and you will find the RNFL totally normal. Exactly. On the other hand, in some patient, RNFL thickness is there, but ganglion cell complex change is not there. So this is already been a recent study by Dr. Kiopart, and he also showed that in some cases you will find GCC changes, in some cases you will find RNFL changes fast, in some cases both. But I have one question to you. If you find the ganglion cell complex changes and would you expect anything field defect in the macular field defect in the visual field?
Not in
question
early stage. Not in early
Yes.
stage.
Not
But
in
to
early
my
stage.
surprise,
in
there was
the 10-2, if we do the 10-2 visual field, then do you expect any visual field changes whenever you find there is a change or thinning of the ganglion cell layer, of the macular ganglion cell layer? My question to all of speakers and
Yes,
panelists.
sir, you're right, because some patients do have a change in 10-2 visual field. We are doing it now routinely for all the preparametric glaucomas. Instead of doing a 24-2, we are doing 10-2 because we all know the changes come first over there. And in 24-2, the points are 6 degrees apart. So there is a lot that we miss. So combing of the visual field in 10-2 is rewarding. And that too with the OCT, RNFL and macula, plus this, we're actually doing a study. So as and when it's finished, we'll publish it. But this is what we are finding in the interim report.
Yeah, actually my protocol for investigation is OCT, RNFL, optic disc, and GCIPL layer.
Yes.
And if we find any change in the GCIPL only, but there is no other change, visual field is 24-2 is normal, then we write for the 10-2. And many times we get some visual field in the center. So that is our experience.
Thank you very much, Dr. Nazrul Islam. I just want to have one question. I have seen few cases in which the optic nerve head thickness was normal, the macular thickness was not normal, but when I did the vascular study, the changes have started at the level of the vascular optic nerve head.
Yes.
How would you comment that?
Yes, of course. In the OCT angiogram, we have this opportunity to see the ocular optic nerve head vasculature. And it is a very, very early change for the glaucoma. Though we are using it in the research purpose now, but I hope in next few months or few years, it will be routine for us to write the optic nerve head vasculature in the OCT angiogram, hopefully.
And more so in NTGs. In all the NTGs, this should become a screening thing because that is where the vascular component is far more important.
Yes, yes, of course. Thank you.
Thank you.
Thank you, sir. So let's move on to the next talk. So our next speaker for today is Dr. Sushma Tejwani. Dr. Sushma is the head of the Department of Glaucoma in Narayan Nethralaya 2, Bangalore. She underwent her training at LV Prasad and at the Mayo Clinic with Dr. Arthur Sitt. Her areas of expertise include glaucoma surgeries, glaucoma shunts, pediatric glaucoma surgeries, and refractive cataract surgeries. She has won the DB Chandra Award in 2017, IGO Silver Award in 2018, and she has won the Best Paper, Poster, and Video Awards at the AIOS, GSI, and AAO. She is the NABH Accreditation Coordinator for Narayan Nethralaya 2, and she is currently also a PhD scholar with the Vellore Institute of Technology. Dr. Sushma will be speaking on the holistic approach in glaucoma management, and she will also be covering certain case scenarios today for us, since Professor Mahir had an unfortunate incident and couldn't be with us today. So Dr. Sushma will take an extra few cases for us. Over to you, ma'am.
Thanks, Shuruba. You can stop share. I will start sharing the screen.
GLV.
So I think, first of all, I will just cover Dr. Meher's talk about because it is in sequence with what Dr. Bodla spoke just now. So my job is done easy as he has taken us through how we should be reading. So I'm just going to take you through some cases. My screen is visible.
Yes, ma'am.
Okay. So when glaucoma diagnostics and imaging come to rescue, well, we know that it's a gamut of diagnostics that we require to have glaucoma diagnosis and management. And in addition to IOP, gonioscopy, and functional and structural tests, when we reach to a diagnosis, many a times we do see structure function discordance. So actually speaking, if these methods agree so perfectly, there will be no need to have both the structure and function, and only one should suffice, but that's not true. So that's why we need to do both structure and function. So that's why perimetry as well as OCT becomes equally important. And I'll try to demonstrate that through some of the case scenarios here. Well, this is a 63-year-old female with the counting finger 1 meter vision, very high pressures. So typical acute ACG attack, and left eye was primary angle closure suspect. So both the eyes PI was done, and then detailed evaluation was done 1 week later. So if you can see, both the nerves, right eye, left eye, look quite okay. And the OCT also gives us quite a clean chit. But if you look at the visual fields, this is the damage that the right eye has had after the acute episode, but it is not yet reflected in the OCT. So in these situations, the functional damage can sometimes be better. However, when we have newer technology, as we were just mentioning about OCTA, so if you look at the OCTA in this patient, you can clearly see the differences in the macular perfusion in the right eye and left eye, so that we can pick up these changes much earlier than what we pick up at RNFL change. So again, you can see in the right eye, there are much more areas of dropouts than in the left eye, and that explains the damage that the patient has had with sudden high pressure due to acute attack. Now, that's how we have these newer technologies, whether it is macular GCC or OCTA, to overcome certain limitations that we had in OCT. Now, a second case is a 41-year-old male with normal pressures, open angles, and this is what you see, a typical NFL defect on the right eye inferiorly that you see. And when we do fields, it's actually normal. So that is where, as expressed well in the previous talk itself, that OCT comes into picture, and we can detect the change which is clinically correlating, and that's how this patient was put on treatment. So it definitely helps in preperimetric glaucoma. Another case, 62-year-old male with the normal pressures on PG analogs for 2 years, open angles on gonioscopy. This is how the nerves looked like, and this is what the fields were. Now, why he was on PG analogs? Maybe because of that. Now you can see the OCT showing multiple changes, a lot of areas of red and yellow there in both the eyes. So looking at clinically normal disc and fields, we advised to stop medication because he had developed this kind of scaly lesions around the eye because of the drug. So after 3 months of stopping medication, his skin became normal. And after that, I have been following this patient now. Over the next 6 years, he's been quite well without any medication. So sometimes we have to be cautious about reading OCT. We have to be cautious of the red disease on OCT, and always should correlate clinically. Another gentleman, 52-year-old with normal pressures, on treatment with beta blockers since 3 months, and open angles on gonioscopy because of this fields. Now, this is very obvious. It is a normal disc and OCT, and this is a clover leaf defect. So we have to be careful. So sometimes function, sometimes structure can definitely give us some doubtful situations. So we should always be clinically correlating the things. It's important to learn a good disc evaluation, which goes a long way in taking care of these unnecessary treatments. So these are the different potential source of errors in perimetry, which I would be skipping as it has already been covered. Now, another case, 30-year-old male on Xelatan for long, and you can see these typical superior notches with this kind of defects, which is corresponding with the disc changes. The OCT also shows superior defects and inferior scotomas on field, so definitely on treatment. However, this patient was not very regular with follow-up. So when we looked at his progression analysis, the rate of progression was quite high, and that's why the medicine was stepped up. Now, this is just to demonstrate that progression analysis are very robust in function as well as structure, which can pick up the progression very typically. In OCT also, you can look at the RNFL change on over a period of time and look at the progression. Even the quantitative change can also be picked up by these differences in baseline and follow-ups. Even the optic nerve head and GCC can give you the progression soft pairs, which can actually help detecting progression qualitatively as well as quantitatively, and help us in managing these patients. A typical large disc, I would say, I'm sure it is very clear that you can see very large nerves with 0.8 CDs and normal RNFLs, and you can see the large disc can underestimate the damage, although here the OCT is normal. Similarly, the fields for this patient were normal. So this is a large disc physiological cup. So we should depend more on the functional assessment when there is unusual size of disc, because even the smaller disc can give this kind of a red disease. This patient again is small disc, 0.4 CDs and multiple red areas on OCT, however, normal fields. That's because of the small disc. So it's important to look at these issues when we are looking at the damage. Why it happens so is then when you have a larger disk and a smaller disk, the calculation circle that checks the RNFL thickness is the same. So the distance that you see from the optic nerve head margin is very different in the right disc and the left disc. And that's how you see the statistical comparisons go haywire, and you can get abnormal values on OCT statistical comparisons and color-coded maps. This is a patient with advanced glaucoma disease. You can see 24-2 and 10-2 getting affected. In these situations, our OCT also gives you a significant depression, but however, because of the floor effect, it has a limited role in advanced damage because it is very hard to detect progression. So there, the function of the 10-2 program helps a lot. So these are certain limitations. Again, I'll skip that. Another case of 30-year-old with dengue fever and high pressures, occludable angles, optic nerve being normal. So this is the UBM that helps in detecting the ciliocoroidal effusion, like how you have topinamate-induced glaucoma. Similarly, this patient developed this kind of a ciliocoroidal effusion after dengue fever and got controlled with topical steroids and atropine. Did not have to do it. So it's not a primary angle closure. 1 week later, as we stopped the medication and put him on steroids, the vision was back to normal and the pressure's okay. You can see the resolved fluid there. So clinical suspicion and UBM could help detect this drug-induced secondary angle closure. 3-month-old child with buophthalmos, you can see this is opaque cornea, and UBM can help us detect that DM split. So that is where its role, when you see children with corneal haze, scarring or opacification, UBM can be an important tool for anterior segment assessment and planning management. Another child with very shallow chamber, you can see a buophthalmos here, 10 pressures, 46 pressures, 20 days old. So when we looked at the slit lamp, you can see the chamber is very shallow. This is a handheld slit lamp picture. There was eco-free vitreous cavity. There was no mass or bleed on B scan. And when we do UBM, you can see this is the anterior chamber. Actually, the lens is here. This was a hyper-reflective membrane, which was causing shallow AC. And that's how the A scan was picking up deep AC. But on slit lamp, we could see a small chamber. So this was a pupillary block due to inflammatory membrane. So again, the imaging or UBM comes into play. So here we actually did membranectomy and surgical iridectomy. Did not have to do trap for this child. And post-operative, you can see the AC is deep and the cornea is much clearer. So last case, I think, 37-year-old with post-DSEC glaucoma right eye with the scleral contact lens user. Trap was done for this patient and the pressures were okay. However, when he restarted using the contact lens, the pressures rose again. So when we did an ASOCT along with the contact lens, you could see that internal ostium was patent. But what we could see is the contact lens edge was pressing onto the bleb. And that is what was causing the pressures being high as the external ostium was being pressed. So in this patient, we actually ordered a customized lens with a notch at the area of the bleb, so that that compression you can see is no longer there and the pressures came back to normal. So these are the things which can be, which these new modalities or imaging can help us with. So you can see the change in the compression of the bleb. So this becomes a useful tool. So just at the end, I would like to say that clinical evaluation is definitely the first and foremost tool for making a diagnosis and planning management for any patient, and we should have appropriate diagnostic tests for a given patient and correlate them clinically. Both structure and functional assessments are important to manage glaucoma, and ASOCT and UBM also have an important role in select group of patients. So this is an integral part of management. Thank you for your kind attention. I think I will continue with the second talk in interest of time, and then we can take discussion. Is my screen visible?
Yes.
Yes, ma'am.
So coming to holistic approach in glaucoma management, well, treatment goal in glaucoma is basically to prevent the loss of vision function so as to maintain the quality of life. which is associated with the disease. And we emphasized enough that structure and function both are important. So we have to have a holistic approach to take care or maintain the quality of life in a given patient. In glaucoma, there are multiple things that we can use. The most important being medical management and the surgical management. There are lasers to support the treatment. There are non-IOP related factors that we should be looking into, like neuroprotection, vasoprotection. There are systemic issues that we need to be addressing. And of course, there is a role of alternative therapies. I think we had a lot of work done by our colleague Dr. on yoga and meditation at RP Center, which uses alternative therapies to take care of glaucoma. Well, I would be talking in this talk particularly about the medical management only. Now, when we talk about medical management, we know that reduction of intraocular pressure is the most important factor to treat glaucoma. And most of our RCTs tell us that per millimeter decrease in the pressure can reduce the reduction from 10 to 20%. So it's definitely important to control the pressure, and the lower the pressure, the better it is for the patient. Now, when we plan medical therapy, we need to look at the efficacy of the drug at its best. We need to look at the indication as per type of glaucoma we have, to look at contraindications in a given patient, including the socioeconomic status. Also look at the systemic issues before prescribing a medication, and maximize compliance. When we plan for any medical management, we look at what is the target IOP for a given patient. Now, target IOP is a range at which progressive disease is unlikely to affect the visual function or the quality of life. To achieve that, there is no validated algorithm. It's actually a range which depends on individual patient's risk factors and the type of the disease. Now, it has to be individualized based on the needs of the patient as well. And over a period of time, as we see progression, we can re-evaluate it and reassess the target IOP range. So to set the target IOP, we need to look at the existing glaucomatous damage that patient presents with, the life expectancy of the patient, untreated intraocular pressure, and the additional risk factors. More importantly, we have to look at the rate of progression on follow-up so as to reorganize our target IOP for a given patient. Now, we do have AAO guidelines to know how much reduction or percent reduction pressure we would need for a particular damage or a given patient, and also lowering 25% of IOP from the baseline definitely slows the progression of POAG. So we need to look at achieving the target, and where we may require one or more than one medication or even surgery to obtain the same. Now, talking about medical management, we have different first-line drugs, second-line drugs, third-line drugs, and the newer drugs also, like Repasidil and Etrasidil now. So all these drugs work either on the aqueous humor inflow or the uveoscleral outflow. Now, we also have drugs which work on the trabecular outflow, that is the Rho kinase inhibitor, which changes the active cytoskeleton in trabecular meshwork and improves the trabecular outflow. Now, just a word about each drug, this thing, beta blocker. Now, beta blockers, the strong points being affordability and efficacy. These are the oldest first-line drugs. The important things we need to take care is tachyphylaxis is a possibility in beta blockers over a long-term use, and a long-term drift is also a possibility. So we need to keep that in mind for patients on beta blockers. And we need to rule out the systemic issues in these patients. So it cannot be given in patients with bronchospasm, cardiac blocks, or altered lipid profile. Prostaglandin analogs have become the most popular first-line drugs. They have mainly the local adverse event, no systemic issues, and compliance and efficacy are the most important factors that are favorable. They are contraindicated in certain diseases like herpes, uveitis, or inflammatory glaucomas. Coming to dorzolamide, there is certain indicators which tell about vasoprotection, although we don't have very strong studies on that. Earlier, there were only animal studies available. Now, with the scanning laser Doppler flowmetry, it has been demonstrated that the patients on dorzolamide have a larger or a better flow on ocular nerve head. However, how this translates into glaucoma manifestation or field changes is something that is yet to achieve. Brimonidine has been known for its neuroprotection effect. Again, the evidence is not very conclusive, but there has been reports of significant preservation of RNFL by scanning laser polarimetry in brimonidine group at 12 months or 1 year follow-up. The newer drugs in the market, that is Rho kinase inhibitors, are supposed to increase aqueous outflow and reduce IOP by improving the trabecular meshwork outflow. They have been popular to be used in Fuchs endothelial dystrophy, or also to decrease progression of diabetic retinopathy. They're known to have a bit of neuroprotective and vasoactive effect also, but most common side effect being conjunctival hyperemia. Now, just taking you through certain statements while you're selecting the drugs for a given patient. So when we talk about the drugs, only IOP lowering effect should be considered for comparative efficacy. For initiation, prostaglandin are supposed to be the first choice for most eyes. However, beta blockers have their role. When IOP reduction with initial monotherapy is less than 10%, that is called non-response, and those drugs should be eliminated. Adjunctive therapy should be limited to one drug from each class, and no two drugs from same class could be used. When we are talking about fixed dose combination, they definitely improve adherence. Also, when the drugs do not work and the disease is still progressing, surgery is always an option, and that should be considered. To select the drugs, it's important to look at systemic issues. Beta blockers are best avoided there. PG analogs are best avoided in unilateral or secondary glaucomas. Dorzolamide is best avoided in ocular surface issues or compromised endothelium. Brimonidine is preferred in NTG, and pilocarpine is still a useful drug. Certain group of patients may still require pilocarpine, and Rho kinase inhibitors are preferred in patients with endothelial compromise. According to GSI recommendations, as I said, the monotherapy should have at least 20% drop in the pressure, and if not, then we need to switch the drug. So medications that do not lower the IOP should be discontinued. Switching can be done from using a drug from a different class. It's only if the initial drug uses prostaglandin, you can switch to a more potent prostaglandin. So the indications to switch would be if the first drug is not reducing the pressure by 15% also after 2 weeks, if there is tachyphylaxis with beta blockers, if you need only additional 1 or 2 millimeter drop, then you can shift to more potent PG analog. And if the patient is not tolerating drug, then you definitely have to switch. If the target IOP is not achieved, you need to add the drug after checking the efficacy. And when you use two agents from the same class, there is no additivity that is expected. So that's why we use one agent from each class. When we use the drug as a monotherapy, the efficacy is much more than it is used as an adjunctive therapy, that I will explain in the next slide also. So always check the efficacy of the primary drug before you add the next one. So when you add to a beta blocker, the PG analog would reduce the pressure by this much, and the other drugs as well. Whereas if the primary drug is PG analog, then the beta blocker would reduce by say 12%, but not the same as a primary drug. So these are the things we need to keep in mind. Also, while we are adding, we need to understand the more drops we add, the chances of compliance reduce. So that's why fixed dose combinations do come for help in these situations, and they also reduce the exposure to preservatives and reduce the cost for the patient. So when to switch or add is when you use the first drug as a monotherapy, and if it is well tolerated and effective for IOP, then you can, and the target IOP is achieved, you can look for periodic endpoints. If the drug is not well tolerated or is not effective for IOP, then you have to switch the monotherapy. However, if it is well tolerated and then you achieve the target IOP, you can follow up. If the target is not achieved after first drug, then you add the second drug. And still, if the target IOP is not reached, then you substitute the second drug and verify efficacy, or add the third drug if the efficacy is all right. So with all partially effective and tolerated drugs, if the IOP is achieved, it is well and good. And if it is not, then we should resort to other therapies like laser or surgery. So compliance is another issue that we need to take care, because that's a major problem, and there are multiple factors which are responsible for non-compliance. So we need to keep in mind that to improve compliance, we should be checking about adherence. We should be training our patients how to use the drops. We should be addressing the side effects, particularly situations like this we should avoid. We should tell them the digital occlusion of the tear duct so that they avoid the systemic effects. And that's how the compliance improves. Just to tell about certain caveats about what guidelines I explained, that these are largely for POAGs, that is primary open angle glaucoma, can be applied to PACG only after peripheral iridotomy. There are implications and alterations for these rules when we are talking or treating the secondary glaucomas, and we need to treat the cause as well. Certain aggressive glaucoma do require surgical approach immediately or at a much earlier stage than trying the medication. For follow-up, in general, if the target IOP is achieved, you can be relaxed. If it is not achieved, you have to be following up the patient closely. As a general guideline, severe glaucoma every 1 to 4 months and mild glaucoma 6 to 12 months can be followed up. So the key points for medical management would be the target IOP needs to be determined individually based on the rate of progression. We can confidently recommend further IOP lowering in patients who are progressing and are associated with risk factors. We should always check the efficacy of the drug before adding the other. We can use multiple drugs, fixed combinations, or surgery in patients who need further IOP reduction. And patients who are fast progressors deserve much earlier and stronger intervention with fewer and better drugs. So the sooner the treatment, the lower the IOP, the fewer the medication, the better it is for the patient. So thank you for your kind attention. I would just end the talk with a message that it is important to understand that it's not the presence or absence of a particular disease that is of utmost interest, but the future health outcome for a patient with or without treatment that goes a long way. Thank you.
Thank you, ma'am. That was a very interesting talk and even very interesting case scenarios that you showed. If I could request Professor Nazrul Islam to please give us your comments, sir.
Oh, thank you very much. It was excellent talk and very good overview on the medical treatment of especially in the open angle glaucoma. And this has covered everything starting from the target pressure, target IOP. And I also agree that for treating any glaucoma patient, we must determine the target pressure. And if it is, say, if I diagnose an advanced glaucoma in the early stage, in the first time, then you have to give maybe 1, 2, or 3 drugs. So you have to determine the target pressure first, how much you need to decrease the pressure. Because we know every drug has its limitation. It can decrease 20%, 25, 30% maximum, not more than that. So definitely you can determine yourself, this patient, which drug and how many drugs I am to give. Another point she has rightly mentioned, you start with one drug of one group. If it doesn't work, go for the other group, definitely. And you take the history of the patient, and also the financial ability of the patient. In our countries, we always think these analogs is comparatively higher price. So if a poor patient comes, we try to go for the beta blockers if there is no contraindication. So she has also mentioned like that. I have one question to her. You have gone very nicely. In the pregnancy, we find difficulty to maintain our anti-glaucoma medication. So what is your recommendation that during the pregnant time, the first trimester or second trimester, what kind of drugs actually we can use for this kind of ladies?
Yeah, I think if you ask, brimonidine is the only drug I think that we can use during pregnancy. So generally what we do is also, if the patient is going towards second trimester, we prefer to use a cyclo G6 to give them a temporary drop in the pressure, so that we can manage for some time also, because as the pregnant mother will convert into lactating mother, even giving brimonidine would be difficult. So that is actually a challenging situation when we come across pregnant ladies with glaucoma. So the only drug that we can safely give is, I think, brimonidine.
But there is some recommendation that brimonidine you cannot give in the late stage.
Yes.
When the baby is born. In the first trimester up to second is fine. But in the second and third, I think you can go for carbonic anhydrase inhibitors for the time being. Otherwise, no other medicine will be safe. That's very important. Of course, Professor Nadeem.
Yes, sir. I think since the trials of all these drugs have not been done on the pregnant and lactating mothers for the safety of the mother and the child, therefore, we always remain unsure what to give in that particular situation. And sometimes even the patients come up with the question that, I'm already using these medicines and I'm recently married and I'm going to be, I'm planning for the family and I'm going to be on the family way. what changes in my treatment would be possible. In that situation, we are again in the dilemma what to start and what to stop.
Yes.
So the trials, since the trials have not been done, there is no confirmation. And in the drug pamphlets and the leaflets which we receive with the medications, it's always written on them that there is no information for the pregnancy and for the lactation. So it's just the clinical experience that we have for the first and the second trimester. You are absolutely right that these 2 trimesters we can still keep on giving instead of prostaglandin analogs are contraindicated in any way, but the the dorzolamide and to some extent beta blockers or brimonidine can be given safely, but they also, especially the brimonidine can cross the blood-brain barrier and it can affect the neonate or even the fetus. So it's very.
You cannot give more next to second trimester. You cannot.
Second and third trimester is really difficult.
What I do in my patient, if I find patient, I try, if the angle is open, I prefer to give the selective laser trabeculoplasty. And I have done in many cases, and I found it's very good that it decreases 30 to 40% pressure. And sometimes you don't need any drug. And during pregnancy, the IOP actually decreases. Naturally, there is some decrease of the IOP. And if you give SLT, it also decreases. So I have some patient, they're doing very good with SLT. And in some patient, I could not give any drug, but the pressure is very high. So I had to do surgery, the filtration surgery for the patient. So there's another option for us.
True.
Thank
True,
you for
sir.
the nice presentation. Thank you.
Thank you, sir. Thank you.
Well done.
So I think in interest of time, we go ahead to the next talk.
Yes.
Shurva.
Thank you, sir. Let's move on to our next talk for today. Our next speaker is Professor Nazrul Islam. Sir will be speaking on challenges in the current glaucoma management in the SAARC countries. Professor Islam is Professor and Chairman, Glaucoma Faculty at Bangladesh Eye Hospital in Dhaka. He is the former President and current advisor for the Bangladesh Glaucoma Society. He is currently the President of the Bangladesh Society of Cataract and Refractive Surgeons at Bangladesh Eye Care Society. He is a board member of the Asia Pacific Glaucoma Society. He is the Editor-in-Chief for the Journal of Bangladesh Glaucoma Society. He has several articles and editorials published in various peer-reviewed ophthalmic journals. He is the author and co-author of several books, and Dr. Nazrul Islam has received multiple gold medals and awards, both at home and abroad. Welcome to you, sir.
My screen is visible, Dr. Sharma?
Yes, sir. Yes, sir. You can make it slideshow.
Oh, sure.
Yes, sir. Excellent. Thank you.
Thank you so much, Dr. Sharma, and the SAO organizing committee for the opportunity. Well, I'll talk a different subject, challenges in the glaucoma management in SAARC region. Actually, already we have discussed different challenges. I think we'll add some more challenges now. I do not have any financial disclosure in this presentation. And if we look to the countries in the SAARC, the 8 countries, all are in the developing country. No one is very developed and much rich country. So first of all, we don't have good data. How many people are suffering from glaucoma? How many patients are having open angle closing? There is a scarcity of data is always there. In Bangladesh, we have a data prevalence survey in 2004 and published in British Journal of Ophthalmology, and we found 3.1% people are suffering from glaucoma at the age of 35 years or more. We know that population growth is another important factor in this developing country. And we know also that when there is aging, the glaucoma progression and glaucoma diagnosis become more. So we are also in that group of having more and more glaucoma. And also we agree that we diagnose our cases in the advanced stage, not in the very early stage. So we have different challenges, clinical, economic, and humanistic. If we look to the diagnostic challenges, of course, the first important is the awareness problem. And Dr. Venkatesh rightly mentioned that we don't have much awareness. In the Bangladesh survey, we found that 98% people in 2004 did not heard the name of glaucoma. So it's so much lack of awareness in our country and in the developing country. And in the different smaller cities who don't have facility or the equipments of diagnosis of glaucoma or confirmation of the prognosis of glaucoma. So it is really difficult and crucial for determining the progression and true diagnosis of glaucoma. We have also challenges for the adherence of medication, because you have seen most of the medication, as Dr. Sushma also showing, having a lot of side effects, that allergic problems. The patient usually, competence becomes very less, compliance becomes very poor. So it is another problem for us. Regarding the challenge of treatment, we know that we have 3 categories of treatment: the drops, laser, and surgery. If you look to the drops, then Dr. Sushma already mentioned so much adverse effect we find. So I always try to convince my patient in the early glaucoma cases, when there is not much defect in the OCT or there is no change in the visual field, preperimetric glaucoma, very low pressure, do not need very high, low target pressure, I prefer to do selective laser trabeculoplasty, because it does not make any harm to the patient. It increases the quality of life. You can see there is no structural damage in the SLT. And Stasfield et al. Showed that it works as good as the latanoprost, that is about the 30% decrease from the initial IOP. If we look to the different studies, we find the SLT decreases 11 to 40% from the initial pressure. So definitely it works. And a very recent study published recently in October, and the LIGHT study in China, they also recommended that SLT is very good for the early glaucoma and ocular hypertension. In one of our study in Bangladesh, we found in 300 eyes that 75% people eyes decreases the pressure more than 30%, and published in 2015. Well, whenever there is advanced glaucoma, moderate glaucoma, SLT is not enough. Then what to do? Then you have to add something, either 1 drop or 2 drops or more. In angle-closure glaucoma, you need a laser or the LPI, but which is also not available in all places of this SARC region. Well, in most of the cases, if we find our patient reach the target pressure, good compliance, stable structure and function, definitely we're happy to continue the medical treatment, even maybe there are 2 or 3 or 4 maximum medical treatment. But unfortunately, this is the common scenario we find to our patient. And this adverse effect, the patient usually compliance become poor, the quality of life become poor. So the patient stop taking the drugs and the glaucoma progression increases. And that is another big challenge for all of us. An ocular surface disorder is very common. And if we compare, according to Shane and Costa's report, that only 15% over the age of 75 years. But if you use the anti-glaucoma medication, it becomes up to 78% of ocular surface disorder. So again, another big challenge for us. Now coming to the surgical treatment, and if we look, a lot of surgical treatment now being practiced throughout the world, especially the developed country. But if we look to the lower part, the early glaucoma, here the SLT, trabectome, iStent works. But if you look at the advanced glaucoma, you need to go for the filtration surgery, tube shunt, or in focus mix, or the Gen implant. But I'm sure in the SARC region, this mix are not available in most of the countries, and it's not affordable. It's not covered by insurance. So definitely it is not our surgical facility for this part of the world. And we have to do mostly the filtration surgery or tube surgery. And when the Zen, probably I heard in India, Zen has been recommended. So Zen is available. And there are a lot of studies showed that basal flow and Zen is having good reduction of IOP like the trabeculectomy. So of course, in future, we can try with this. But till now, our surgery remains only in the filtration surgery and tube shunt, most of the cases. If we look to the mix, yes, there are many types of mix. But what are the mix that we can try in our SARC region? iStent is expensive, but the previous generation iStent become very cheaper now. Probably that can be used in some cases. I had the opportunity to use few cases which I brought from USA, and actually it is only good for the early glaucoma or moderate glaucoma cases. You can do along with the phaco, but it's not good for the patient we get in the advanced stage. Similarly, the Kahuk dual blade, which is again a mix, but it is good for the early glaucoma, moderate glaucoma, but not very advanced stage. I had the opportunity to do a few cases, and out of 7 cases, I had to do trabeculectomy in 2 cases because the pressure was become higher after 6 months. So actually, these are the mix which is good for the early glaucoma, not for the advanced glaucoma, and maybe not be good for the Bangladeshi or for the SAARC region. But I like to emphasize on the bank surgery. You know, the bank surgery is the bent ab-internal needle goniectomy. This is good for the SAARC region, for the developing country, because this surgery works like the KDB. And I have done more than 20 surgery now, and I have seen most of the surgery results are almost like the Kahuk dual blade. As the Kahuk dual blade, you are just excising, you can see here, the trabecular meshwork with the 27G bent needle from one corner to another, and from this side. So we can excise up to 110 degree of the trabecular meshwork. And that decreases the pressure 25 to 35% from the initial pressure. And it is so cheap that, of course, I'll recommend that we should do it. And I know Dr. Tanuj Dada is doing the live surgery on Bang now, and hopefully it will be more popular from now. Now coming to the advanced glaucoma that we face day to day, and we have to do the filtration surgery, tube shunts, or the laser, diode laser. Even in a very recent study of the primary TVT study showed that trap success is 72% compared to 67% tube if you do in the primary stage. That is the primary trap and primary tube. Primary trap is still better giving the success. So why not the trap for us, the gold standard? But only I'll recommend trabeculectomy is not a day surgery. You have to prepare the patient at least 7 days or 2 weeks before by stopping the blood thinners, stopping the PG analogs, giving the oral acetazolamide, giving the intravenous mannitol before the surgery, so the IOP becomes come down, ocular surface disorder becomes better, then your surgical outcome will be better. I use the anti-metabolized MMC in almost all my cases. And from last 2 years, I've used the subterenons low concentration MMC in all my cases. And one thing I'll show here is the limited deep sclerectomy. Because if you need a low target intraocular pressure, you need a single digit pressure, 9 or 8 or 10 or 11 like this. So in that cases, if you do your trabeculectomy along with limited deep sclerectomy, definitely it can decrease the intraocular pressure a much more than your routine trabeculectomy cases. So after making the superficial flap, half thickness flap, I'm making another deep scleral flap, but of course very thin, should not go to the choroid. And then I'm excising that part of the deep scleral. So making a lake actually in that part, the fluid, the aqueous comes and deposits here. And I have seen in all my cases, the pressure comes down quickly and for long, long time. But unfortunately, I got few cases which had hypotony and the pressure becomes so low. So this is not my routine procedure. I do when I need the target pressure very minimum in that cases. Now coming to tube, of course, when the refractory glaucoma, we need to do the bulb or the non-bulb tubes. But again, the tubes, we have Ahmed bulb, we have Burwell, Paul glaucoma implant, and RD. I'll recommend in SAARC countries, we learned RD. Because even in few years, we were afraid of doing RD because Ahmed bulb gives the instant result. The second day, you will get the intraocular pressure comes down. But in the RD, you have to still give the anti-glaucoma medication for maybe 1 week, 1 month, or 6 weeks like that, because you're occluding the tube. And though you're giving some fenestration, but most of the cases, you need to continue some of the anti-glaucoma medication in the RD. But recently we have learned how to make good outcome from the RD. So I will request in the SAARC region, we can use the RD, and we must thank the Aurobindo group to making this kind of very low cost tube for us. And we can offer to our patient who can afford the very high cost $600 Ahmed valve or the barbell for us. Even the PGN wall glucose implant is also expensive, but I use few of this implant is very good for the cases where the anterior chamber is shallow, because its tube is 30 gauge. It makes only very small space in the anterior chamber. So PGI is good in that cases where the AC is shallow, especially in the angle closure glaucoma cases. Now coming to the other part, the economic burden. We know that direct medical and non-medical costs of glaucoma are significant, not only in developing country, also globally. So this is economic burden. So if we diagnose our cases early, treat our cases, this economic burden goes very less. If we see the cost per patient, though we don't have much data, but we have data in the USA, it is $1,800 per patient. Australia, $500 per patient. Nigeria, $480. This is very high. So definitely, we need to cut the cost of the patient by early diagnosis and treatment.
Sorry to
Lastly,
interrupt you, sir.
Sure. Humanistic burden, of course, the quality of life should be increased by decreasing the, by awareness increasing, and of course, treating the glaucoma. So in conclusion, I would say that I will suggest strategies for combating the challenge and improving quality of glaucoma care. Number one, increasing awareness about glaucoma among general population. Early detection and optimal management of glaucoma is a means to prevent blindness and produce clinical, economic, and humanistic burdens related to this disease in developing and SAARC countries. We need low-cost, preservative-free anti-glaucoma medication. We need availability of the laser for the affordable cost. And of course, glaucoma filtration surgery must be learned by all glaucoma practitioners and should be done at low cost for the permanent treatment of glaucoma. Thank you very much.
Thank you so much, sir, for that excellent insight into very relevant challenges in our SAARC region and relevant to all of us sitting here in India, Bangladesh, Pakistan, Nepal. So thank you so much for the excellent talk. In interest of time, I'm just rushing to the next talk. So we have an important talk for the current situations in COVID times, the challenges, by Dr. Parul. Shoruba, can you?
Please unmute yourself.
Shurba, unmute. I think I will introduce. Dr. Parul is currently a professor of glaucoma services at Chandigarh Government Medical College. She has done her glaucoma training from PGIMS Chandigarh, and then clinical fellowship under Dr. George Spaeth at Wills Eye Institute, Philadelphia. She's the member of Associate Advisory Board and Education Committee of World Glaucoma Association. She's the Associate Managing Editor of Journal of Current Glaucoma Practices and is an Assistant Editor for Glaucoma Section IJO. She was enlisted in the PAR list of 2015 of Best 40 Ophthalmologists Under 40. So let's hear the best talk from one of the best, Dr. Parul. Can you share your screen, please?
Surely. Well, good afternoon, everybody. I would be talking about challenges in glaucoma management during COVID. So we know that COVID has almost been like a tidal wave. It just refuses to die down. From the perspective of an ophthalmologist, beta variant was one of the most severe ones, but we really don't know how the Omicron is going to behave. We have covered a lot of phases, moving from the lockdown to navigating our way back to our clinical practice. We tried to adopt a new normal, but we don't really know what googlies would be thrown by the newer variants that would be coming up. So it's always better to be prepared. when we look at from the patient's perspectives how COVID has affected their glaucoma, we know that the number of patients visiting the outpatient areas of our hospital and the number of surgical procedures for glaucoma has drastically gone down. So the follow-up of glaucoma patients has been impacted, and many of them run the risk of getting progressive changes in their glaucomatous status. Additionally, if we look from the doctor's perspectives, when it comes to risk for our own self, we know that the risk of ocular transmission of the COVID virus through the tear film is low. But we are concerned because of the risk that comes from the respiratory droplets from the patients. And especially, we are also concerned about our patients who are elderly and who have several comorbidities, making them much prone to contracting the virus when they visit the hospital. We also worry about the progressive changes in our patients. So looking at both the perspectives, the concern is very valid. What we really need to do is to reevaluate each of our glaucoma patients, evaluate the care that we need to provide. Earlier, what would happen is that if a patient has 20 or 21 pressures on a certain visit, we would tell them to come a couple of weeks or a month down the line to get their pressure rechecked before jumping onto escalating treatment. Now, the frequency of these visits has to be curtailed so that we can give them the best care without exposing them to the risk of contracting infection by visiting a healthcare facility. We need to develop scalable algorithms for triaging our appointments, and we have to take care of what is urgent and what isn't. We can develop our own teleophthalmology setup to address some of the non-urgent issues. And when we see our patients, then what do? The general guidelines have been floating around since the last 2 years, ever since COVID has taken over our lives. We need to remember that a certain set of staff has to be redeployed in doing this new task of pre-screening all the patients for COVID-19 symptoms when they visit our healthcare facility. There has to be a facility of hand sanitation at check-in and check-out. We need to reconfigure our space. Both the examiner and the patient need to be masked, and it's a general tendency when the patients sit on the slit lamp, they just pull down their mask. The slit lamp therefore has to be meticulously cleaned between the use. There has to be a screen shield barrier between the patient and the examiner, and we need to tell our patients to avoid or limit speaking when they are at the slit lamp. Now, cleaning of any slit lamp or any device at which the patient is putting their chin, we have to clean them as per the manufacturer's instruction manual for the adequate cleaning use for the agent that is best used or best suitable for that equipment. It's time we go paperless and we switch on to digital records, because the paper documents itself can be carriers for the COVID virus. So it's a good idea to switch to digital systems, and it also makes it easier to share digital data between two doctors. If the patient is not able to visit you when they visit a colleague, you can always transfer your digital records to them. Now, when it comes to the first factor, that is the tonometer, the challenge which most of us had initially was that the non-contact tonometer would aerosolize the tear film, and that would cause transference of the COVID virus. But that all was based upon one paper of 1991, which said that the pressurized air, when it encounters the ocular surface, it leads to microaerosol formation. But there were several problems with that paper which were overlooked in the initial period, that the photographic method which the authors had used at that time could not determine aerosolization, as aerosols are particles which are less than 10 microns in size, and the technique which they were using could not determine that. And the non-contact tonometer, which was used at that time, had an air pulse technology which was 4 to 6 times much stronger than what we have. So the modern NCTs definitely don't have this risk. They are safe to use. With Goldman applanation tonometry, the challenges of the high chances of contamination. So whenever we are using a Goldman applanation tonometry, we may need to make sure that we do not touch the eyelid margins with the anesthetic drop container that we are using to anesthetize the patient. And if we have accidentally done so, we need to discard the bottle even if it's new and replace it with a new one. The same contamination rule Also applies to gels which are used to fill the gonioscopy contact lenses. After each patient, if you are not able to properly sanitize the tip, at least use an alcohol swab of 70% isopropyl alcohol to clean the tip. As regards the other errors that can creep in, the mask, if it can go up, that can also result in pushing the feeder arm of the Goldman applanation tonometer. Different mask models have pushed the feeder arm, or they have caused external pressure on the globe and caused problems. When the data was analyzed, there was no study which concretely mentioned as to the best way of sanitizing a Goldman applanation tonometer prism, but 70% ethyl alcohol for a minute or sodium hypochlorite can be used. Another interesting fact is that if a patient is doing a walk, and if they are wearing an N95 mask when they're going for a walk, that can cause hypercapnia because of increased resistance and also can result in elevated intraocular pressure. So whenever your patients who have glaucoma, they go for a walk, just tell them to switch to a surgical mask or a fabric mask, but not to wear an N95, because even if the elevation of pressure is significant, it's small, it is still significant. Remember to disinfect all your lenses, be it 90D, 78 diopter, a gonio lens or a laser lens, because usually we forget to sanitize them. So we can use either a household bleach of appropriate concentration or a 2% aqueous solution of glutaraldehyde, which needs to be freshly prepared. When it comes to perimetry, the perimetry bowl can be a potential source of viral spread, and therefore it needs to be cleaned. But remember that if it is cleaned, it is going to cause a subminimal stimulus strength. So the Humphrey does not really suggest to be for the perimeter to be cleaned with the alcohol. The mask-induced artifacts mimicking inferior arcuate glaucomatous defects have also been seen. So whenever the technician is making the patient sit on the perimetry machine, they should make sure that the mask is properly placed. Patients wearing clothes or face masks have been found to have lower reliability parameters as compared to the surgical face mask, and that is because of the fogging that happens through the cloth face masks. Additionally, it's a good idea to seal the mask from the top, because this study recently, which has been published, shows that even if there is no visible fogging on the lens, if there is a tape seal, the artifacts are much lesser as compared to the one in which there is no tape seal. So visual field scores are improved with the face mask that is sealed. Portable options can also be considered if you are concerned about the infection of the patient through the infection of the perimetry bowl. One of the apps which I've been recently using is the Melbourne Rapid Fields app, which has a full glaucoma module and can be used on an iPad. This is a printout of one of my patients. This is the Humphrey printout, and a very similar looking printout on the Melbourne Rapid Field app. So during the COVID times, this definitely can be considered as an option. Additional option with this tool is that they have a telehealth module. So your patient can take up a perimetry test from the comfort of their own home using just a desktop computer, and then this test is mailed to the treating physician. Disc assessment, remember that clear pod, there can be fogging when you're using lenses very close to the patient's eye. So now we have these clear pod holders, which can create some distance between the lens so the fogging does not happen and you can have a clear view of the disc. Although there is no tool as yet for the patient to click their own optic disc photo and send it to their physicians, but now at this academy, there was a smartphone retinal imaging device wherein you get a decent clinical picture of the optic disc. So I'm sure this technology is not too far away. When it comes to imaging, many of us have moved to using imaging much more than perimetry in these times because it's easier to clean an OCT. But does that mean that we would be dealing a lot with the red-green disease? We just need to remember that whenever we are commenting upon the progression, we need to look at the signal strength of the previous test and of the test that we are considering now. And also we have to look at the motion artifacts. Localized RNFL defects have been seen in non-glaucomatous patients with COVID-19. So whether glaucoma patients who have had COVID-19 got their RNFL defects because of COVID or because of the disease progression is something that is still a gray area. But if we are observant about this fact, we can definitely pick up these changes in our subsequent follow-ups. It has impacted progression in this ARVO presentation. Nearly 40% of all patients had disease progression during the pandemic. So that's something concerning, and therefore we have to be very observant about the adherence of therapy in our glaucoma patients during these times. As has been mentioned earlier, that SLT can be considered for patients who are less likely to come to you. We can do same-day bilateral SLT, or we can develop a teleophthalmology protocol to somehow remind our patients to improve their drug compliance. Even the surgeries that we do have changed. Earlier, trabeculectomy was done much more often as compared to tube shunt, but now we know that the patients would not be able to come for a follow-up as frequently as they would pre-pandemic. So tube shunts, which require lesser follow-up, are the way to go, or we can definitely use a micropulse diode laser or a SLT. So as I mentioned earlier, this is a good time for all of us to develop telemedicine in whatever simplistic way we can and for our own setups, because that will not only help us in screening, but also in managing our elderly glaucoma patients. So with this, I would come to our conclusion, in which if we are checking intraocular pressure of glaucoma patients during COVID times, we can use both NCT or applanation tonometry, but we need to remember that these have to be disinfected after each use. And the patients should wear a mask, as well as the technician who's checking the pressure. Even for visual fields, the mask should be taped, and one should make sure that there is no fogging of the lenses. Due precaution must be taken whenever we are doing imaging not to over-interpret imaging and change treatment. When in doubt, be aggressive with therapy, set a reminder system to encourage compliance, and create some sort of telemedicine system, because we really don't know when COVID is going to be out of our lives. So thank you so very much for this opportunity.
Thanks, Dr. Parul, for taking us through the changes that pandemic has taught us and the way we should practice our glaucoma or ophthalmology now. Well, this has been a wonderful session. I'm very grateful to all the speakers, and particularly our chairperson, Dr. Madhurya, Dr. Nazrul Islam, Dr. Nadeem Bhatt, Dr. Tanush Dada, I think he's left already, and Dr. Imtiaz Ali, and all the speakers for taking us through this wonderful session. Actually, all the talks have been so much of a learning experience for me personally. I'm sure all the audiences would have got benefited through it. And thanks to SAO conference, Dr. Namrata and Shorba, thanks for taking us through this. And last but not the least, all the audiences who would be listening to us, thank you so much for joining us on this afternoon.
Thank you. Thank you.
Thank you.
Thank you,
Thank
sir.
you.
Thank you.
Thanks. Dr.
Thank you
Shubha,
very much.
thanks to you, Dr. Parul, Dr. Nadeem. Nice to meet you here.
Absolutely.
Thank you, Professor Nazrul Islam.
Yeah,
Have a
thank you very
wonderful
much.
Sunday. Bye-bye.
Thank
Thank
you.
you.
Bye-bye.
It was
Bye-bye.
wonderful meeting all of you as well.
Absolutely.
Let's hope we meet
Absolutely.
again.
Surely.
This is the advantage of COVID.
Yes, that's true. Distances become less.
We have finished well in time,
Yeah, or more or less,
so many
yeah.
speakers, but the whole symposium went so well and so smooth, and all the presentations didn't have any technical hiccup or anything. So organizers have done the great job. They have done their homework properly, and their technologists sitting behind the scene, they are working very hard to make this virtual conference a success. It's all technology based. So if we don't have good technologists and good technical support, it becomes very difficult to run these kind of activities. So well done, Dr. Namrata Sharma, Lalit Verma, Rajvardhan Azad, Madam Aba, and all the team of the SARC region who have been doing so much hard work for this symposium. Thank you so much, and greetings and goodbye from Pakistan.
Bye-bye. Thanks, Sabrina.
Bye-bye.
Bye-bye, sir.
Bye-bye.
Thank you. Thank you so much, doctors, for such an informative and wonderful talks and presentations.
Thank you.
Thank you.
Thank you.
I now
Thank you. See you
conclude the
again.
hall.
See you again.
Hi, sir.
Hi, Rohan. Hi, Sumit. Good afternoon, Dr. Azad.
That's a good afternoon.
Good afternoon, Samrit sir. Hi, Rohan.
Hi, sir.
This meeting is being recorded.
So all in order, Rohan?
Yes, all in order only.
Hmm.
Dr. Sonia will not be presenting. She had a
Okay.
family emergency.
Okay.
The rest of it is all in order.
All right.
I think we should finish by 3:30 and then we can have a short discussion. And
We have one additional talk, I think, by Dr. Azad also, that Kripala just sent to me on future of optic nerve regeneration. That
Listen, who is this? Is this Digvijay?
Yes.
Digvijay, I thought that this will be very relevant to all of you.
Oh, sir is here. Okay, yes, sir.
My basic idea is that you all are young people. You should not stick to what we call Hindi mein lakir ka fakir. You should go beyond, what is happening at the present moment. So that's why this presentation here. I thought this will be very useful and very inspiring, and also, it will help you to think in a direction so that you can make your own career, and I know that you all people are very talented people, and you should make use of your talent, not only in India but in international field of ophthalmology. So that was the concept, and that's why I thought that this presentation will be useful.
Certainly.
Yes. So this is a pre-recorded, and this actually I presented this yesterday. So I thought that it will be useful. So I took this. I barge into your session.
Any sir, most welcome, sir. So we'll begin with your talk,
please.
sir, then?
Yeah,
Yes,
please.
we'll do plan like
Please,
that.
it's pre-recorded. Yes.
Okay, sir. We'll introduce you to begin with. Then Sumit will come to you, and then Dr. Sumit will take it on from there.
Oh, sir, perfect.
And Sonia's not here, right?
Yeah, she won't be presenting.
Okay.
We'll wait for a few minutes and then we'll start with the session.
Rohan is here, Zen, Pooja, and okay. I think everybody else is in.
So Sumit is here.
Yes, sir. Good afternoon, sir. How are you?
Yeah, Sumit, how are you?
I'm fine, sir. I'm very fine. Nice to see you, sir.
All the young people here, and Pooja is also here. Pooja is giving a smile. She doesn't seem to be here.
Hello,
Isn't
sir.
it?
Good afternoon.
No, good afternoon. Good afternoon.
Good afternoon, doctors. Welcome you all to South Asian Academy of Ophthalmology Conference. To get started with our session, I would like the chairperson, Dr. Digvijay Singh, moderator, Dr. Pooja Mehta, and Dr. Rohan Mehra, to please switch on the camera. Over to you, Doctor. Doctor, you can take over now.
Right. Thank you. And welcome all of you to this youthful IRSI session at the SAO conference. We're really excited for all of us to be together and to discuss things which are relevant to the young ophthalmologists. And we have a special guest with us on this session. We have Professor Rajvardhan Azad. So he's going to give us a talk to kickstart the session, a talk which is talking about future in ophthalmology and optic nerve regeneration. And after that, we'll take our talks on in the same order as they are. And I'll hand it over now to the moderators, Dr. Pooja and Dr. Rohan, to take it over. And Dr. Azad, sir, we welcome you, sir. We're happy to have you as a part of this session. You've always been an inspiration for the young ophthalmologists, and we are eager to hear from you, sir.
Thank you so much, Dr. Digvijay, sir. And it's an absolute pleasure to be able to have this session on this platform. And it's a wonderful, wonderful surprise that Dr. Azad can also be included in this session. And I've had personal encounters with sir, and every single time he has inspired all of us. So I'll ask Dr. Azad to share his screen and we can start this session. And after that, we'll introduce each presenter as they follow.
I think to say what about
It's already
Professor Azad sir. Professor Azad
Yes,
sir has been the ex-chief of RP Center AIMS, and he's very well known in the global circle, not only the Indian or the South Asian circle. And I think all of us have known of him. He's headed APO, and he has made India proud and put India on the global map. So we're happy to have you, sir. And if you could proceed.
Can you ask them to start my pre-recorded, presentation?
Yes. Admin, can we have Professor Azad's presentation? Play the recording. Yeah.
This is a topic which I am going to, speak today is, little different, and it will create generate a lot of interest among the young people and also, our practicing fellows and our colleagues. Next, may I have the next? And I have to say that I have no financial disclosure. We all know that one of the most important part of our body is the vision. And loss of vision, not only creates a disability, but it has a deleterious impact on quality of life and individual's independence. And above all, it puts a heavy burden on the state exchequer. If we, talk about the optic nerve, we don't have any treatment so far. Currently, there's no treatment is available for loss of vision due to optic nerve atrophy or optic nerve damage or the retinal ganglion cell loss. And therefore, this is a subject which is not often discussed, but it definitely needs a lot of attention. What are the facts with us? The fact with us is that optic nerve is essential for vision transmission, and visual pathway is responsible for transmitting light and color. The question arises is, can we regenerate or transplant the optic nerve? And if you ask me the answer, the most unfortunate is that, like central nervous system, optic nerve does not regenerate, and once damaged, hence till date, there is no treatment is available for optic nerve damage, either due to glaucoma or due to injury or due to stroke or whatever reasons the optic nerve is damaged. But to say that is not the end of life. There has been a lot of advancement in the neuroscience. And we often talk about, the transplantation of heart. We talk about the transplantation of lungs. We talk about transplantation of liver, kidney, bones, and most of the organs can be transplanted, but not the optic nerve and not the central nervous system, or if you call precisely the brain. However, there has been a lot of advancement in neuroscience, especially in the last century. And if we go into the history, we find that optic nerve regeneration is a reality in the lab mammals. The experiments have shown that if you cut the optic nerve and if you just leave it, there is a possibility of, possibility of regeneration through the existing pathways. Experiments have also shown that if you cut the optic nerve and put a peripheral nerve in between as a bridge, the evidences are there that regeneration is possible. Also, in cases where there has been embryonic transplants or at certain level of central stages of CNS development, there is a possibility of regeneration of the optic nerve. Now, what are the challenges in optic nerve transplant or optic nerve regeneration? Regeneration is one step, optic nerve transplant is the next step. Okay, can we go back to the, can we go back? Yes. The challenges are that the origin of this optic nerve, the optic nerve is an organ specific. What I mean to say is optic nerve cannot be replaced by any other organ. And the donation at this point of time is basically after the death, after the brain death. We have to think whether we can transplant the optic nerve after the brain death. And then above all, the human retina only lives about 4 hours outside the body. So this is the critical time where we have to think of optic nerve transplant, but it is a far reality at this point of time. Now, just go into the chronology of events. The work which has gone into the optic nerve transplant, and in 1886, on May 17, and whole eye replantation and transplantation in 24 rabbits, and none of the animals regained vision, and 18 of these 24 eyes were lost. Then again in 1924, Kopany and Baker excised the eyes of European toads and replanted them into the same eye socket. A skin color adaptation, which is usually visually stimulated, returned after 8 weeks. So there was some ray of hope that it is a possibility. In 1930, Stone exchanged the right eye of 41 pair of larvae of Amblyostoma punctatum and A. tigrinum and tested vision planted eyes in 3 of the pairs by removing the contralateral eye. Contralateral eye was removed, and all 6 of the animals tested demonstrated functional return of vision in the transplanted eye. So this means that there was possibility of regeneration or transplantation of optic nerve. Now, the first xenotransplant was done in 1885. Dr. Chebret removed the staphylomatous eye of a 17-year-old girl and placed a rabbit eye into the empty conjunctival sac. And as it would have happened, the transplanted organ perished by the 15th postoperative day. The first human transplant, cadaveric donor human transplant, was attempted in 1969 at Methodist Hospital in Houston. The cornea, lens, and iris were transplanted, but it failed to restore the vision. Next. Go to the next, please. And I will take you to this experiment, which is very, significant in the sense that this experiment, made us to think that optic nerve transplant is possible, because frog is an animal which is more or less akin to our experimental, study animals. And in this, Roger Sperry did an experiment. He rotated the one eye to 180 degrees without disturbing the blood supply. And he removed the contralateral eye so that from the contralateral eye, the inputs do not go. And when the objects were presented in various quadrants of the visual field in front of the frog, frogs consistently aimed for the quadrant opposite to the object, which means that the experiment which Roger Sperry did to some extent was successful, in the sense that the optic nerve could survive even after, cutting the, the optic nerve. So this is very significant. Now, what are the challenges in optic nerve transplant? The challenges in optic nerve transplant is, first is the retinal ganglion cell survival. The second is the axon growth and the guidance. If the retinal ganglion cells has survived, then the axon growth has to be there, and it has to be guided also. And the third thing is control the target selection, where it has to go. And the fourth is the synapse formation. And the fifth is the circuit integration. These are the challenges in the optic nerve transplant. And if there is a obstruction to the blood flow, or the blood vessels have been cut, then establish the blood flow and then control the immune system, because the immune system has to be controlled as we control in other kind of transplants, like kidney transplant or heart transplant. The immune system has to be put to, at the required level. Now, what are the evidences we have available? We have the evidence available. If you cut the optic nerve and without surrounding damage to the, the central retinal artery, the peripheral nerve can be connected to the optic nerve head or directly into the retina. If you join them with appropriate growth factor, the ganglion cells survive the effect of exotomy and regrow and extend external growth. These are very significant evidence which is available, which says if you cut it, peripheral nerve, and if you connect them, straight into the retina or to the cut end of the optic nerve, and with appropriate growth factor and ganglion cell survival, the effect of the exotomy and regrow and extend axonal growth, which means the axons can regrow if the appropriate growth factor is there, which means if we give the proper environment to the optic nerve, the possibility of optic nerve regeneration after transplantation is possible. Shall we go to the next? Now, what is the important breakthrough? I have told about 5 factors. One is retinal ganglion cell survival. I have told you the axon growth and the guidance. I have told you about the direction of these optic nerve. Then fourth, I have told you about the synapse formation and the circuit formation. If you combine all these steps, 40 to 70% of the optic nerve fiber regenerate from the eye wall, from the eye and go into the brain at the age of up to 2 weeks after birth, which means that all these steps are done when 2 weeks after birth, when the nerve fibers from eyeball are going into the brain. This is the time when nerve growth factor inhibitors are already appeared in the mouse brain. So if at this time, if the nerve growth factor inhibitors are not there and we have the nerve growth factor, promoter growth factors are there, then possibility of regeneration is there. If 4th and 5th factor are also overcome, optic nerve injury damage can be regenerated and is a future possibility. So this study was done in Skippen's Eye Research Institute, and this was the inference which was drawn. We did a study when I was a visiting professor in Zhongshan Ophthalmic Center in China, and I was leading this project, and I am very thankful to Professor Yuzi Lee, who permitted me to do this project, and he gave me $5 million to do this project. And what we did was, can we have the next? What we did was we disconnected the optic nerve, and the reconnection of optic nerve we did, and after transection of the whole nerve and the suture, and after preserving the optic central retinal artery and also the other vessels, we try to we try to preserve them. Next. And then we did the OCT, and we also did this flash VEP, and we found that the flash VEP in the left eye and the left eye, if you can see the response was there, even after the optic nerve was cut, and after say 4 weeks, we found that the response in VEP was present. We showed that, can we go to the next? which meant that there is a possibility of optic nerve regeneration because the optic nerve, connected and the response was available in the VP as a VP response. Now, what is important is we have to identify the barriers to the optic nerve regeneration. And one of the, what are the barriers? The barriers, regeneration, if we have BDNF or brain-derived neurotropic growth factor, this can prevent the ganglion cells from going into apoptosis. So with this growth factor is very important. This will prevent from going into apoptosis. Then the next one is chondroitin sulfate proteoglycan and expression within the glial scar antibodies for inhibition of oligodendrocyte developed. So this is also a very important because this will prevent the glial formation. Next. We also have the promoters. We have the promoters like beta tubulin messenger RNA in ganglion cell. This is for ganglion cell induction by some growth factor. And this is the beta cell lymphoma 2 proto-oncogene. This is important for ganglion cell regeneration. So these two are very important. And then matrix metalloproteinase 2 is identified as a molecule essential for regeneration to foster a receptive transplant environment in eye and CNS tissue. By this, I mean, if we give proper environment in the form of the promoters of optic nerve regeneration, as I have mentioned you here, the possibility of optic nerve regeneration is there. It very much exists. Next. Now, when we consider the most suitable animal model, the primates are the most suitable animal model. And because the microvasculature of optic nerve head in rats is similar to the primates, and strains of rats, with pigmented eyes, such as brown Norway, might be a better fit for studying optic nerve transplant and testing such as non-invasive ocular imaging, electrophysiology, and a slit lamp examination can be easily performed in the rodents. And therefore, this animal is most suitable. And in addition, behavior studies to assess function are well established in the rodent. So if we want to, see the results in the form of behavior, I mean, how the animal is behaving, whether he's, seeing or not, his visual assessment, and other functions can very well studied in the rodents. And therefore, these animals are very, suitable for this study. So this study I did in, Johnson Ophthalmic Center, Guangzhou in China, where I was a visiting professor for 2 years, 2015 and 2016. And later, I have submitted a project to the Indian Council of Medical Research, and the research project has been approved. Basically, the research project is about this optic nerve regeneration, where we have 3-4 factors. This optic nerve growth factors, and we have 6 groups. One group is control, the other group is the normal, the other group is one nerve growth factor, the other one is another group nerve growth factor, the third one is another nerve growth factor, and the last one is the combined of 1, 2, 3 growth factors and the study animal. So this way we have submitted the project. The project has been sanctioned, and very soon we are going to start the study in Regional Institute of Ophthalmology in Indira Gandhi Institute of Medical Sciences in Patna. So this is the progress of this project, and I'm going to take it further. And once I have, maybe another year or maybe year or two, we have some results, I'll come back to you. And, it is a very exciting, project. And if something comes out, something positive comes out, as it seems, as we can see here, then, this will be something, a great, work, and it will be, a big contribution to the, ophthalmic community. We have the next. Thank you very much for giving me this opportunity. And this is a topic which I am going to, speak today is, little different. Yes.
That was a very nice presentation, sir. And as a neuro-ophthalmologist, that always excites us to know that, something more is happening. Potentially, very often we have to, tell patients that there's no other way around, and maybe the future holds something. However, of course, all this, as you said, is still a long distance away in terms of still in the rat models only. But overall, sir, in the study that you did at the
actually this is being done in other places also, in Pittsburgh in US, also in Skippens Eye Institute, and one or two places in Japan. People are trying to look into this, and they are trying to see if the retinal ganglion cells, they survive. Like we are doing this study, this is basically in vivo and in vitro study both. What we are going to do is we are going to take these, these mice, and the 6 groups are there, and in each group there are 6 mice are there. So, and then we are trying to, see the response of the, the nerve growth factors, and then, see the result and all that by doing, and we are going to purchase this Micron 3. Digvijay, you must be knowing Micron 3, which has got OCT and the angiography together. So we'll be able to, do both together, and we'll be able to see what is the response after, this cutting the optic nerve and then using the nerve growth factors. So this is one. And the other one is we are going to take out retinal ganglion cells is available outside, and pigment epithelium is also available. So we will do an in vitro study. The in vivo study I told you, the other part will be the in vitro study. So let's see what is the result, because this is very ambitious, as you rightly said. This is just the beginning. Even if we are going to, even if we show that either of these growth factors or combination of all the 3 growth factors, they are helping in regeneration of the optic nerve, then I think this will be a big contribution to the global community. And, although it is too far, maybe, but then, this will be something which is out of the blue. This very fairy tale, project.
Right, sir. All the best for this, sir, I think. And thank you.
Thank you. Any other question? Anybody has any question? मैंने जान के यहाँ पे रखा है कि आप लोग stimulate हो. You should be stimulated. You should take up, such things. I have a lot of things in my mind, but you should take up these things. Because, you have a long way to go, and you will be, you people will be there, to, bring out new things and all that. That was the basic idea of coming here. I told Namrata that you please keep this talk here so that people are, stimulated. I hope you are.
I'm sure, sir, that they all are. Thank you so much, sir.
Thank you so much. Thank you very much. Namrata, thank you so much. If there are no questions, then I will leave.
I'm sure, so there'll be lots of questions. I think people can get in touch with you directly, or somebody who's
okay. Thank you. Yeah, you can ask me anytime. No problem.
Welcome Dr. Namrata Sharma, ma'am, who's
joined into
the session, ma'am, and welcome. And I think it's great to have you here.
Thank you, Digvijay. And I think you can continue with the session, and maybe we can extend a little bit on the next session. I have just talked to them and made them aware of this, because this was not there in the earlier. Okay, so carry on.
Thank you. Thank you so much, ma'am.
Over to Rohan Puja.
Yeah. Thank you so much. So we'll start the Youthful IRSI session now. First, it's my honor to introduce Dr. Sumit Lahane, who is an assistant professor at Grant Medical College and Sir JJ Group of Hospitals in Mumbai. He has done his fellowship in oculoplasty and oncology at Center for Sight, Hyderabad, and a cornea fellowship at Narayan Netralaya. He currently mentors many youngsters and pushes them to succeed and excel. And no one better than Sir to talk about his experience in pushing residents to clear more than one examination during residency. Over to you, sir.
Very good afternoon, everyone. Thank you so much, SAO organizers, Dr. Digvijay, and of course, Rohan and Pooja for including me in this session. And again, it's very honor to present in a session where Azad sir has presented and started the session. So I'll be talking about basically my experience in pushing your residence and residency via exams. Now let's start with I have no financial interest here. Disadvantages of doing all this. Very first is economical concern. Again, not all the PGs are from the same background, and many times I have faced this that they say that there is a problem in paying a fees for a certain exam, especially the international ones, and they don't want to do it. Then there are different goals of setup. Then I have people, few of them who are from uh, army colleges and few are from the rural setup who wants to go back to their own thing, and they keep asking me questions that I don't want to do any abroad fellowship or don't want to settle there. Then why do you want me to give this kind of exams? It's a very valid questions, and again time consuming for a few of them who feel so. So starting with the disadvantages, moving on, when I have to tell them, this is the advantages which I see, which I have seen in last few years. I have been mentoring my students. Basically, we'll come back to this slide after we finish all the slides again. So the first thing is basically we invest our 3 years in studying for our mastery in ophthalmology. It could be DNB, it could be MS, FCPS, whatever. So we end up investing 3 years and getting one degree. My question is very simple. What is the harm if you invest your 3 years and get 2 or 3 degrees? It is going to be a good experience in your curriculum, and it is going to be a certain thing that you will take back, and in the same amount of time getting a more degrees is not a bad idea at all. Then what is other advantage? Again, after finishing residency, we do have lot of options what to do. Can we join a corporate hospital? Do we want to go for fellowship, or do we join a government hospital straight together, or we want to start our own setup? And if at all we want to go for a fellowship abroad, do we have enough grants, or can somebody give us grants? So giving certain exams of course opens certain other ways for us, especially going for a fellowship abroad. We have no new doors open by clearing few of these exams. So of course you open new doorways and you have more opportunities when you give such kind of exams. Very important aspect from my, for which I started pushing my residents for this, is that they do study when there is an exam coming. This has been from the school that we have been taught there is an exam and then you need to study, and we need to study to excel in the exam. This old concept which is there in our mind is never gets cleared up, and we don't study when somebody tells us to study unless we have an exam to prove ourselves, or to get a pass mark on the result paper. We do study. So important aspect from my side is they do study when they know there is an exam next month which they have to excel in. Reading between the lines. This is what I experienced when I was giving the exam. That when we read generally for the theory or to understand the subject sometimes. That I have certain questions. Nowadays, everything, including DNB, has a question bank, and we know what portion is important out of the textbook. That was a good idea till we were in MBBS or 10th or 12th standard, but not when you are doing masters in any subject. Leaving something for the option during 3 years of residency just because it is not asked in the exam is not good idea at all, I feel. So when we read, we underline certain things, but we do miss out. There are certain important facts. Most of these exams are basically OSCE based, or these are MCQs, and those are conceptual exams. So you do read between the lines when you want to prepare for the exam. Specifically, you understand a topic and a subject better when you want to read it for a certain question oriented or exam oriented time. This is just an example that one of the exam that we give during residency, the International Council of Ophthalmology. Giving this exam has its own advantages. Of course, there is dispute going on, but still clearing your 3 ICU exams gives you some doorway or some shortcut to give your FRCS when you want to give it later. And of course, ICU has its own fellowship program for which they do give grants. So when you want to apply for a fellowship abroad, the ICU is one of the doorways that opens for you, and post residency you have more options to go through the ICO fellowship program. So that's why giving this ICO exam step by step is again very important aspect of your residency, which should be aspect of your residency. Another advantage is you have something to add in your biodata, because you will be going for a fellowship or you're going for a job. They are going to ask you how are you different from rest of the 10 candidates who are here for the interview. Of course, having a degree, the front person knows that this guy is some additional degree and he has put some extra effort than the others to get it in its CV. So of course, adding something to the CV is very important. So having this again, one of the thing, like you do your FRCS not during residency but later, just walking on the path and getting your degree at the FRCS venues, of course, could be fascination for some, and this is again I will put as a advantage of giving these exams. I went through some literature while I was preparing for the presentation. I realized the studies have been done to know what is the status of your postgraduate study, and the conclusion for most of them were the same, that on the whole, the students still felt the need for the improved training across all aspects of ophthalmology. And of course, they did study that what are the aspects. They did ask questionnaires, that there were workshops taken, and the students gave a feedback that there is a PowerPoint lecture, wet lab, case presentation, video library. Everything is very important in their curriculum, and that will basically help them to learn better in their residency. Now, covering all this point as a feedback, as a part of the questionnaire is very important, and they should be the part of their curriculum. But we forget the most important thing, the value of the self-study. We do forget the story of Eklavya. We are there as a mentors and teacher to guide you in each and every aspect of your residency. But we will not be able to teach you if you are not ready to learn. So the self-study plays a very important role, which is missing out of all the studies that have been done. Goal of the teacher basically should to motivate your students to make them ask questions, like Azad sir in his presentation, he asked us that do you have any questions. Of course, you need to motivate the younger generations who are coming, and tell them that they need to read, they need to get inspired. Unless you ask questions, you will not be behind finding their answers. So the important aspects for us as the teachers is to motivate our students so that they read and not only listen to us. We do take exams in our college, and we do display the results to the students, but again those are at the local level. They do motivate them to read, but having a competition, worldwide competition, is not what they realize when they are giving exam at the local place. So when they have to go back and they finish their residency and go back into the real world, they do understand that there is a competition outside, which is they were completely unaware about during their residency. Giving such exams is again advantage, which exposes them to the world, and they know that they have a tough competition outside. Before concluding, I will go back to the slides where I want to put those advantages in summary. So basically it's about go back to a structure and a conceptual reading, like I told you, reading between the lines. Know and retain things better, because most of the things, like even in the presentations we see nowadays, some senior doctor is presenting, and we sitting in the delegates basically take pictures of those PowerPoints instead of taking notes. And I don't think so anyone of us hardly opens those photographs and see what was being told in a lecture. So we don't retain things. Of course, it's a CV addition. International certificate is basically a door for a fellowship, a national or international. Of course, there is a grant access. There is increased interest in the subject, because students do read for the exams, and now they know better what are they seeing in the OPDs and OTs. Realization and utilization of the time, like I told you, in 3 years instead of 1 degree, if you are getting 2, what's harm in that? Thought exchange program is what I want to stress upon. Is we keep talking about residency exchange program, but in reality hardly it happens. But when the students go for this exam, of course they do happen to meet students from the other colleges, and then there is of course a thought exchange program, and they know that what is going on in the other institute, and the idea then being shared. So this is very important exposure to the other college residents. And of course, it is contagious to the next batches. Once the one batch has given, the next batch is feel, so that it is very important for us to give, because it becomes a part of the curriculum and not an addition to the curriculum. So just to conclude, 3 years are not only for the residency, but it's basically a comprehensive fellowship. Orientation is always earlier the better. Instead of coming into fellowship, if you get that in residency, it is going to save your time. Teaching and lectures are basically inputs, while the performance and the written knowledge are the early output measures of the residency and the students, which we should measure somehow. Self-study and motivation for the same are important, yet the neglected part of the residency. An exam should not be taken just for the evaluation. These are basically tools of teaching and not just the door to exit. I would like to thank all my students who dedicatedly work with me, and they try to learn and explore the world of ophthalmology. Again, I thank organizers for giving me an opportunity to present in front of this forum. Thank you again.
Thank you so much for the wonderful talk and so much inspiration to all the young guns who, don't know where to go ahead with in residency and whether to give an exam or not to give an exam. We have our next speaker. I would like to introduce Dr. Rohan Mehra. He's done his fellowship in phaco and refractive surgery from Narayan Netralaya, Bangalore. He's the medical director at the CKI Institute in Saranpur, consultant at the Vision Eye Center, Mumbai, and co-founder with me of the Youthful IRSI. Over to you, Dr. Mehra.
Thank you. Thank you so much, Dr. Pooja. And without further ado, I'll share my screen. And so I'm going to be, I have no financial interest in the subject matter of this presentation. I'm going to be talking about staying afloat in private practice as a beginner, how to invest wisely. So I've on purpose put this slide as the first slide, staying afloat in a rapidly changing industry. So our industry, the ophthalmology industry, is an extremely rapidly changing industry, and we have to stay up to date all the time. There are changes coming in every 6 months. There are changes coming in all aspects of ophthalmology. Take, for example, the phacoemulsification machine itself. Started by Kelvin in 1969, and now here we are 50 years later. There have been so many advancements, and there have been so much changes in the fluidics. Along with that, of course, it brings in a huge cost. Take biometers and the timeline for that as an example. We had the Bosch and Lomb keratometer, then we got into the contact biometry, the immersion came in. And then once the partial coherence and the low coherence interferometry came in, we thought this is the final frontier. This is a no-touch technology, optical biometry. Just when we thought that this is the final frontier, therein came the swept source OCT, and which is now considered to be the latest and the gold standard in biometry. So all these things, they come in with a cost. So as a beginner, we do not have that much of backing or that much of confidence to invest in machinery, which helps us in getting us outcomes. So it is a vast world waiting outside. I've on purpose put this photo, the man walking through this door only to find that the ocean is on the other side. And it is a vast world. We can't do everything. One person will not be able to do everything. So you've got to manage your finances extremely wisely. Managing money is an art, and in order to get the best out of it, we have to spend wisely and spend smart. By that, I mean all your basics should always be in place. But when it comes to high-end equipment, high-end machinery, you have to be smart. You have to always calculate your revenue per minute. So why I talk about revenue per minute is because if you look at all the big multinational companies, they have also started calculating the revenue per minute rather than calculating it per month or per year. The reason behind this is that nowadays it has all become mostly an appointment-based system. Everybody has fixed timings. You have to maintain a balance between your life and your family life. So gone are the days where you would be sitting from 8 o'clock in the morning right up till 10 o'clock at night and waiting for patients to come whenever they walk in. Now you have to basically manage your time well, give appointments according to the time that you have so that you can maintain your balance with your family. Always and always, we had this lecture by Dr. Mohan Rajan in the recent IRSI, and he spoke to us about return on investment. And he made some very pertinent points wherein you have to invest not according to what your neighbor practicing ophthalmologist has invested in. If somebody has got a new machine, they must have done their calculations and thought that they'll get a return on their investment. It is highly possible that you will not. So you don't have to get under that peer pressure and invest in a machine which costs a lot and your return on investment is not there. So these are the things that you get into that trap of EMIs, paying off those EMIs. So you stop working for yourself and you start working for the company. So return on investment has to be calculated prior to investing into a machine, and always your return on investment should be calculated at at a lower end, as in you should always calculate it in a negative. Whatever you get on top of that is always a positive. So money flies. So for example, we have had experiences with ophthalmologists investing in equipment and then struggling to pay EMIs out of that equipment. So Dr. Mohan Rajan also made a very valid point the other day when he was talking to us. He said that you have to make sure that that particular machine pays for itself. Even if you're not earning, you need that machine, of course, to give good treatment to your patients, but that machine should earn from itself. So Make in India, we have got a push from the industry now. Thankfully, our Indian industry has picked up and we are making a lot of machinery, a lot of lenses, medications, all in India, and they are at a reasonable price. So always look at the Indian products before you go ahead and buy the expensive machinery that is offered to us by the multinational companies. And now, especially companies like Appaswamy, they've all upgraded all their machinery. A personal example that I'd like to share, we had to upgrade our YAG laser. We already had about a 15-year-old Appaswamy YAG laser. We looked at all other options. And then we went ahead and we took the Appaswamy YAG laser itself. And it's wonderful. They have upgraded the machinery. It is a step up from the previous laser that they had. And it did not, put a hole through our pocket also. And at the end, always the ABCD of practice: availability, behavior, competence, and documentation. This documentation has become very important nowadays with a lot of medical legal problems that people are facing. So you have to be available in your practice. Your behavior towards your patient always counts, competence, and then documentation. With that, I'll end my presentation. Thank you very much.
Thank you so much, Dr. Rohan. Do we have any questions?
I think that was a great talk, Rohan, and you brought about all the points pretty well. I also would suggest, for anybody who's buying big equipment like lasers or maybe phaco machines, to talk to the companies and try to go and see them at their centers where are being used, and be upfront and frank in asking questions to the consultants, because we must understand that we as peer owe it to us, our colleagues, to tell the honest truth about what is happening. Because if we don't support each other, and this is something we need to learn at a very young age, we need to be very upfront and honest about what is performing and what is not to each other. But great talk. I really enjoyed it.
Thank you.
It's my pleasure to invite Dr. Zaim Khatib. He's a private practicing ophthalmologist in Mumbai, working primarily at the Khatib Eye Clinic and a visiting consultant in multiple hospitals. He's completed his MBBS from KEM Hospital, Mumbai, and MS Ophthalmology from KIMS Hubli. He's also cleared his DNB and FICO exams. He is well trained in phacoemulsification and anterior segment surgery, having completed his long-term fellowship from Lakshmi Eye Institute and a short-term observership in the Advanced Anterior Segment Surgery from Moran Eye Center, USA. His area of interest includes phacoemulsification, refractive surgeries, glaucoma, and neuro-ophthalmological. Over to you, sir.
Thank you, Dr. Pooja and Dr. Rohan, for inviting me to be part of this session. So my talk today is going to be on current trends in biometry. There are a lot of points to discuss with respect to biometry. We all know that it has become something really important in cataract surgery today. But I'll be dividing my talk into three important aspects pertaining to biometry. The first part is regarding the axiometry, which is the axial length measurement, anterior chamber depth, pachymetry, and so on. The second part is about the keratometry. And the third part is about the ELP prediction, or rather about the formula being used. So we all know the year 1999 revolutionized axiometry because we changed from ultrasound contact axiometry to contactless optical biometry, and Zeiss has to be credited for this by introducing the IOL Master 500, which was the first optical biometer. So when the IOL Master 500 was released, they used something called as partial coherence interferometry. So all the optical biometers work on the principle of interference, wherein a light is reflected through a mirror and then passed into the eye, and both the interference pattern from the eye and the light are then detected by a detector, and we get an interference pattern to find the difference between the distance between two structures. So the IOL Master 500 partial coherence interferometry used a light source called as MMLD, which was 780 nanometer. And as you can see, it didn't have a smooth waveform, but it had multiple peaks around the 780. The second thing about this technology was that there were two mirrors. One was a fixed mirror and one was a moving mirror. So both these mirrors together were used to create the interference pattern. And ultimately what we got were signals like this, where you can see you can't really make out the spikes properly, where exactly you get a good spike. So in other words, the signal to noise ratio was very low. The noise was high, signal was low. But the software had its own technology by which it took multiple of these patterns and it could eliminate the noise from the signal. And with multiple readings, you could get a peak like this. But this software came at a cost because you had to use this software to differentiate the signal from the noise. You could only use it for one particular distance. So that distance was from the anterior surface of the cornea to the front of the RP. So we only got axial length by this technology. After this came the Lenstar LS900, which was which was based on a technology called as optical low coherence reflectometry, OCLR. And here you can see the light is a superluminescent diode of 820 nanometer, and it has a smooth waveform. And here we had only a single reference mirror, which was movable, not two mirrors. And as a result of this, the interference pattern which was created was much more precise as compared to the partial coherence interferometry of IOL Master. And the final spectral interferogram was then Fourier transformed to give us a signal. And because of this technology, we could actually measure distances between multiple structures. So we got the anterior posterior surface of the cornea, anterior posterior surface of the lens, and the retinal peak. So we could measure things like pachymetry, anterior chamber depth, and lens thickness, all using the axiometry. So because of this, we could integrate newer formulae like the Barrett formula using the technology. We know that it uses the lens thickness as well. So a lot of machines were based on these technologies, but today, okay, what are the advantages of the OCLR Lenstar technology over the PCI is that there's much lesser noise. We've discussed that, and we could take all the readings as well. But the drawbacks of both these technologies were that it had poor penetration through dense cataracts and posterior subcapsular cataracts, and it had a slower scan speed. So today what we have, which is kind of, pushed away these other technologies, the swept source OCT technology, whereas the light source is a tunable laser. So swept source means that the laser actually sweeps across the entire wavelength in small parts. So as a result of this, we have extremely fast speed of scanning, and it can be done through the even most dense cataracts, which is something which is really important. And as far as I know, we have 3 machines available in the market today which use swept source technology. That is the IOL Master 700, the Tommy OA 2000, and the Heidelberg Antirion. The OA 2000 and IOL Master 700 are pure biometers, whereas the Antirion actually is an anterior segment OCT along with a topographer. So that was about the axiometry part. Let's go on to the keratometry part. So one thing is there that most optical biometers, whichever technology they use, they are all extremely accurate in measuring axial length and comparable also. But measurement of keratometry is where most machines differ, because each machine will measure a different zone with different number of points and different methods. Let's just study how exactly the different machines work for keratometry. So there are machines which measure only the anterior cornea, and there are machines which measure both the anterior and posterior cornea. The ones which measure anterior cornea, actually, what they do is that they modify the refractive index of the cornea from 1.376 to 1.3375, and this modification helps negate the value of the posterior cornea. And the ones which measure both anterior and posterior cornea, they keep the refractive index of both the same and actually measure both of them. So the machines which measure only the anterior cornea, the ones which are based on corneal reflectometry, IOL Master 500, Lenstar, Nidec AL scan. So the initial machine of which was IOL Master 500 measured only 6 points at 2.3 mm zone, which was not ideal. The Lenstar, which came later, actually measured 32 points in 2 zones. And the Nidec AL scan, I think, which is which has more accuracy, actually measures 256 points in 2 rings of zones. So these are all basically evolving technologies how the keratometry could be made more accurate. Then we have other machines which do keratometry based on Placido disc system, that is the Tommy OA 2000, which is just does a 5 mm topography, and the Topcon Aladdin actually does a full topography. So if you look at the Tommy OA 2000, you get 9 Placido rings, and you can get keratometry at the 2, 2.5 and 3 mm zone. 2.5 is what is recommended for lens power calculation. Machines which measure both anterior and posterior cornea, you have keratometry based on shine plug principle, which is seen in the Pentacam AXL. Again, Pentacam we know is a time-tested topographer, and AXL is something which is an added-on biometer machine. But again, that works on partial coherence interferometry and not swept source based. And the ones which are based on OCT are the IOL Master 700 and anterior. Now, do you actually need measurement of both anterior and posterior cornea? So for years, measuring only the anterior cornea was done, and all our modern formulae actually are based on this principle. So for routine cases, I don't think there's any issue at all for biometry part in measuring only the anterior cornea and modifying the refractive index. Where the machines which measure both anterior and posterior cornea actually work are in post-LASIK eyes, whereas the refractive index modification is not valid here because we are changing the relation of the anterior to posterior cornea. So in post-LASIK eyes, definitely measurement of anterior and posterior cornea is required. Some, there is a debate on whether measuring the both anterior and posterior cornea actually helps toric lenses because of posterior corneal astigmatism. I have not really felt that this actually holds true, and the Barrett study itself proves that with the nomograms we have for the predicted TCA giving better results than the measured TCA. Actually, for toric lenses, you don't need a machine which will need to measure the posterior cornea. So according to me, when you're talking about keratometry, the most important thing is which machine measures the keratometry fast, because we know that keratometry is most sensitive to tear dynamics. If you do it for a longer period of time, the result can change. So just sharing 2 videos of the fastest machines that we have. So this is the IOL Master 700. You see the keratometry is getting measured now. It's taking few seconds. And yes, that is done. So that was the keratometry measurement, pretty fast. If you look at the Tommy OA 2000, you just focus on the center and just have a look. So that fraction of a second when the Placido rings came, that was when the keratometry was measured. So we see how fast it is. So according to me, the faster it is, whichever technology you use will give you a good result. There's another thing called as telocentric keratometry, which the IOL Master machines follow. That is, the distance of the machine from the eye actually in normal machines would alter where the points are on the cornea. But in the IOL Master machines, whatever be the distance you measure, the points will be at the same part measured, at the same ring, the points are measured. So that is something which also helps the accuracy of keratometry. So coming to the third part, that is the formulae. So we have regression formulae, which we all know. These are time tested. Then the most popular formula used today is the Barrett Universal 2, which is a combination of both theoretical and regression. And we have a lot of newer formulae nowadays. So the Olsen is based on ray tracing. The Hill RBF is based on artificial intelligence. We have version 3 right now. The EVO is another theoretical formula, and the latest one right now is the Kane formula, which is also based on artificial intelligence. Now, why is the Barrett time such a popular formula? There are two landmark studies which actually show the supremacy of the Barrett formula. So this one by Kane et al. In the JCRS compared these regression formulae with the Barrett universal, and the results clearly show that across the range of axial lengths, the Barrett actually outperformed all these other formulae. So this was one landmark study. This is another one by Mellis et al. In the American Academy of Ophthalmology, studying 13,000 eyes, which again compared these formulae along with the Olsen. And in this also, you can see the mean prediction error for the Barrett is closest to the 0 mark. Olsen is also pretty good, but you can see Olsen is going slightly hyperopic, but Barrett and Olsen seem to be outperforming the others. And the other formulae like SRKT and Hoffer-Q and all are also with the Wang-Koch modification. So in spite of having the Wang-Koch, Barrett outperformed them. This is one of the latest studies because this is the newest study which has tested the new formulae like Hill RBF and the Kane formula. And this particular study from JCRS studied 10,000 eyes. And here, contrary to most other studies, the Barrett is being placed at the 5th position. And this study very categorically states that the Kane is a more accurate predictor of post-op refraction compared to all others. So why did something like this happen? If you look at this study carefully, they have not put in details of crystalline lens or white to white. And we know very well that Barrett being partly a theoretical formula, without the crystalline lens thickness or white to white, you won't get that good and accurate result. So it's important to study yourself and see your results. This is one of our studies which is under publication, which was comparing the SRKT, Barrett and Kane. And we can clearly see that Barrett outperforms the SRKT and Kane both. And you can see here as well, the percentage of 0.2 and 0.5 is more in Barrett as compared to the Kane. So this is under publication. This is one of the studies which we have already published again between Barrett, EVO and Hill RBF version 2. And it again shows that the Barrett performs better than the other two. So ultimately, Barrett, I would say, is a very accurate formula. It can be safely used for all axial lengths. The biggest advantage is available on most biometers now. Olsen and Hill RBF version 3 also are good, but they are only available on Lenstar. And the Kane is very promising, but only available online. Barrett also is available online on the APACRS website, and it has a series of calculators for different conditions. Just to summarize what I discussed, if I would buy an optical biometer today, the desirable features would be I would need a biometer which gives me reliable axiometry, and the swept source as the best ones today. Swept source are going to take over the others very soon. I would buy a biometer which would have a quick keratometry more than anything else, and a calculator which would have the Barrett formulae, preferably Barrett Universal and Truque, but preferably Toric also. So thank you. And this is the newest Lenstar, which is also coming with a swept source technology. So swept source technology is here to stay. So thank you.
Thank you. Thank you very much, Dr. Zain. Covered all aspects of biometry very well, including the formulas. So would you now say that the Barrett's formula is the go-to formula for all eyes, whether it be short eyes or long eyes? Is that have we reached that stage that we don't need multiple formulas anymore?
I think we have reached that stage quite some time back. But besides the post-refractive surgery eyes, I think Barrett is definitely accurate compared to the others. But having said that, the formulae which are based on artificial intelligence, like the Hill RBF, are constantly evolving. So every time they come with a newer version, their data set in bounds becomes better. So definitely artificial intelligence formulae are here to stay, and they may overpower Barrett in the coming days. I think right now Barrett is as accurate as any other.
Thank you. Any questions from the panelists or the chairperson? So any questions, or we'll go ahead with the next?
I think very well presented. Let's proceed.
Right. So next we have Dr. Pooja Mehta. She is a consultant at CKI Institute in Saharanpur and a consultant at Vision Eye Center, Mumbai, also the co-founder of Youthful IRSI. And she will be talking to us about expression, articulation, and counseling.
Thank you so much for having me here on this panel. My topic for today is keys to success, expression, articulation, and counseling. We know that 100% or 99% of our practice is all about communication. What is counseling but? Influencing the behavior of a prospective customer's purchasing capacity. And who are the customers? Are the patients. Prospective to have a diagnostic eye condition and a purchasing decision of what treatment options are available. And influencing is B, helping the patient to make a choice. So we need to go ahead and from time to time do a self analysis of our clinic of exactly to see what is it that we are doing well, what is it that we could be doing better, and what are the opportunities that have been missed in the past few years. So comes communication. As we know, 90% of our practice depends on our communication skills. It is starts from the minute the patient walks into your clinic. The patient notices your body language when you walk up to the patient. So believe in your mind, body, and soul, because that is what is going to convince the patient. Remember, in today's day and age, they've researched all about you and their condition on the internet. They've just come to see your confidence level and indirectly take your interview. So there are three main parts of counseling, which is expression, counseling, and articulation. Sometimes as young ophthalmologists, we come across questions in our head saying, how will I win the trust and confidence of the patients that walk into my clinic? I have just started out. But remember, we've just finished our education. So we do have a good database, good knowledge base in our head. Be confident in your talk. Be true to yourself. It will show to your patient. Listen more to the patient. Patient comes with a good amount of complaints. Listen to them so that if you listen to them, you can probably convey your message more clearly to them. Understand your patient's psyche, from where they are coming and how and what they are thinking in their head, so you can talk to them in a way that they'll understand better. Smile often, give them the confidence that yes, you are here for them and you're going to help them come to a good solution for the problem that they've come to. Try and giving as much chair time as possible. I know it's not possible in a busy OPD, but to give more chair time, it makes the patient definitely happy. Having a positive attitude also definitely helps. Show some empathy, and of course have a very good body language. We also come across how to deal with unhappy patients. So again, I would say listen, listen, and listen. That's the first and last important thing, that listen to the patient. Have and show empathy. Reassure the patient that there is not a problem that cannot be solved. We are here to help you and we will solve your problems for you. Have humility, have patience. Tell the patient that, okay, you've come here, give me time to analyze the situation and we'll come across a suitable solution for yourself. Counseling. Try to win the trust of the patient. When the patient comes to your OPD, we get the paperwork before done by the optometrist, so we already know that the patient has a cataract. So once the patient walks in, just saying that you have a cataract and you need to get operated is not the right approach. You have to spend some time on the slit lamp, do a dilated examination, go over, so they feel that okay, yeah, we've looked at every aspect of it, and then the doctor has said that yes, I have this condition, this is how I help you. Pan out all the options to them, tell them that from this range to that range, everything that is options are possible to them, and let them have a choice. Also touch upon the fact of finance. Tell them that I know this is your budget and this is what I can help you financially in this way. So when they know that the doctor itself is looking after the finances of the patient, it wins the trust of the patient as well. Make sure your staff is well oriented and they have a good counseling as well. And of course, give more chair time to the patient. In complications, how do you communicate in case there is no complication? Do not be scared, first of all. Be responsible for it. Do not hide the complication. Don't act guilty. It's not a crime. We are also in our learning phases and complications happen. It's not that, oh my God, I made a complication, I'm a pathetic surgeon. Absolutely not. Even the best of the best surgeons do have complications. So don't act guilty. It's definitely not a crime. But yes, when you have the complication, be honest to yourself and to the patient. Explain them clearly to the patient that yes, we've had a complication, but the surgery has gone off well and we'll restore your vision, or give positive feedbacks to the patient so they know that, okay, even though there was some problem, the doctor handled it. Make sure your tone and language is nice. Don't be harsh and, don't be very rude to the patient. and show empathy and document. Documentation is very, very, very important in today's day and age. In many a times, you have a patient who comes with a complication from another doctor. So what do we do in such conditions? First of all, explain the condition properly and suggest proper measures. Communicate in a very nice way. Do not be rude or behave superior to the other doctor. Try to tell the patient that yes, if this condition would have come to me, probably the same complication would have happened to in my clinic as well in my setup. But today you've come to me with this problem. Instead of figuring out and talking back about the doctor or what happened and where it happened, we'll come to a solution today. Stop backbiting on your colleagues, because at the end of the day, it is your colleagues who, your patient also might go to another doctor, and you don't want anyone to backbite each other. One more important thing is having a good place, and your staff should be well trained. Having a well-equipped clinic that impresses the patient the minute they enter. Make sure your clinic is clean and tidy. Have a well-trained staff that knows everything about the surgery. Reduce the patient's stress and tension before he or she visits the doctor. Gets them time to digest that he will she require surgery. I have noticed that most of the patients feel lot of more at ease when asking questions to the staff. So make sure that they are staffed, are well equipped, and they know everything about what is happening at your clinic, because it reduces your chair time luckily with the patient. For the staff, have a timely orientation with the clinic staff. As a lens company, people to come and brief your staff about it, because sometimes these staffs don't enter the OT, don't enter the operation theater. They're just at the reception and they're made to do counseling, but they do not know exactly what is happening in the operation theater of what are the complications. So they sometimes tend to give false beliefs and false impressions that okay, this everything will happen successfully and no problems will happen. But no, they should know, and they should explain to the negatives also to the patient, that you might, in case if it's a LASIK surgery, you might get your number back. It's not that you provide them with false belief that no, LASIK ho gaya to matlab there'll be no glasses again. You can help the staff provide the patients with visual and demonstration. Incentivizing a staff for every patient who gets counseled properly is very, very important, because that way they counsel them in a right way, and plus they're getting incentivized. So, they're motivated to work more and in a better way as well. Leave the choice to the patient, discuss the merits and demerits of every option that you give, explain everything to the patient, including the negatives. Like if you're putting a multifocal in the patient, make sure you emphasize that you will see glare and halos. They might not see it's a different thing, but at least put it in their head that yes, you're putting a multifocal, you're definitely going to see glares and halos. Reset their expectations. Always under promise and always overachieve, so that way you at least have the barrier that okay, you have under promised it, but the patient will be much happier when you over deliver. And always try talking to the decision maker of the family, because ultimately they are the ones who are going to finally decide for the mother or father of the patient. Reassurance should be given to the patient. Reduce their stress by reinforcing on positive things. Minimize using negative dialect in your conversations. And of course, as I said from starting of my talk, listen as much as you can to the patients, because that is what they've come here to a doctor to vent out their feelings and frustrations, and although the conditions of the eye. Because if we don't listen to their complaints, then who will? Clearly communicate the older and newer technologies that are available, understand the patient's lifestyle, needs and wants. Understanding his or her profession as well as his patient's psychic is very, very important. Listening to their doubts, thoughts, and learning about deep thought making to the patient. Explaining the patient entire procedure to them in a simple language, so that they feel that they've been a part of the process from the start itself. So that you can explain to them that this are the steps of the procedure and this is what is going to happen. And showing some patient testimonial videos on the cases that are similar is extremely successful and helps and clears the patient's doubt as well. And of course, answering all their questions clinically and financially in a cool, calm way, even though you've had a busy OPD and they're asking the stupidest of the stupid questions. But make sure, you go ahead and that final touch is answering their questions if they have any. That helps a lot. Thank you.
Thank you. Thank you very much, Dr. Pooja, for that presentation. Next, we have Dr. Samresh Srivastav, currently working as a consultant ophthalmologist at Raghudeep Eye.
Rohan, we lost your audio.
Name and has a special interest in complicated cataracts and managing subluxated lenses. So we'll be talking to us about the challenges in joining an established practice.
Thank you, Rohan. Thank you, Rohan and Pooja, for inviting me for this talk and to the ISI youthful session. Guys are doing a great job at conducting this session. So I'm just going to briefly discuss on my experience of what happened when I joined an established clinical practice. And I think there could be some key takeaway points from this. It took me a lot of, it was quite interesting making this presentation, I must say. So just a brief about me, I graduated in Mysore and I did my post-graduation in Shankar Nethralaya. And once I finished my residency, I thought that, with an institute backing like this, I had all the knowledge sorted out and I had the skill set to go out and achieve what I wanted to, anywhere I wanted to. And I landed up after my fellowship, my post-graduation program at Raghudeep Eye Hospital, which was in Ahmedabad. And for those of you who are not aware of Raghudeep Eye Hospital, it is the director of the hospital who spearheaded the hospital and brought it to new heights. Was Dr. Abhay Vasavada, who at some point in time was leading the cataract sort of change from SICS and ECC to cataract in the country, and had a lot of laurels to him. Also, interestingly, I was married into the family. So I was married to Dr. Vasavada's daughter. And so the fellowship came as a, as a gift to me, which I had no choice but to accept. But the first thing I realized the moment I joined this place was that this was a big gang of overachievers. So it was not just Dr. Vasavada, but it was also the daughters. There were the rest of the doctors, the fellows who had passed out, and everybody had something in their kitty, which I obviously didn't have because I just finished my post-graduation. So one of the big challenges that I faced was just to figure out how to settle down and how to blend myself into this big gang of overachievers. The first conference I attended was within the first few weeks of joining in, and the house was packed even before the session started. And so there was a lot of pressure, obviously, and a lot of expectation coming out of people towards looking at who was joined next. So when you join an established practice, and particularly in practices which are family-run practices, you will realize that there is a lot of if your practices are established for over a decade or two, you will realize that there is a lot of pressure from the environment, and there's a lot of pressure from the peers because they all expect you to have a certain minimal standard to take care of, which you may not really have because you don't have the kind of experience in the beginning. So like I said, to make matters worse, that's my wife, Vaishali. She's also a cataract surgeon. But not only was I married, I was also a fellow under her for about 2 years. So I had to stand next to her, take her notes, and she would assist my surgeries. So this was a big character building experience for me. And now not only was I alone, my sister-in-laws, my brother-in-laws, everybody was doing the fellowships or had just joined as consultants. So we were a big family at home, but we were also working together, trying to understand newer surgeries which are coming up, because last decade was the decade of change for everyone, where femtos joined in and phaco underwent a revolution again. So what one needs to understand when you join a big practice or a set practice is that it's already a full-blown tree. You're just a small part of it. So no matter how much energy you come out with in your fellowship program, you have to understand that, or a post-graduation program, you have to understand that you have to now fit into this big scheme of events that's there. This was the team when I joined, and you can't even notice me in a corner over there. So it's really important to understand that you're not a big picture anymore, which you already had in your mind. If you do a single practice, if you start a single proprietorship or your own clinic, it's a different story. But when you want to do something in an institution, you have to understand the first thing you want to unlearn and relearn is a different system of working. Every institute has its own technique, has its own nuances, has its own systems. Private practice is very different from institutional practice, is very different from government practice. So there's a lot of unlearning and relearning to be done. A lot of unlearning in the sense that what you believed was a standard of care is now changing, because it's now a specialized clinic with a specialized set of rules and a specialized system of working up patients. And one needs to be open to the idea of adopting newer techniques and also changing your way you have looked at ophthalmology in your residency. One big thing that I want to bring about, more than the educational or the clinical aspect, is that when you join an institute, you need to understand in good detail, with spending enough time, what the core values of that institution are. Because you have to align to this institution that's developed over the years, there are some core values that you will be apparent to you, but there are some subtle ones which are basically the backbone of the institution, but you will never know, like performing charity work or performing ethical code of conduct or having a system of values where patients given priority. You have to figure it out. You have to ask your seniors, you have to ask the consultants, and that is something it's not clinical, but it will govern how you blend into the system and then you shine out of it. The good part is there's no struggle to get patients, because the moment you sit in the clinic, you have ample number of patients. So for those of you who really want to just start on with work and don't want to break their head with the economics of it, this may be a great option. But for somebody who wants to create one's own presence in this ophthalmology world or in the society, it may be a little difficult, because the boundaries have been set, the foundation has been laid, the levels have been set. So for you to make your own mark, it's going to take some time. Nobody's going to pay attention to what you're going to do. People are going to not come to show you their eyes or come to you with problems, but they're going to come to senior doctors. And no matter where you've been trained and no matter how skilled you are, it's going to take time. So you better be in this for a long haul, because it's unlike a single person's practice with the 5-person clinic which you're going to sit on is going to be yours. This is not yours. You have to prove to the patients that you are worth their time and effort and money. Again, even if you have a radical idea, you want to challenge the normality, it's not going to be easy, because there's going to be a lot of friction, simply because the system has worked for so long. The system, and nobody wants to change a system which has shown results, no matter how radical your idea may be. But if you work it up and you prove the point and you go in a stepwise fashion, it may not be impossible. It's just, like I said, going to take time. Administrative work comes as a part and parcel. There's no escaping it. If you're joining institutional work, and especially if you're joining a family practice, or if you're if you're taking over somebody's practice, it's very important to understand that your clinical knowledge is on one side, but you have to know a lot of skills. You have to know finance, you have to know housekeeping, you have to know management, you have to know HR. A bit of everything may be required, and all this will happen in the course of one day. So you have to change your roles as fast as you can. But now comes the important part. Once you've set in and once you've joined in and you've learned the working of the institute, you want to grow, because as a human being, it's everybody's tendency to grow from where they are and to become a little bigger than where they were. If you want to change this, you have to understand that not only is it important for us, all of us, to maintain the standards of where we work, but to raise the bar every time we work over there, and to put up newer standards which are only higher and not drop down in the course of time. Which essentially means sometimes you have to handle, for the lack of a better word, dead wood, which is always there in every organization. And sometimes it's so deep rooted that it will pull you down with it and it will not let you grow. So you have to be intelligent about it, reasonable and rational about it, and when required, deviate the system. It may be unpleasant for many, but this is the way it should work, because you are now going to be taking charge of the situation. It's really important to understand that we've all learned this in school. We all learned this in all those children who used to see the Doordarshan earlier on, that there is strength in teamwork. And so I must tell you that if you understand that in life, if you really need to grow, it has to be a team, and not one person can achieve too much in life. When we teamed up, all of us, we had a winning streak. So for close to a decade, we were on a winning streak in terms of the number of publications we did and the number of awards we received, be it the ACRS or the APSCRS. So we have and it was a winning high. But this could only be possible because there were people who were designated for different roles. And we all understood each other over the course of time. So when you join an institute, it's exceptionally important that you understand your roles and you get other people time and space to breathe as well. Now, trying to take the brand ahead, like I said, sitting down and just getting comfortable is one way, but getting comfortable will get you nowhere in life. So you always have to challenge the system. You always have to grow, and you always have to look for what next is going to happen. Like I said, under a big tree, a small one will never really thrive because the shadow is too dense for you to grow. So we decided that we're going to take the brand ahead, and from Raghudeep Eye Hospital, Ahmedabad, we opened up another branch in Ahmedabad, and eventually opened a branch in Jaipur, which is here, where Shali and my wife and I run. And we expanded to a newer branch, which is upcoming. Hopefully by the end of first quarter next year, we should be shifting into a newer place. Again, like I said, up your standards. So this is nothing to do with institutional practice, but like Pooja brought about, Dr. Pooja's points were so bang on. You don't have to have plush, but you need to have clean. You need to have visible, and you need to have light. Positivity in a clinic will always be very welcome. So if your clinics are old and you've joined institutions, be upfront and tell them you need to change the decor a little bit, bring in a little more positive vibes, and that should be the end of it. Now, so like just to summarize it, it's not easy. Joining any place in single practice is not easy. Institutional practice is not easy. Joining your father's practice is not easy. Nothing is easy because you have to live up to the expectations and you have to do better. Sometimes it's really difficult because if you're living under a big tree that's already made a huge identity, it may be very difficult for you to break out, but that should not be a reason to give up, and one should really strive for it. On the good part, there's a lot of potential for growth because the team is already in place. You just have to go in, see the system, understand it, and try to push it to a newer level. And that's the only way you can take a bigger leap, going from a single place to an institutional work, going from institution to a chain of hospitals. But most importantly, it gives you enough time to pursue what you like because you have other people to look out for. So you don't really have to get involved in the nitty-gritties. I like old things and old people. So, I spend my time in cleaning up my old cars and doing up new old cars. Thank you.
Thank you so much, sir, for a very candid and very enlightening, presentation. You brought out the points so very well that it's very difficult to grow under a large tree. So you have to do something different. You have to branch out, and that's the only way that's going to happen. And also challenging what you think is not correct. So established practices have been running for a long period of time, and people tend to get into their comfort zone and they do things the way they are doing it. But you should have the courage to challenge that as well. Excellent talk, sir.
Thank you, Rohan.
Very well talked about, Samresh, and also to it was interesting to bring out the personal and the professional both in that in your presentation. And it is always the bigger the organization, the more well established it is. It's always difficult to bring about change. So that also reminds me of a book that once the IBM CEO had written about elephants can dance too. So you can actually make them change, but it takes a lot of effort. So I think that's what it is. But I think a wonderful presentation.
Thank you.
So that brings us to the end of this session. Dr. Digvijay sir, if you can close this session.
Yes, and I think I also want to congratulate both of you, Rohan, Pooja, for Youthful IRSI, the association, as well as for so beautifully conducting this session and getting this kick started and pushing it off. And I hope there are many more sessions for you guys in the future under this banner. And I think very wonderfully planned. And from the OC perspective, we'll be very happy to be collaborating with you and take things on. But a wonderful session, and congratulations, everyone.
Thank you so much.
We have a Youthful Chapter 13 this Wednesday. That's 22nd at 8 p.m. on March to Zero End Ophthalmitis. So we'll be sharing out the details soon. So please do join because that's the need of the hour of how to go about if you get an end ophthalmitis documentation, medical legal aspects. We have a medical legal lawyer as well on board. So, we plan to discuss a lot of things because that is need of the hour. So do join us this Wednesday, 22nd, 8 p.m. Chapter 13, March to Zero End Ophthalmitis.
Absolutely. Very important.
Yes.
So do we have I think we have about maybe 2-3 minutes with us, though we are over on our time, but we had an important talk with Dr. Azad. So if there's nothing else, then we can hand it over to Yeah. All right then. So can we have
any
a quick
questions?
screenshot?
We'll have a quick photograph. If Thank you. Thank you so much.
Thank you. Thank you,
Thank
Dr.
you,
Rohan.
doctors, for wonderful presentation, and thank you, Dr. Digvijay Singh, for chairing the session so wonderfully.
Thank you. Thank you, Sabrina.
Thank you. Bye-bye.
Hello, Madhu ma'am. Good to see you here.
Sabina, nobody is audible. I don't see anybody.
No, you will. I think everybody will join now. I think Dr. Awa is already here. So this meeting was supposed to start at 4, but Mohita
Yes,
said it's
doctor.
running late. But anyways, now.
No, doctor, it was ended on time. So we'll begin with the session within 2 minutes. We'll just wait for the other panels to
Yeah.
join.
Kindly call Dr. Mohita Sabrina. Please call
Yes.
her and call Dr. Namrata. Also,
Okay, doctor, I'll do that.
yeah. Dr. Madhu and Dr. Awa Hussain are already here. Yeah.
Yes, doctor, I'll inform.
Thank you.
Yes. I think Dr. Mohita has already gave us, and Dr. Namrata has answered that 4:15 will start. So let's hope. Me, hello.
Hello, your voice is cracking. I think the signal is poor.
Hello, Professor Madhu.
Yes, hello. Good evening.
Good evening. I'm telling that I'm present here, but I have seen in the WhatsApp just a few minutes. Mohita gave a message. This session will start a bit late. That is half an hour. But Namrata said that 4:15 we will start. So let's wait for
Welcome, madam.
20 minutes at least.
Good evening, Dr. Iba. Assalamualaikum, madam.
Hello.
How are you?
Nuzhat, right?
Yes, I am. I'm
Bangladesh.
Yes.
From Bangladesh.
Yes, I'm from Bangladesh. Yes.
You're related to Mujibur Rahman, right?
Yes.
Are you related to Mr. Mujibur Rahman? Your granddaughter or something?
And pardon me. I didn't understand the question.
I said, are you related to Mr. Mujibur Rahman, the first president?
Oh, no. Yeah, no, not really. My father is martyred intellectual Dr. Alim Chaudhry. He was martyred in our liberation war. So probably that's why you've seen me active in those areas.
I think I saw you in Guwahati, probably.
Yeah, yes, I think so. Hello.
Yeah. Samina, somebody is asking to start the video.
We need to, I think, see, Dr. Madhu, we just had a session right now before this to discuss the questions for this session. So we'll wait for Dr. Mohita to join us and we'll start.
But I was getting a message that you start your video, so I was just wondering which video.
There is no video as such. It's a panel discussion.
Right.
Yeah.
So now mind, take your time. Sorry. We'll wait for a while.
Already 14 has participated.
Can we just get the password, because I'm trying to put in the password through the laptop and it's just not accepting it. Do we have the password? Yeah, Assalamualaikum, Dr. Awa. I was just looking for the password and somehow missing it out.
Yeah, alaikum salam. Oh, just a minute.
Thank you. Otherwise, I'm on my phone.
1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
Hello, can you see me?
Yeah, the password is 1, 2, 3, 4, 5.
Okay.
Hello, madam.
Dr. Namrata.
Hi, hello everybody.
Hello, everybody.
So nice to see everyone again after a very long time.
Yeah.
Hi, Samina. Hello, ma'am. How are you?
I'm good.
Oh, great.
Thank you so much, ma'am, for helping.
Hello.
The morning session also. Hello, Samina.
Hi, hello, ma'am. How are you doing?
Hello, ma'am.
Good to see you.
Good. Hello.
So we shall start or begin with the session?
Yes, we just wait for a few seconds for Dr. Mohita to start.
Okay, ma'am.
Hello, Namrata, ma'am.
Hi, how are you, Nuzar? Nice to see you.
I'm fine.
Hello, Namrata, ma'am.
Hello, Millie.
How are you?
I saw Dr. Ava Hussain, ma'am, also somewhere, but
Yeah, she's there. She's there.
she's there, no?
Yeah.
So very nice program from women from the SAARC countries.
Yes.
Today's day was busy day. Booked from morning 11:30, then 2 o'clock, then now.
I know. Sorry, ma'am, but thank you for holding the fort from.
Once in a while, it's all right. But it's a power pack program. This, topics and all were really good.
We had very short time. We planned everything in almost say 2 to 3 weeks time. If we had planned it earlier, because there was this debate whether to do it as a webinar only or to do it as a meeting, full meeting. Then gradually, as we started to do it, became a full meeting only.
It's another AIOS actually.
Yeah.
Samina.
Yes.
What is the meeting ID, please?
The passcode is 12345.
1, 2, 3, 4, 5.
You are already in the meeting, right?
No. It is in the mobile. I want to be in the computer.
The computer. So should we send the link? I'll just paste the link. This is Hall E, huh?
You send me the
Passcode is what?
link name.
Yeah,
Personal
passcode.
link name.
I'm just sending it. I'll put it in the chat.
Ma'am, I've sent you the mail. You open your mail, Millie, ma'am.
Okay.
Just click on the link or open the mail, and then I think you'll be there.
I believe we should start with the session, or else
We'll start at 4:15, 14. 1 more minute. That's it.
Okay, ma'am. We'll take 1 minute.
Before we start, can we make sure Abha madam is connected? She was here, but I can't see her anymore in the panel section.
Now Mohita has come in and Abha's logged out.
Ah, yes.
I can't see Dr. Ava, ma'am, now.
We have Dr. Ava.
She's there?
Yes, she just logged in.
Okay. Ma'am is there.
To start with the session, I would like the chairperson, Dr. Awa Hussain, co-chairperson, Dr. Madhu Bhaduria, and Dr. Mohita Sharma to please switch on the camera. Over to you, Doctor.
Mohita, you are muted.
Samina, you start, please.
A warm welcome to each and every one of you. It's such a wonderful gathering over here, and the next 1 hour, without wasting any further time, we will go to the questions what we have planned for the leaders in ophthalmology in the SAARC region. I would first request now Dr. Mohita to take the first question. Dr. Mohita, Tirupati Eye Center in Noida is a place which is of great repute. And we would like to know from you that what are the learnings, what you can share with all of us women ophthalmologists in this area in building not just the Tirupati Eye Center, but building your, in your role as a leader, woman leader in this area. So we would like to know some tips about networking in this context. So over to you, Dr. Mohita.
Yeah, thank you so much, Dr. Samina, for your kind introduction. And welcome everybody. Welcome Dr. Awa ma'am, Dr. Madhu ma'am. And we have a very interesting panel here. And I thought I should not be the first one to answer a question. We have such senior people sitting here. So Samina, can I come to my question a little later? We can ask Dr. Madhu and Dr. Awa and later, because let's hear from them what they have to say. And after that, we come back to our networking. So Dr. Awa ma'am has joined, and Dr. Namrata. Samina, can I ask them a question?
Of course. Yeah,
Okay.
surely. Go ahead.
So Dr. Namrata and Dr. Awa, madam, one question as soon as this session was planned that came to our mind was, we find that whenever we see the executive boards of ophthalmology societies, we find that there is a very less representation of women ophthalmologists there. We are always told that 50% of ophthalmologists today now are women. So how come in these leadership positions, the women are so less? And because you and Dr. Namrata, you and Dr. Awa ma'am have reached that pinnacle. So definitely you would be the best person to tell others how to reach there and what are the challenges you faced and how you overcame those challenges. Just for to tell the audience, Dr. Awa ma'am is at the highest of pinnacle, and she's currently she's the president, I think, of APAO.
Yes, ma'am is the president of
Yeah,
Asia.
and Dr. Namrata is the General Secretary of All India Ophthalmological Society, and these two women are the first ever women on these posts. Though these societies have been existing for so many years and there have been so many women ophthalmologists. So can you please share with us?
I think
how you became the leader.
I think you know it all and you know the entire history, but I would just briefly put it up in few words. I always feel, and I am a party to it, I cannot exclude myself out of it. We are very good followers, but we are not very good leaders. So if your seniors tell you what to do very, obediently, sincerely, with utmost sincerity, would do whatever has to be done with we would never cut corners. So I think that mindset is there with all the females. I'm not saying maybe with males also, but that mindset is there. But then we are not projectionists, so we can't project ourselves that much. And it has to be a change of attitude and change of the mindset that, you have to be there at the helm of affairs. We like to be guided, but we don't like to guide others. That also is there, and we are hesitant to do that. So when I actually changed from a follower to getting into the leadership roles, my mindset was this, that if I can work so hard for others, then why shouldn't I work, for my own self? If I can burn the midnight oil, and if you can make slides, make videos for your seniors and for your mentors, then why don't you do it for yourself? So it was like that. And it takes time. There are a lot of obstacles. There's a lot of hesitancy. Every leadership role that you get into various societies comes in a different manner. For instance, some places you are nominated, but some places you are elected, and election is a completely different ball game, which you realize when you get into it. It's not easy. It's not done purely on your merit or purely on your academics. It is done more on your popularity, more on the number of friends you have. And I believe it is also done on the fact that how many lives you have actually touched, how many people you have helped. So when those kind of genuine reasons are there, then you make it. But sometimes it is not like that. Sometimes you cannot pat people on the back, or have a fellowship drink or a dinner, and then say, come on, vote, elect us, and ask your friends also to help us. So it doesn't, we are probably not that forthcoming or that outgoing in that sense. So there were obstacles, but I think now there's a complete change in the mindset, which I myself have witnessed in the last almost, you can say, decade, or last 5 to 10 years, that women are coming in the leadership roles, and they are very much there, and they are here to stay. But like I said, we have to cross the fence, and we have to jump the ladder. We cannot be at the bottom of the ladder. It always has to be at the top of the ladder. And I think Dr. Ava Hussain ma'am has also joined, who's at the topmost stair of the ladder, leading us all the way. And hats off to her. I'm sure it must not have been easy for her also. And from country like ours, like India, like Bangladesh, must have been so tough to come at that level. Maybe people in America, women leadership roles are there, but there also I see that there is a deficiency at the helm of affairs, at the powerful positions. When it comes to power, it has always been male ophthalmologists. We have nothing against them. They have done a good job, but I think now it is. I think in future they will have no choice, because almost 80% of the females are ophthalmologists. So in future they will have no choice as far as leadership roles are concerned, or surgery is concerned. Everybody will have to get surgery done from us only. So that is the way it is going to be.
So Dr. Ava ma'am, we wanted to ask you the same thing as to why you think there are such less women in when it comes to the executive boards of societies. And plus I also wanted to ask you that if there is such less representation, obviously it is the responsibility of those who are at the helm of leadership positions to promote others and pull up others to reach that position. But many times, not many times, but at least a few times, I have seen that those who reach the top tend to not pull up others, and they tend to sometimes think, sometimes I've heard them say, if I could do it, why can't she do it? Why should I help her out? So I have always felt that we should come out of this attitude, and we have to do that pulling up. So I want your opinion now.
Thank you, Mohita. And Namrata has said very nicely, as because really it is such a way that women are now coming up in ophthalmology. But in Bangladesh, what was the situation? I was alone for a long time, and I always just invite our junior colleague to come to do the ophthalmology, as because this is very important subject for the ophthalmologist. This is not that much emergency. I always believe and said to them that ophthalmology is such a subject, such a delicate subject. Now it is machinery, but initially when we have started, that is very delicate. Finger only, we have to do the surgery with manually only. But still the women are very much interested in gynecology, obstetrics and other subjects, but not in ophthalmology. But now it is not that. Now in Bangladesh also, there are so many women are coming, and also the junior, about the resident, 60 and 40 now. So days will come when it will cover 100%, and at that time all are women, and always competition. Professor Namrata has said very nice thing, that if it is a nomination, then it's one thing, but if it is election, you have to come, you have to achieve this by doing an election. So that might be some other reason also. There must be popularity and also leadership, developing personal mind set up, and also her willingness to do that thing also. So this all the way, but I think women should come up, and women should do, can do, not should, can do all the, they can overcome all the obstacles, as because women are overcoming the obstacles, the beginning, family, they are, why they are not coming up just like male, as because both the partners, they are in the same home, same thing is doing, but women have to do more thing, that is, they are the mother, they are carrying the children, they are doing lot of things in the home, and also they are doing work and life balance. By balancing this in the professional part, they are growing up. And so this should be everybody's mind from the very beginning, from the residentship, that she will follow her mentor, she will follow her senior, she will follow everybody, how they are growing up. And leadership development, this is not by born, never. Of course, there are some situation, environmental factors are there, as because in a home where there is father or leader, national leader, and then the child are also saying that they are in that way they grown up. But nobody are born by a singer, nobody born as a leader, nobody born as a parliamentarian, and all these things. So this is a very important thing. And women, there are so many countries that women are in power. How? They are all ruling the country, in Bangladesh also, you know, and in India, Mrs. Indira Gandhi, when she is the idol. I was at that time thinking how it is possible that Mrs. Indira Gandhi is doing so many things at the time of liberation war, how she helped us, how she helped Bangladesh. You can't imagine, as because Dr. Mohita, you are very, I don't know whether you born at that time or not, in 71. So that is the leading capacity. And that is also come generation after generation, same thing. So I think Namrata is a leader, very good leader, and she's doing in such a way. This time, you think one thing, Sark Academy Ophthalmology Conference, this is actually scientific session, not the full conference, not the biennial conference, but this is of course a conference, everybody are here. So this is a conference, not the biennial conference 2021. And within a very short time, less than a month, not even 30 days, she got. But she with her team and Professor Lalit Verma and others, all they are doing in such a way I think every day I got in WhatsApp group, Professor Namrata Sharma is giving something. Of course, I was very much stressful for my personal, for my husband's health related program. I was in Hyderabad just yesterday. I came late night in the at my home. So today I can actually participate. And before that, while in Hyderabad, I tried, but I could not join. And Professor Raj and Professor Namrata has said, take care of your husband. That is the first, that is the priority. And next is the conference. This sort of conference will come and go. I believe that, of course. But as because not that this is vice versa. Not only women are taking care of their husband are also taking care of wife. That is separate entity. But with the help of the husband, women are growing up, and in the leadership development program, my husband has so much contribution on me also. So I am very grateful to that. But the thing is that in professional, the male are always the upper hand, but we are very good friend of our male counterpart. But still, I think my contribution, and I will say to everybody, my junior colleague and everybody who are just growing up, and leadership development program in Asia Pacific Academy of Ophthalmology, in India also, you are doing leadership development program. This is the way that we can grow up, and we can encourage our junior to come up in the leadership development program. Thank you, Dr. Mohita.
Wonderful, ma'am. Very good message you have given for everybody. One is, as you said, as you talked about Dr. Namrata, within a short period, she organized everything. So we have seen sometimes women get perturbed very fast, and for anything that is given to them as a task, they would ask for time, and they would say, no, this seems difficult. But what we have to learn is we have to take every challenge if we want to be a leader, and we have to, our first thought should be that everything is possible. Even if we have to do that job in 2 days, which would otherwise take 1 month, we'll do it in 2 days. And all we need is a good team. And when we have a good team of women ophthalmologists supporting us, then definitely we can do it. And secondly, ma'am, one very important thing that you said was leadership quality can also, it's not that everybody is born a leader. Leadership quality can be acquired. And for this, you can attend the programs like leadership development courses. Plus, you can attend such, when you interact with leaders, then that itself gives you a lot of tells you a lot of things, and gives you a lot of learning lessons as to how you can do it. Ma'am, I want to share, I myself did a leadership development course of in India, and that brought about, I call it a pre-LDP era for me and a post-LDP era for me, because it changed my whole thought process on how I should conduct myself. And these programs are definitely very, very useful. So thank you so much for your message, ma'am. And Dr. Madhu, ma'am, I would like to introduce Dr. Madhu Bhadoria is the president of our Women Ophthalmologist Society of India. And she is a true leader, and she's an inspiration for all of us. And she is currently in Sitapur, and she has she's made such a changeover of the whole organization, which she joined a few years back, that it is unbelievable. And simultaneously, she made the big changeover in India also with as president of WOS. So from Madhu ma'am, I have been in touch with her for the last 6 years, and though I know her for a long time, but I have seen that she's always positive. And she is always ready for any challenges, and she never says no to anything, and she's never negative in anything at all. So this is what I have also learned, and I feel that she's a true leader. So Dr. Madhu Bhadoria, we would like to know from you, what are those according to you, true leadership qualities which everybody should have and learn and acquire?
Well, it's a very difficult question, but let me tell you what I feel. I feel first and foremost is a passion. You've got to have something within you that's a burning desire. And second thing is, then go on and never learn to let go. Let go your passion. I'm not talking of an appointment or a post. Suppose you come across a challenge. First thing, there is no challenge which is not surmountable. Every challenge is surmountable. It's just that you have to see whether you can do it alone, you need collaboration, or what else you need. So there has to be a proper strategic planning in the mind to meet the challenge. And unless until there is a challenge, you will never grow. Nobody can ever grow without a challenge. So I always welcome challenges. And my challenges here were very different kinds. I had to deal with mafia. I had to deal with bad employees. I had to deal with the crumbling infrastructure, lost patient demand. It was a very different ball game. And also, let me tell you, I feel very proud now, which I did not know now, till now, that this was a job refused by all the men, whosoever was approached, plus refused by major organizations of this country. They said, this is dead, this cannot be revived. So what saw me through was that take challenges head on with your courage, with capacity, very important. Because if you don't have capability and competence, nobody will ever respect you. And in the end, I'm not a person of too many words, but I would say anybody who is there needs to be respected for their age and what they know. It is not that a person who's cleaning the floor and is the perfect person. The person should be respected. Therefore, I have some role models from Dr. M.P. Mehra's era. I still have some people who are 80, 85, 90 years old. And they're still there in the organization because they are my pivots around which I have woven the motivation of the whole organization. And currently I'm doing a leadership program. So in that I'm a mentor for multiple mentees. It's called Leap Leadership. So it is through a particular this thing, but if there are women who are interested in it, maybe the next program that we have for next 6 months, we can enroll some people in that. Thank you so much, Maita.
Wonderful, ma'am. I think that's a great opportunity which everybody has, and so much to learn would be there. And I'm sure we'll take this from you and pass it on to others for the benefit of others, as well as join ourselves also. So over to you, Samina.
Yeah, I think the next question is for Dr. Huma Saigal. She has single-handedly overcome all the challenges in Pakistan, and she's now the leader for WIO Pakistan. So we would like to hear from you, Dr. Huma. What were the challenges you faced, and what was your one distinct quality which allowed you to overcome all these challenges?
Thank you, Dr. Samina. Thank you, Dr. Eva, Dr. Mohita, Namrata. I mean, I wouldn't like to call doctors now because Nuzat, Millie, Namrata, Madhu, all of you, you are like one big family that I have been included in, and I'm really grateful to you for having me on this wonderful session. Now the question that you asked, I think I'll start with the second question and we'll come to the first one. And what is that quality that makes me who I am, or who brought this, incorporated this leadership quality? I don't know whether I'm a leader or not, but I do believe in the fact that I'd like to take everybody along with me. So maybe that is one of the reasons that makes me more self-determined. So when I see things happening around me, and it makes me very observant, and I just start thinking a lot as to why these things are happening, and why let's say that in Pakistan now, when I started, I was like, there was a whole bunch of men sitting, and I would just be the single woman ophthalmologist, and as a woman ophthalmologist, I would be sitting at the back while all the men will be sitting in the front. I would be knowing the same thing, they would be knowing the same thing, but I probably didn't have that much of a courage to sit in between them, or take that that sofa that was there right in the first line to sit. And that was that that started making me realize that I have the same qualifications, I have the same skills, and maybe I'm very hardworking and I'm very self-determined. So why would I just subconsciously or unconsciously I would just go and sit at the back while all the men were sitting in the front? And similarly, when there was a stage somewhere, all the men were sitting, the moderator was a man, the chair was a man, the co-chair was a man, and everything was a man. And we had the same degree, we had the same qualifications, everything as them, and we were heading the departments just like them. So that was the first thing that made me realize to move from that grassroots level, that pyramid that people talk about, that at the top of are the leaders, and the grassroots level are the the workers and all that. So I didn't want to be there. I realized that I am to be to start climbing that that pyramid, to reach to the top. In order to that, I had to gain that self-determination, and that determination was in me. It's just that I had to bring it out and show. And if I could do that, only then, I realized that if I can move from this step to next one and go ahead, then I'll be able to encourage all the females, who are falling behind to come, and I started encouraging them to come and sit in the front. Why are we sitting in the back? Why can't we, like ask a question, things that were in our mind, why do we keep it hidden inside? We've got to bring it out. So the first thing of self-determination and that observation and the thing that was inside me, I started, talking it out and speaking about it. And I just forgot about the fact that, if I say something, maybe they'd say, oh, why are you saying it? Or why are you asking that? Most of the time, my talks were vetoed. I would say something and, it was like there was a smile on the face of somebody, that she's asking. But all that I had to, just cover that up and realize that I have to move ahead. And on doing that, I started noticing also. So it was not just self-determination, but observation and compassion. All these things were together. So for me to realize that my skills have to be talked about, what I have, what is inside my mind, I have to bring it out on my, and speak it out. So I started speaking out. And once I started doing that, I realized that I have to take others along with me also. So the first thing that we did was that I started looking at other people. I looked at Mohita, I looked at Dr. Eva, and I started looking at Nuzat and all those people, who were like making a difference in their places also. So that gave me a lot of encouragement because I knew what I was doing was right. But, to get that support, you need that support program also. So that support program was provided by other women who were, facing the same or were, had overcome that. And in looking that, I think I overcame that. And then I now coming to the first question, I developed this Women in Ophthalmology Pakistan. I just started with, looking at seeing what other was like all international were doing. We had just a small WhatsApp forum first. So I started gathering and finding out where all the Pakistani fellows were, what were they doing, would they like to join this group? I would encourage them and they'd have a social talk and then academic talk. And then started encouraging them to, come up and start being a very, very important part of conferences and talk about it and meet each other, because I realized that men have a very special way of bonding. They have a very nice network, they can play golf together and they can, have dinners together. And in part of our world, we have some certain norms that, women are family members, they take care of the families and all that. Going out in the evenings and all that is not that easy. So how to get them together to, discuss academics and research and social everything together. I think that was the first step that was taken. So with the development of Women in Ophthalmology, then we had this logo developed, then we had a directory developed. So everything, the ideas were floated and the ideas were picked up. So I think a leader, if I am a leader, I'm not sure if I am or not. If I'm a leader, it's because of the self-determination and observation and sensitivity inside me that I wanted to have all Pakistani fellow women who were sitting at the back seats of a conference or a society, who I knew were at par with the, the male ophthalmologists. All we wanted was to have like a support system, as if we are their support, they should be our support. So it was not something, I'm not talking about gender equality, I'm talking about a support for each other. We stand side by side, we talk together, we represent together. And that is something that brought a lot of resistance also. So when we said Women in Ophthalmology Pakistan, we want it as a society, the first question was, why? And I think the only thing I answered was, why not? So this was something they didn't have an answer to, because when it's a why not. You tell me why you don't want a Women in Ophthalmology Pakistan, I'll tell you why not. So this was something that, brought about a peace between the two, and the society was built up. And now, just like Dr. Eva said and Dr. Madhu said and Namrata and Mohita, it's like, women are so many in medicine that nobody has a choice now. Every woman ophthalmologist is is coming to that stage, is developing her skills and realizing that she will be recognized. It's just that you just have to, show them a direction, and somebody has to do it, somebody who's determined. And maybe I was that one fortunate one who realized that before, and maybe went through so much ordeal and hurdles that I realized and kept, stood my ground. And that stood my ground gave me a choice and got the respect from everybody around me, that I'm now standing for the post of General Secretary in the Ophthalmologist Society of Pakistan, which has never happened before. In 60 plus years of society, no woman has stood. And I'm doing that for the first time. And I see the faces and I see
Wonderful.
that they think that I should be in a ceremonial post. And I said, no, I will fight for this vote. I will get elected for this post by my own campaign, by my own skills and my determination. I don't want a seat. I don't want to be selected. I want to be elected. So
Wonderful.
in that is the self-determination that we have in us. And that's what we're doing. And that is what, now just look at all of you, such beautiful women who started supporting with this word. That is the support system of women ophthalmologists all over the world. And that is what determination and just a thumbs up, it takes us a long way. And that is, I think, the most important for a leader. The support that it gets from its people around is what makes them a leader. Otherwise, we're nothing without an audience. Simple as
Very,
that.
very nice. So wonderful, Dr. Huma. And I have known Huma for a few years now and met her in WIO conference in America. And I know that one of the most important leadership qualities that she has highlighted is supporting others. A leader is somebody who supports others. And when you support others, you automatically become a leader. You don't need to do anything else. And that is what she has done. So she had faced so many questions, but when she decided she has to do it, she decided it for the others. Many times people tend to think it is maybe for a post that you are doing it. But I feel that true leaders who start something, new, they are doing it with the intent of helping others. It's very, otherwise it's easy to go on a normal path, but going on a different path is what makes you a leader.
And
Agree,
one thing which
Samina?
I think which I loved about what Dr. Huma had to say, and if there are some young ophthalmologists listening to this session, is that if you enter into a conference hall, please don't feel shy to sit on the first rows. They are not reserved. You can sit on that and you can ask questions. Ask your own self that, are you afraid? If you were not afraid, what would you do? So just do exactly that. If you were not afraid, what you would do, just do that and ask that question. It's okay to do that.
But Samina, I've also seen in our women's sessions that when some men enter, they tend to sit on the back seat. Why so?
They're scared.
And we always invite them to the front. So it's probably true with majority also.
They feel it's not for them. It's not really that. But I feel a very important thing is that the girl child should be brought up thinking original. That you don't have to be a follower. First and foremost thing is, honestly, if you ask me, I don't know, born or not born, I don't remember following anybody because I just didn't think it was right. Now I'm just thinking when it's being talked about. If you don't follow anybody, you will have your own ideas. So that is where the girls are. And I think it's great to be what Huma is and to what Dr. Awa Hussain is. It's really, like, in our country, things are easier. For them, things are a little more difficult and they're far beyond.
So coming to Dr. Millie, we would like to have your views on women leaders. And again, we want you to highlight on the fact that whether leadership qualities are born or they are you're born as a leader or you acquire it, and your message for others regarding leadership.
Oh, thank you, Mohita, for inviting me in this session, and also Madhu ma'am. Thank you. This is wonderful to see Ava madam, Namrata ma'am, Dr. Samina, Dr. Huma, Dr. Nuzhat, Dr. Madhu, everyone who are the leaders and who has expressed how they have acquired this leadership and how they are going forward and encouraging others also to be a leader. So if you ask me a question, is it inborn? Leadership is an inborn quality or we acquire it? I will say it's 50-50. every lady or man, they have this leadership inborn, but it becomes apparent when they get an environment. They get good mentors, and knowledge also is important to be a good leader. So if you tell me, if I say about me, from childhood, I was a little bit, I had a leadership quality. Wherever I went, I took the leadership, and in my family also, it was, had some inborn qualities. But how it became apparent is when I grew, I became a doctor, medical MBBS. There I got teacher, my teacher, she was Rujahan Bhuiya. She was a very renowned gynecologist. And when I saw her, I thought, this is a leader, she's a leader. And I used to follow her. So you have to have a mentor. And then Ava Madam, she is my true mentor in ophthalmology. I'm so fortunate to have Ava Madam as my mentor. And you can see that she is the leader in ophthalmology in Bangladesh, in this SAARC region, and now Asia Pacific region. So my thanks to Ava Madam that I'm so fortunate to follow her. And then I saw in due time, Namrata ma'am. Then I came to know Professor Claire Gilbert. She was my supervisor when I did my MSc. She's a very renowned epidemiologist and a peer surgeon and pediatric ophthalmology. She has such vast research and everything. So that was also to know this women in different part of in ophthalmology, like Namrata ma'am. Then in India, I came to know Dr. Samina. I joined her eye care quality course at this age. And it was a wonderful session. And she's a leader to me. Dr. Mohita, she invited me to World Women Ophthalmological Society. And I saw so many ladies who accomplished, they know their subject. So first of all, we have to have the inborn quality. Then we have to have acquired the knowledge. The environment helps us to grow as a leader. And then you have to have some mentors who you follow. This is how a leader develops. So when I'm not in any society now, at this moment, I'm not in the OSB because as I salute Huma, Dr. Huma. She is contesting for General Secretary post. I twice contested, but I failed. I couldn't win. But I don't mind because election is, people have to choose you. They have not chosen me. So I'm not disappointed or disheartened. What I think, I will go on. Hopefully one day I will achieve that leadership, like I will be the leader of my society. If not, I will not mind. I have other platforms. Just I started Joita. Joita, and I did 6 back-to-back webinars with the women of all SAARC region. So that is, I think, what I did. It is very happy moment for me to see all the ladies, all the accomplished women to take part in that platform. So hopefully I will do such things again. And I encourage the young ophthalmologists to grow themselves as a leader. I tell them, this is your strength. You nurture your strength, and so that your strength overcomes your weakness, you become a leader eventually. And finally, I want to say, like in retinoblastoma, in Bangladesh, there was no specialist on retinoblastoma. I started being trained in 2014, 7 years back. And now I have 500 retinoblastoma patients. And I have developed a center for retinoblastoma treatment in Bangladesh. These patients, they don't need to go to India or any other country now. They are getting all the treatments like their diagnosis. They are getting every monthly UA, EUA, and then they are getting chemo, intravitreal chemo, intravenous chemo, intra-arterial chemo, transpeople thermotherapy, and I am acquiring plaque brachytherapy also. So in this arena, retinoblastoma field of things, I have taken the leadership approach. So if everyone think like that, this is not a very big task to become a leader, but you can achieve that. It's your passion, dedication, determination, and your mindset. That is what you need to be an acquired leader, but it has to be inborn. You have to be some leadership by birth. That is my saying about this on this topic. Thank you, Dr. Samina, Dr. Mohita.
Thank you so much, Dr. Millie. That was wonderful, very, very inspiring, very motivating. And it is also important that we should, whatever we want, we should do. And whether we succeed or we fail, we definitely learn lessons from it. And a lot of time that only, leads to something else getting formed. For example, you contested elections, but though you may not have won the elections, but you went and started some very important webinars, and which helped so many people. And probably that the role for which you contested elections, there could have been 10 others who could have, worked for it. But this, what you did was something which nobody was working for. So I have always felt that for example, when we are in women ophthalmologist organizations, this is where work is needed. Now, for other positions, there are so many other people, vying for those posts and were willing to work. So let's work. Maybe God plans it that way, that this is where he wants us to work. And hence, it's important to take that initiative. And that's what makes anybody a leader. So, Dr.
I love what Mohita had to say. And Dr. Millie, we were dumbstruck. So I think there are no failures. There are only lessons. And you have learned some lessons, and more power to you. More power to you. Yes, Mohita,
thank you.
Continue. Yes.
Dr. Nusrat, we would like to, we see you as a very multifaceted person, and seeing you, we feel that a leader needs to be multifaceted. And so we want you to share your experience and tell others how they can be better leaders as with multiple faces and multiple roles.
Thank you, Mohita. Thank you very much. It's a privilege to be speaking among such women that I see here. Honorable Chairperson of the session, honorable speakers, my mentor, Ava Madam, like a mother to me, and people I admire, and she's one of them at the peak. And Namrata Madam, I don't know how you become such an important person in a country with so many ophthalmologists, in a country like India. Then there is Huma, my friend, and she's fighting such a hard battle. Madhu Madam and my friend Mohita. You people inspire me. It's an honor. I'm getting goosebumps that I'm speaking, and I'm considered as one of you. There is Mili Appa. She has always been a bigger sister to me, and I do believe. It's not that I really don't think I have reached the level that you people have reached, but I do believe that all the leaders, all the faces that I see here, they are multifaceted. Leader has to be multifaceted. Like, why would I follow, say, Ava Madam or Namrata Madam or all of you? Because you are, why do I say you are mother to me? Because you inspire me. You hold my hand when I fall down. You create the path for other women so that they have a smoother journey than you had, and they can reach higher pinnacle they may not have. But multifaceted means that not only you, but also you have to be a good teacher. I have to learn something from you. You have to be a good mentor. To be a good mentor, you must have been a good student. At least, we are all lifelong students. So a leader has to be somewhat good student, somewhat good surgeon, because I have to learn surgery story. Let's be practical. It's ophthalmology. So I have to learn my clinical art from you. I have to learn my surgical art from you. I have to learn my academics from you. But at the same time, whether I'm aware of it or not, I'm also observing how you talk to patients, how you speak up in your society, in the table, a room full of men, how you come from behind to the front, how you have come there, and how you are also holding my hand and cheering me on when I might make a mistake, but I'm still trying to be brave. You know, I think a woman, a leader inspires, man or woman, a leader inspires to be better than what I think I am capable of. And then suddenly mentee finds that, yes, I can be as good as my mentor, and some of the mentees become even better. So, you know, I think a woman is, our leader is a person, man or woman, who inspires. And that has to be multifaceted. Also, the personality. I think, you know, when a mentee or a follower feels loved, appreciated, respected by a leader, that leader, unknowing to that follower, becomes her leader. And that is even more so in our in our world, because let's call spade a spade. It's a man's world. It's a surgical subject. We all had to face the initial attitude that we are maybe not enough bold surgeons, not enough good academicians, but you know, we all had to fight that barrier. So I think the first thing is breaking self-doubt. The barrier of self-doubt, whether I'm good enough, whether I can be one, but also to have, you know, I do believe that if I'm just a good clinician, I cannot be a good leader. I have to have a social responsibility, a voice that speaks on certain level, not political, not social active. It doesn't have to be social activism, but a voice that speaks for change. Like, see, Abha madam and Ramrata madam, they are leaders of whole of ophthalmological society in this region. Mohita has a point to make. She makes the point for women. So she's we all have to have something new to deliver, something new to inspire our followers. So if we are inspiring them, I think one can be a leader, and that has to be multifaceted. There has to be a good surgeon in me, good teacher in me, good mother in me, good sister in me, and you know, good clinician in me. My behavior, my bravery, my attitude towards my juniors, if they feel respected by me, they will respect me. So I think a leader needs to have multifaceted qualities, and a leader must be invested in the lives and the betterment of the followers. So, you know, I have to know that my mentor actually loves me and wants me to rise up. And if that is there, I think, you know, that one quality of love. I think love for others make you a very good leader. And all of you are like Samina, she's changing things for her passion of this, you know, you have to achieve standard. And Huma, she's fighting for all women in Pakistan. So I think, you know, and most of all, when you see someone like Abha madam or Namrata madam, who has made it up there, they're such big inspiration. So I think, you know, once you feel that there is a possibility, you aspire to be that, then you break your barrier of self-doubt, and somebody loves you enough to give you a hand. Then I think you can make it. And everybody, junior doctors who are listening to us, I think they know that all of us here would love them that way, and we have received love from our mentors that way. And if we women stick together, sky's the limit. Nothing can stop us.
Thank you so much. Wonderful. Very, very nice. Definitely, we agree with you. Leader is somebody who inspires. And there are so many inspirations all around that if we want to become a leader, We just have to look at those inspirations, and I'm sure those inspirations are ready to mentor also. And if we can find those good mentors, that's something which makes our path much easier. So that's a very good message for all the juniors here who are watching this. And yours and Dr. Ava Madam's mentor-mentee relation is something which we all envy and look up upon. And thank you, Dr. Ava ma'am, for being such a good mentor for her. So Samina, now over to you. So Samina, we have discussed a few times the difference between a manager and a leader. Especially when it's your own private practices. It's not that leadership just means being, secretary of some society or president of some society. Wherever you are working in your own circumstances, you can be a leader, whichever organization you are working in, whether it's your own or it's somebody else's. Samina will tell us about how to be a leader in your own organization and the difference between a leader and a manager.
Thank you, Dr. Mohita. I'm really enjoying my time today. So thank you so much for inviting me here. I just wanted to give you a brief introduction about myself for people who are sort of watching this session. Is that I started my practice in year 1995 single-handedly on a kinetic Honda. And I used to go to some 8 nursing homes with a pager. And now I have 3 eye centers in Bangalore. And all my centers are NABH accredited. I am an NABH assessor also. So I feel that is possible if you detach your role as a manager as compared to an owner. A manager thinks about the next day, how the function will happen today and tomorrow. And as an owner, as a leader, you think about what is happening, what's going to happen 5 years. So you have to decide that you have 24 hours in a day. And out of the 24 hours, suppose if you are dedicating 8 or 10 hours to your work or 6 or whatever number of hours, you have only those many minutes and those many seconds. Would you like to work in your zone of discomfort, your zone of comfort, your zone of excellence, or your zone of genius? In your zone of discomfort, as an ophthalmologist, if you're still doing the optometry work, then you are definitely in your zone of discomfort because somebody can do the same job in a better way. Zone of comfort, you're running an ophthalmology OPD, you can have somebody else to help you with that, a junior colleague. If you are an excellent surgeon and you're operating, but if there is something else what you can do, because if you're taking the stress of only operating and if you have enough and more work and you're only busy, who is going to look at the other aspects of running a practice? And what are the other aspects of running a practice in a country like India and a city like Bangalore? You need to look at public relations, marketing, and empanelments, accreditations. You need to look at lean management, and you need to look at growth. Only if you grow, you can sustain. Otherwise, you're going down. That's, you have to keep running to stay in the same place. So if you need to do that and you need to build a team, at present, I have a team of 31 eye care professionals and 6 eye doctors working with me, mostly all women. Okay, that is possible if you are ready to delegate, if you're ready to allow other people to do the job and make mistakes. Mistakes not in clinical work, but mistakes in area of administration, in many other things. Yeah, you would do it perfectly, but will you be able to do that if you want to grow? So you'll have to think about hiring a manager in your practice who is responsible for day-to-day work. In the Japanese language, it's known as looking at the gamba, at the workstation, walking around the gamba and seeing and reducing the muda. Mudas are the waste steps. So you need to definitely have a manager, somebody who will do the day-to-day work, and you as a leader should have the vision and the strategy to do better and how to grow. So I completely believe, and like what Dr. Mohita said, we need to learn. This year, I picked up a course at IIM Bangalore, which I'm encouraging Dr. Mohita also to take up. Of course, that is something we need to learn. Every single opportunity to learn and grow. Madhu ma'am is offering her leadership development program to all of us. We should maybe join that also. So learn and please be ready to delegate work. Mohita, I hope that answers the question. I would rather be an owner, not a manager.
Definitely, very, very important. And this is, I feel, important in every aspect of life, that we have to be an owner and not the manager. We have to come on the leadership role. So, just a few lines from my side. As a leader, we also always have to, as Meena said, I elaborate on that itself, that we should not see what we will do today. We should envision what will happen after 2 years or after 5 years. In our life also, I feel we should follow this principle. What do I want to see myself after 5 years as? And what is my long-term vision? Because only when we have a long-term vision, maybe 1 year, 2 years, 3 years, 5 years, not what I want to see myself as after 7 days. Because only when we have a long-term vision, we are able to think in a broader fashion, and we are able to make things happen as they should. And coming back to, you asked me about networking, just quickly about networking, I feel networking is a very, very important aspect for anybody to become a leader, or even if you don't want to be a leader, for success in your life, networking is important. Talking about my practice, which you asked, something I realized as I started practice and as I started doing, that one of the most important aspects of running a successful practice was networking. And hence, I tried to be multifaceted, just like Dr. Nusrat said, that I now network with all possible people in and around my area. And it is very important that when you network, so many avenues open up for you, that whatever you want happens. And as a leader, it should be that way, that if you want something to happen, it should happen. Rather, you should be in a position to help others. And this is possible only when you have a good network. And as if we come to our women's organizations, again, networking is something which helped WAS also grow. When we talk about Women Ophthalmologists Society of India, because we networked all over the country, and then we started networking with other organizations all over the world, and that's how growth happens. So for anything or everything in your life, networking is important, because it connects you to people. When it connects you to people, opportunities automatically open up, because people are willing to help you, and that is what you have to realize. Only you have to come out of your comfort zone and go out, and that is when you become when you start assuming those leadership positions and roles. So anybody,
Dr. Mohita, you should also share
I
about your role in the IMA. You know, you have, besides ophthalmology, you have a prominent role in the IMA in Noida, and I think I would want to share something about that.
I realized that not just IMA, I realized that when you are working in an area, you need to be networking with everybody. So whether it was IMA or it was social, there are several social organizations which you're not even aware about in your area. I found there was an organization working for villages, there was an organization working for apartments, there was an organization which was working for industry, organization for education, and I connected with all of them. When I connected with all of them, I found that automatically it changed the whole scenario for me, not just in terms of patient load, but in terms of, as you were talking about, permissions, etc. Now I just have to, now anything that I want should happen is just a call away. I have to make a call and it happens. So all this happens when you develop connections, and developing connections is very, very important. I'm sure Dr. Nusrat agrees with me.
One point I want to add finally here, that we have talked a lot about leadership, vision, mission. We have talked everything. But this entire leadership, any organization, society, everything stands on one thing, the spine. And the spine is value system. Therefore, all of us who are leaders there, we are doing it unknowingly. But if we bring out that value system in the forefront in the organization, where every person is on the same wicket, every person understands that this is my value system, that I got to be honest, I got to have an integrity, I got to be supportive, I have to trust people. So if this value system starts right from the beginning, then the vision, mission carrying becomes relatively so much easier for people, you know. And this gender ratio, of course, we had 1% when I started. Now we have 72% gender.
Wonderful. Very, very nice.
Thank you. Men are feeling
very, very nice.
Mohita says that they're on the back benches. Just wonderful listening to each one of you. Honestly, it's been such a learning experience for me.
Thank you.
So Dr. Amrita, are we over with the time, or
I am just,
Yes,
I
madam.
like to say just few words.
Yes, madam.
Thank you, Dr. Madhu. I didn't tell full name as because just immediate session, we were in community ophthalmology session. In that session, she has given a very keynote speech, excellent speech. So thank you so much. And now she has gave a hard views on leadership development program, and I am very much happy to know that she has a leadership development program course.
It's
So
collaboration. I'm one of the instructors in the collaborative program. It's not my own program.
okay, still then you are
I'm the
very,
mentor in one of
very
the programs.
nice job. So now I would like to congratulate my daughter, Dr. Mili, Dr. Nuzhat. Really, they are just my like daughter, as because I have seen them very early life, and Dr. Nuzhat, she was at that time only 2 to 3 years old girl when she lost her father. What I said, he is a patriot, during Liberation War. I have seen him in my younger age, as because our mother was my teacher when I was in school, and I am her teacher. This is a very good relation between us. So, and I knew her father from then onwards, as because I was in my school, that is Mirzapur Bharateshwari Homes. I don't know whether you know that it is a really small place, but it has Rai Bahadur Ranoda Prasad Shaha. He made that in larger way, the Kumundini Hospital, the Bharateshwari Home School, English medium school, and also the other thing, his creature, his creation. And during Liberation War happened, he has just taken away and nobody have seen his body. Same our Nuzhat, our sir, that has happened. But during my childhood, I have seen him. He was working in Kumudini Hospital at that time. That is why both father and mother are very close to me. And always I am feeling that when I was a professor of ophthalmology in Mymensingh Medical College, Nuzhat was a undergraduate student at that time. And from then onwards, again, it has established. And Mili, she is my resident, and she was always talking about her mother, as because she also lost her mother very earlier time. So she feels very much, and both are very close to me. But I am really satisfied. I am just proud feelings that they are telling such a way. They are now the leader. They are now the leader. Actually, I feel very proud. And also not only Nuzhat and Mili, but also Huma, that is also another experience. She was in Asia Pacific Academy of Ophthalmology, in Women's in Ophthalmology, our committee meeting. And after that, going back her home, she mailed me, ma'am, I was there. Perhaps you can remember me. Yes, I remember her. So beautiful lady, how I can forget her. So lovely. And she gave here the leadership. I have learned a lot from Huma, from Nuzhat, from Mili, from Samina, and from Mohita. Mohita is my inspiration. I always talk to her. Very minimum time that I give message, as because I love to talk, as because everybody, Mili, Nuzhat, they are thinking that why madam didn't give the message. We are so busy nowadays, but that is my attraction. I can hear it, I can feel it, I can hear the voice that attract my heart, and that is very, very positive. I get inspiration to work, as because they are my child and I am growing up becoming old nowadays, but still I have a very heart is my very new one, just like heart transplant from a new child like that. So I am today very happy. Professor Namrata, really, she's my inspiration. I always try to do something for her in the broader platform where she can do much more better thing for us. And Mohita is another, she is the burning example nowadays. She will do so good thing for us, everybody. And with this few words, Madhu Madam, thank you so very much. Thank you all. Thank you, Millie. Millie is very busy with her son and daughter-in-law. I said no in-law, only daughter. That will be better as because she has no daughter. So this is the way we are now a very small family, whole world, whole Sark family now in one home. So thank you so very much. Thank you.
Thank you,
Thank
ma'am.
you, madam. Thank you, madam.
Thank you, ma'am.
So much.
Thank you, madam.
Thank you so much, everybody. So nice.
Thank you. Thank you so much. Thank you, ma'am, for always helping everywhere. Thanks a ton. You do it in a very subtle manner. I don't even come to know about it, but I know that you are there behind. Thank you so much.
Thank you.
So thank you everybody for this session. I think we had great discussions and everybody here is a great inspiration. And Dr. Ava madam, Dr. Madhu ma'am, and Dr. Namrata, you as seniors are an inspiration for all of us. And I'm sure all of the whole group here will be pull up a lot more other ladies and create more leaders, and we would have a bigger group next time.
Absolutely. Absolutely.
Thank you, everyone.
Thank you so much.
Thank you.
Once again, a huge gratitude to everybody for this event. And before we move ahead or before we close this session, can we quickly take a group photograph, please?
Yes, please. So everybody smile.
Wonderful.
Thank you.
Thanks.
Thank you. Thank you.
Thank you. Thank you so
Thank
much.
you.
I'm sure
Please
Dr.
share the
Namrata and
picture.
Dr. Mohita will create more opportunities for us to meet again like this.
Yes.
Absolutely.
Please share
Looking
the,
forward to it.
please
I
share
am
the picture
thankful
in
to
the
the entire group. At such a short notice, it was done, and only we can do it. Men need more.
Madam,
Yes.
you all are inspiration, and we are always here for all of us.
Only
Uma,
women can do
Uma,
it.
good luck.
Men need a lot more time.
Thank you. Really
Uma,
need
good luck
you
with
so
your
much.
election.
Thank you.
Let us
Yeah,
know.
yeah. The
All the
first
best,
time
Uma.
around. Yeah. Thank
Best
you.
wishes
Thank
for
you.
Huma
Thank
Saigal.
you. Thank you so much.
We will
God
be-
bless.
Madhu
Oh,
madam.
I'm going to let you know. I will definitely
Yes.
let you know on the 22nd of
Yes.
January.
Okay.
Okay.
Will do.
Amma
Bye-bye.
madam.
Okay,
Bye,
see you
madam.
all again. Bye. Bye, madam.
Bye-bye.
So see you all in the valedictory function in Hall A.
Bye, Madhu
Okay.
madam.
Bye,
Bye.
bye, bye, bye.
Bye-bye.
Bye.
Bye, everybody.
Bye,
Nizar.
Nizar.
Bye,
Bye.
bye.
Nizar.
Bye, everyone.
Bye.
Bye bye, ma'am.
Bye.